अच्छा मैं बोलता हूँ।
Let's bow to the divine light, seek the blessings, and pray for the success of this event. Ma'am, please. One tree can start a forest, one candle can wipe out darkness, one hand can lift a soul, one word can frame a goal. One leader can make the difference, and she is that one today. Let me take the privilege to invite a strong, determined, focused, and goal-oriented leader, the storehouse of knowledge, and the lifeline of this conference, the organizing chairperson, SHKM, and Professor and Head Pathology, Dr. Pooja Ma'am, to kindly deliver the welcome address. A huge round of applause, please.
Thank you, Dr. Bhavna. Good morning, Honorable Chief Guest, respected Director, sir, respected dignitaries on dais, distinguished guests, esteemed colleagues, and dear participants. On behalf of organizing team, I, Dr. Pooja, wholeheartedly welcome you all to this second annual conference of Regional Society of Pathologists, IAPM Haryana chapter, and 14th HAPPCON of Association of Practicing Pathologists, Haryana. This conference is a remarkable platform that has brought minds from nooks and corners under one roof and allowed the exchange of ideas and sharing of knowledge. I thank Chairperson IAPM Haryana chapter, respected Dr. Sunita Singh ma'am, to honor us with this opportunity to organize and host this conference. I could accept the honor of hosting this year's conference at SHKM GMC Nalha during last year's GBM only because of the faith and trust I had in capable faculty of my department and support from the institute. This gathering today is not just an event, it's a testament to our collective commitment. And I feel proud to say that it's because of my team members and collaboration with the members of APP, especially Dr. Santosh, Dr. Prashant, Indu Jyoti ma'am, our young dynamic members like Dr. Yudhvir, Dr. Saurabh, that this event has seen the light of this day. Today we have eminent speakers from the most renowned institutes of our country at this place in Mewat, which nobody, I think, even knows. And their insights and expertise is undoubtedly going to enrich each one of us. I would again like to extend a warm welcome to all the dignitaries, guests, and participants whose presence has added immense value to this gathering. I, along with the entire organizing team, hope that this conference provides you with the meaningful insights and new learning experiences. Please enjoy and add to the success of this conference. Thank you very much.
Thank you, ma'am, for your kind words. A leader is the one who knows the way, goes the way, and shows the way. A noble endeavor of Knowledge Summit, such as this conference, needs the support, guidance, blessings of diverse dignitaries. We are really blessed to have your endless care, support, and motivation throughout. May I request our chief guest, a great visionary, highly committed and determined, extremely disciplined and punctual man, our Honorable Director, sir, to please inspire and motivate the young minds. Thank you, sir.
Good morning. Distinguished guests, esteemed faculty members, and respected pathologists, and my dear delegates. It is an immense honor and privilege to stand before you today on the occasion of second annual conference of the Regional Society of Pathologists, that is IAPM, Haryana chapter, and the 14th HAPPCON of the Association of Practicing Pathologists, Haryana, and that is hosted by the Department of Pathology, SHKM, Saeed Hassan Khan Mewati, Government Medical College, Nalhar. I extend my heartfelt gratitude to all of you for being part of the prestigious event. Gatherings like these are the cornerstone of scientific progress. And I am truly delighted to support and witness such an inspiring gathering of brilliant minds. This conference serves as a platform where diverse ideas converge, knowledge is shared, and collaborations are forged. It is an opportunity to reflect on where we stand today and think about the transformative advancements that lie ahead. For our young pathologists, this is an invaluable moment to learn from and interact with some of the most esteemed faculty members, experts in the field. The guidance and insight they gain here will definitely shape the future of pathology. I take this opportunity to appreciate the Department of Pathology for their unwavering dedication and meticulous efforts in organizing this event. Their commitment to excellence has ensured that this conference stands as a testament to the spirit of learning, collaboration, and progress. To all our delegates, I encourage you to immerse yourself in the discussions, forge meaningful connections, and make the most of this gathering. I am certain that each of you will leave with new viewpoint of view, a wealth of knowledge, and valued memories of this event. Let us together strengthen the foundation of pathology while accepting the innovations that will definitely define its future. Thank you for being the part of this journey, and I wish you all a successful and enriching conference. And wish all of you a happy meeting, eating and chatting. हम कभी भी कॉन्फ्रेंस में जाते थे तो ये तीन चीज अक्सर कहते थे कि मिलना और खाना पीना और बहुत सारे डिस्कशन हम इसमें आपको करें. थैंक यू ऑल, थैंक यू फॉर बीइंग हियर, थैंक यू वेरी मच.
Thank you, sir, for your motivating words. We are really happy to hear that. Gurur Brahma, Gurur Vishnu, Gurur Devo Maheshwara, Gurur Sakshat Parabrahm, Tasmai Shri Guruve Namah. I feel honored to invite a dedicated guru who have been an inspiration for many young pathologists, including myself. She is a perfect example of work-life balance, and the way she handles challenges with ease are truly admirable. She is an ever-smiling, ever-charming, and mesmerizing scholar. Let me call the main driving force behind the conference, Dr. Sunita Singh ma'am, Senior Professor and Head PGIMS Rohtak, and Chairperson, Regional Society of Pathologists, IAPM Haryana Chapter, to please guide us. Thank you, ma'am.
Thank you, Bhavna. Good morning to all the dignitaries sitting on the dais, and my teachers sitting here, my colleagues and my students. I'm really happy standing here, and the words Bhavna has used, I think we have learned from our teachers, whatever we have learned. And this society which we created last year, this is almost 1 year completed of Regional Society of IAPM, Haryana. The spade work was done by Dr. Rajiv Sen. And from there onwards, we carried on to this, and we became successful in creating this by the help of our IAPM chapter office bearers, Dr. Ranjan and Dr. I must thank Dr. Harinder also. They supported us a lot, and Dr. Kim also from PGI Chandigarh to create this chapter. And this was a mandatory thing, because now initially it was just a one medical college in the whole of Haryana. Now we have 10-15 medical colleges, so many faculty members, students, teachers. I think we needed some platform where we can stand, meet, discuss and know each other. So with that we made an effort, and we could make this, and it was really initial years, so we have all those teething problems also, many challenges also we are facing, but I must thank that the moment we created it and we wanted to have the conference, first Dr. Mukta agreed to it, and then immediately Dr. Pooja also agreed to conduct, because it was difficult initially to have people to conduct these conferences. So I'm thankful to Mukta also and to Pooja also, and from here onwards I think we will carry this forward. For that I request all the medical colleges and their heads and all to have more members and to participate more in the conference, in such meetings, and to also conduct some in between mid-year sessions also, other than the national and this annual conference. I am really thankful to all of you, and I am just the face of this, but the real work is usually done by Dr. Mukta, Dr. Promil, Yudhveer. They are the ones who does more of the work. I am just the face, so I am thankful to them also. And thank you, the Department of Pathology, SHKM, and also many thanks to APP. Without APP, I think we cannot conduct such conferences, because you know, being government medical college, not much funding come to us. So your support is really needed to carry this work forward. Thank you so much. Thank you.
Thank you, ma'am, for your guidance, unwavering support and motivation. Thank you so much, ma'am. Coming together is a beginning, staying together is a progress, and working together is success. Let me take the pleasure to invite a key person involved throughout in designing this conference and taking this conference to a state that it has seen the reality of the day. I would like to call Dr. Santosh Kumar, a really sincere and humble man who even after a sudden demise in the family managed to be involved in every important task related to the conference. Looking forward to hear from you, sir. Thank you, sir. Please.
Thank you, Dr. Bhavana ma'am. A very good morning to all our distinguished speakers, respected chairpersons, esteemed dignitaries, delegates, and dear friends. As the President of APP Haryana, it is both an honor and privilege to welcome you all to this 14th Annual Conference of Association of Practicing Pathologists, HAPPCON 24. This event, jointly organized with the Regional Society of Pathologists, IAPM Haryana chapter, and the Department of Pathology, SHKM Government Medical College, NU, brings together all the brightest minds in our field. It is a celebration of knowledge, collaboration, and our shared commitment to excellence in pathology. This annual gathering is a unique opportunity for all of us to interact with each other, share our experiences, and learn about recent advances in pathology. With each passing year, our field continues to evolve, incorporating new methodologies, tools, and technologies that enhance our diagnostic precision and efficiency. One of the key highlights of this year's discussion is the growing role of artificial intelligence in pathology. Artificial intelligence has already started transforming how we approach diagnostics, from automating repetitive tasks like slide scanning and image analysis to aiding in complex tasks like predicting patient outcomes and identifying subtle patterns that might elude the human eye. These tools are not here to replace us, but to empower us, enabling us to focus more on fast and accurate decision-making and prompt patient care. Alongside AI, the emphasis on good laboratory practices cannot be ignored. Adherence to GLP ensures accuracy, reliability, and reproducibility in all aspects of laboratory work. From standardized sample handling and quality control to ensuring biosafety and ethical compliance, GLP forms the backbone of our profession. As pathologists, we bear the immense responsibility of providing timely and accurate diagnosis that forms the backbone of patient management. Integrating AI into well-established GLP framework can further strengthen our practices and elevate the standard of pathology. This conference offers us the chances to dive deep into these transformative ideas and explore their real-world applications through interactive sessions, keynote addresses, and hands-on workshops. I urge each one of you to make the most of this opportunity to ask questions, exchange ideas, and build connections that will not only enhance our individual practices, but also enrich the pathology community as a whole. As we gather in this beautiful and scenic campus of SHKM Government Medical College, NU, let us take inspiration from this environment to foster collaboration and innovation. Together, we can shape the future of pathology, ensuring it continues to evolve as a dynamic and impactful discipline. To conclude, I once again welcome you all to this HAPPCON conference. Let us make it a grand success, making us all wiser, inspired, and better prepared to tackle all the challenges and opportunities ahead. My special thanks to our HMC observer, Dr. Praveen Garg sir, and Director of Medical College, NU, Dr. Mukesh Kumar sir. Thank you, and wish you all a fruitful and memorable conference. Thanks a lot.
Thank you, sir, for your continuous support to us. Your suggestions, your guidance really meant a lot. Thank you, sir. Serving the society is the foremost principle on his agenda. Our honored guest and HMC observer is a retired Director General, Health Services, Haryana, with more than 35 years of total experience. His services has made a difference to the community for the greater good. Apart from other noteworthy laurels, it's worth mentioning that sir has done more than 35 blood donations. Can we have a huge round of applause, please? And have holded many reputed positions in Indian Medical Association and Government of Haryana. We wholeheartedly welcome you, sir, and over to you, sir.
morning, everybody. It's a pleasure and honor to be here today. The very eminent honored doctors sitting on the dais, Dr. Mukesh ji, Dr. Snita ji, Dr. Pooja ji, Dr. Indu ji, Dr. Santosh, Dr. Prashant, Dr. Harinder, Dr. Sheetal. I have come from the council just to boost you up, not as a VIP or something like that. Idea is to come and see the credit hour which the council has given, whether they are justifiable or not. And seeing everything outside, inside, lectures, everything, I hereby justify the credit hour allotted to the conference. Secondly, I want to say that the conference of pathology which I have attended was in the year 17, I think, when I was Director General at Mulana. At that time, it was a very wonderful conference. After that, I attended many conferences because due to the involvement of the Association of Practicing Pathologists, it is growing like anything, and it should grow also, because the need of the hour is to promote the pathologists, because everything depends upon the pathologist. जैसे फिल्म होती है ना, एक हीरो होता है और पीछे जो लोग होते हैं उनका नाम नहीं आता। मैं तो यही कहूँगा कि जो हमारा मेडिकल का सिस्टम चल रहा है, इसके पीछे जो है फोर्स वो पैथोलॉजी की है। सारी रिपोर्ट्स इतनी बढ़िया बढ़िया आ रही हैं, उसी के ऊपर सारे सर्जन्स फिजिशियंस काम कर रहे हैं, पर उनका नाम नहीं आता आगे। इट शुड कम। तो मैं डॉक्टर साहब से बात कर रहा था, जैसे पहले जो एमडी पैथोलॉजी डिग्री होती थी, उसके बाद वो एलिजिबल होते थे डीएम एंडोक्राइनोलॉजी लिए और उसके लिए हेमेटोलॉजी के लिए। आजकल इन्होंने बंद कर दी है, तो आप इनको एक लेटर भिजवाओ, मैं भी परस्यू करूँगा। हमारे काफ़ी लोग हैं एनएमसी में, तो ये होना चाहिए, क्योंकि जो पैथोलॉजी का रोल है ना, बहुत बड़ा रोल है हमारी डॉक्टरी लाइन में। इसको लोग समझ नहीं रहे, इनके ऊपर ही सारा ढांचा इनके ऊपर ही है, इनकी इतनी बढ़िया रिपोर्टिंग सारा कुछ। तो मैं यही कहूँगा, ज़्यादा नहीं संभालूंगा आपका, कि ये जो कॉन्फ्रेंस है बहुत बढ़िया कॉन्फ्रेंस है, आपने मेरे को बुलाया, थैंक यू वेरी मच।
Thank you so much, sir. It's rare to see someone work with such a passion and integrity. Thank you so much, sir. Days are not lost when memories are created. May I request the dignitaries to kindly proceed with the unveiling ceremony of the souvenir. This keepsake is more than just a memento. It reflects the sheer journey, the dedication of everyone involved, the lasting impact of the moments we have celebrated together. May I request the dignitaries to kindly do the honor, please. Can we have a huge round of applause, please? We are humbled and honored to have such esteemed guests to release and such elite gathering to witness the unveiling ceremony. A huge round of applause once again, please. Thank you. Moving ahead further and creating few more unforgettable memories with the dignitaries. May I request Dr. Pooja ma'am to kindly present a memento as a token of thanks to Director Sir. Thank you, sir. Thank you, ma'am. May I request Director Sir to please honor and thanks Dr. Parveen Garg sir with a small memento. I would like to again request Director Sir to please present a memorial token to Dr. Sunita Singh ma'am. I would like to request Dr. Pooja ma'am. Thank you, sir. Thank you, sir. You may please proceed for the chair. I would like to request Pooja ma'am to give away a token of regard and thanks to Nayak ma'am, please. I again request ma'am to present a small gift of honor to Dr. Harendra sir. May I now request Pooja ma'am to deliver a memorial keepsake to Dr. Indu Jyoti ma'am and to Dr. Santosh Kumar sir as well. The smiles will be even bigger if we have some claps, please. Thank you. Next, I request ma'am to present a memorable token to our big support, Dr. Prashant sir. Dr. Santosh Kumar. Yeah, please. Ma'am, please stay here only. Please present a memento to Dr. Prashant, please. Now I would like to request Dr. Indu Jyoti ma'am to please present a memorable memento to Dr. Pooja ma'am. Again, I request Indu Jyoti ma'am to please present a memento to Dr. Sheetal ma'am, please. With this, I would like to thank the esteemed dignitaries for gracing the event and being part of this ceremony. I request you all to please take the respected chairs in the hall. The conference is not only an opportunity to hear from experts or share knowledge, but it's a platform to meet, greet, regard, and honor our mentors, our senior professionals and educators who have devoted to the most meaningful and worthwhile task of teaching and guiding. It's time to honor the highly dedicated stalwarts in the pathology. यस्य वाणी सुनिर्मला यस्य दृष्टि दयापरा सर्वे ते पूजनीयाः देवतुल्या इह स्मृता. I am absolutely thrilled to invite our respected Dr. Uma Singh ma'am, who is a dedicated and diligent pathologist, always found immersed watching slides under the microscope with full interest and passion. And what I love the most about ma'am is she is not just a hard-working lady, but the way she carries the warmth and calmness and spread it to others. Okay. I request The senior members from the APP team, Dr. Rajiv Singh sir, Dr. Gajendra sir, Dr. Santosh Kumar sir, Dr. Prashant sir,
Dr. Manish Wadhwa, Dr. B.C. Gupta, to please come on the stage and
do the honors, sir,
do the
please.
honors.
Kindly proceed to the stage. We welcome you, sir. Sir,
कहाँ है वो? लेके आ, लेके आ.
Uma Singh ma'am have trained more than 50 postgraduate students and have received many prestigious awards and is still enthusiastically working as consultant in Rohtak. We are really grateful for your contributions which will echo for generations. Your presence means a lot, ma'am, and we really wish to honor you at this point of time. I request Prashant sir, Santosh sir, and Rajiv Singh sir to please do the honor.
Happiness and peace and everything, and which gives
You
pleasure in the life. And सबसे ज़्यादा pleasure तो उसमें मिलता है जो हमने पढ़ा है और उसको हम पढ़ते जा रहे हैं और उस पर हम काम कर रहे हैं. बाकी चीज़ें मैंने देखा कि डॉक्टर के लिए या कोई भी लाइन हो, अब तो हम पैथोलॉजिस्ट है इसलिए पैथोलॉजी की बोल रही हूँ, सिवाय पैथोलॉजी की कोई और चीज़ अच्छी नहीं लगती इस उम्र में. क्या बताएं. तो इसलिए अब ये शौक हमारा चलता रहे, यही दुआ है. लेकिन कई बार रुकना पड़ता है, दूसरी हॉबीज़ को भी डेवलप कर ले, वो सही है. और जीवन का नाम चलते रहना ही है, और वही होए भगवान करे सबके लिए और हैप्पीनेस के साथ.
Thank you, ma'am, and thanks for being a motherly figure for all of us. I know nobody wants to be elder enough, but we really wish to pay regards, ma'am. Thank you. Indu Jyoti, ma'am, please join us. Next, we wish to honor Dr. Jagpal Singh Nalwa sir with deep expertise and skills, tireless dedication, and unwavering integrity. Sir has set a benchmark of excellence that has inspired many of us. So, Dr. Jagpal Singh, sir. Since Dr. Jagpal Singh Nalwa sir is not around, may I request someone to please come on his behalf and do the honor. Sir, please.
Dr. Sandeep Kalra, please.
I request Dr. Sandeep Kalra sir, please come on the stage. Yeah. For Dr. Nalwa, we are going to hand over the things to Dr. Sandeep Kalra. And for Dr. B.L. Goyal, who is also more than 70 years old, so we are going to hand over those things to Dr. B.C. Gupta.
With this, I again thank our guiding lights, Dr. Uma Singh ma'am, Dr. JPS Nalwa sir, and Dr. BL Goyal sir. Thank you for being a beacon of excellence and inspiration. I again thank all the APP members, the seniors, for gracing this occasion. Before concluding this ceremony, we would like to pay a tribute to the memories of late Dr. Anita Narula ma'am. She was an extraordinary individual whose compassion and brilliance illuminated every life she touched. As a devoted doctor, she worked tirelessly and along with her husband, Dr. Arun Narula, established famous diagnostic centers in Rohtak. Dr. Anita departed for her heavenly abode on 29 September 2024. Let's honor the life and legacy of ma'am, cherish the moments she's shared with us, and hold her memory close, knowing they will forever be a part of us. Though neither words nor the silence can capture all what a person means to the close ones, but still, let's carry her love in our heart as a testament to a life well lived, and let's stay in a silence for a minute. May I request everyone to please stand on your seats. And let's keep a silence for a minute. With that, let's conclude this ceremony. In the end, I would like to extend a heartfelt thanks to the Chief Guest Sir, Dr. Mukesh Kumar, all the dignitaries, delegates, and students for being part of this elite event. Please refuel yourself with a cup of tea and a small chit-chat with your friends and colleagues, but please be back soon. We are going to start with the upcoming sessions. Thank you all. Thank you.
Mitotic count is more than 5 per 2 mm square and necrosis there, it is called TC. But if the differentiation is not there and more than 3 mitosis is there per 2 mm square or necrosis, is called poorly differentiated high-grade carcinoma. This is a differentiated high-grade carcinoma. On A, it is the follicular high-grade carcinoma. You can see the necrosis and mitosis, and the other side, B, is the high-grade papillary carcinoma with mitotic activity. Now, anaplastic thyroid carcinoma by definition is an undifferentiated tumor, may have focal features of thyroid follicular differentiation or a pre-existing differentiated thyroid carcinoma, but majority it is made up of undifferentiated cells. Primary squamous cell carcinoma of thyroid is now considered as a histological variant of ATC and not a standalone entity. And BRAF detection by immunostaining or genotype should be performed in such cases because we have a targeted therapy. Though it is anaplastic, but still BRAF detection by surrogate marker should be done so that we can give the targeted therapy. So this is a pure BRAF mutant ATC detected by VE1 immunostaining. You can see it is strongly positive, and on this side you can see it is undifferentiated tumor. Now from C cell we all know arises the medullary carcinoma thyroid. It is mainly has RET and ROS alterations. There is no benign counterpart of this, and it is graded as low grade and high grade. High-grade medullary carcinoma thyroid is based on mitotic count and tumor necrosis. High grade should have mitotic count more than or equal to 5 per 2 mm square. There should be tumor necrosis and Ki67 proliferation index. As I previously told, it is not used in follicular carcinomas, but for medullary, Ki67 proliferation index is considered, which should be more than 5%. High grade, they constitute this. And the important is that grading of medullary carcinoma is reserved only for surgical specimens. It should not be done on FNAC or cytology. This is a picture of high-grade MTC medullary carcinoma. You can see there is a tumor comedo-type tumor necrosis which is present in, so it is a high-grade. This is to show you how we do the mitosis count. Now it is done in 2 mm square, and it is almost equivalent to the 10 high power field which we used to do previously. Now grading system which has been introduced, I am just revising it. That we follicular type neoplasm, we grade it as poorly differentiated thyroid carcinoma depending upon the mitosis and the tumor necrosis, and differentiated high grade thyroid carcinomas and medullary carcinoma into high grade and low grade depending upon the mitosis and necrosis. Now these are the salivary gland type of carcinomas, which includes the mucoepidermoid. I think I have 10 minutes more. And secretory carcinomas, previously they were known as memory analog secretory carcinomas. They have a specific gene fusions in them. Now the new entity which I told you has been added is a category of thyroid tumors of uncertain histogenesis. One is sclerosing mucoepidermoid carcinoma with eosinophilia, and another is cribriform morula thyroid cancer. But additional studies are needed to further define these. This cribriform morula thyroid carcinoma, previously it was a variant of, or it was a subtype of PTC, but they do not have a BRAF mutation. No case has been seen with BRAF mutation, so they have moved it out from the papillary carcinoma thyroid, and it is now called a tumor of uncertain histogenesis. As I told you, thyroblastomoma has been introduced as an entity for teratomas and carcinosarcomas with specific mutations, and extranodal marginal zone lymphoma is now a preferred terminology for mild lymphomas of the thyroid. Molecular immunohistochemistry should be applied, but it should be very clear that we have proper reagents, stringent validation protocols, and positive controls are used, and we have only surrogate markers to define these entities, which include VE1, PAN-TRK, RAS, a clone of SP174, ALK, P10 and beta-catenin, and a theranostic marker PDL1. Now this is the molecular classification. I'll just take 2 minutes to tell this. That once we have a follicular cell-derived neoplasm, we see whether it has got a BRAF mutation or not. If it has got a BRAF mutation, then we see whether it has got a differentiation or not. If it is well differentiated, you can see the differentiation, all characters of a carcinoma, then we call it as PTC. If it is no differentiation is not seen of papillary, we call it as poorly differentiated thyroid. Some differentiation is seen but not much, then we call it as poorly differentiated thyroid carcinoma. If there is no differentiation, we call it as anaplastic carcinoma. But if in PTC we have high grade features, what were they? They were mitosis and necrosis. In a well differentiated tumor, we have mitosis and necrosis, then we will call it as differentiated high grade thyroid carcinoma. So, and if BRAF mutation is not seen, then we look for other multi-gene tests in which we do the RAS-like mutations and other non-RAS-like mutations. Now, if RAS-like mutation is present and we see the tumor is encapsulated, circumscribed with follicular pattern, then we look for PTC features, that papillary carcinoma thyroid features are there or not. If they are present, then we see whether capsular invasion is there or not. If capsular invasion is there, we call it as invasive encapsulated variant of the follicular variant of the papillary thyroid carcinoma. But if invasion is questionable, we call it as well differentiated carcinoma with undetermined malignant potential. And if there is no invasion, we call it as NIFTP, that is non-invasive follicular thyroid carcinoma with papillary-like features. But if RAS mutation is there and no PTC-like nuclei, then we look for invasion. If invasion is there, we call it definitely a malignant follicular carcinoma. If there is no questionable invasion, same as FT, UMP, or if no invasion is there, we call it benign or follicular adenoma. In malignant, we see for differentiation. If there is no differentiation, then we call it as poorly or anaplastic. And if differentiation can be seen, like follicular follicles are present or oncocytic cells are present, then we call it as differentiated high-grade follicular carcinoma. So that is how, looking into this, so two important molecular alterations are very important to see. Even the papillary features are present or not present, we look for RAS mutation and BRAF mutation in thyroid tumors. So this is the decision tree. I think I don't have time, so I will not go into this because it will take almost 10 minutes to explain that. Basically, it is the same as I have told you, that you have to look for the mutation on nuclei and then encapsulation, whether it is there, invasion is there or not, and then you derive. So that clinical outcome is dependent on this tree, that if it is favorable in case of follicular, papillary, or oncocytic carcinoma, it is intermediate for differentiated high-grade thyroid carcinoma or poorly differentiated thyroid carcinoma, and it is poor for anaplastic carcinoma. So this is how we go for the, even if molecular is not there, by this diagram, we can, by the following this algorithm, we can reach whether what type of a carcinoma it is on the thyroid carcinoma. So to conclude, thyroid tumors are now classified based on the cell of origin and on the molecular profile. The concept of low-risk neoplasms and histology-based grading system help guide the personalized therapeutic decision for the patients. And finally, these changes are continuing, and we may get the new updates in another 3 years. Thank you so much.
I would like to thank Dr. Sunita Singh ma'am for such a thorough and wonderful session. Now, I would like to request our respected chairpersons to please present a token of appreciation to me.
A big thunder we want. A big thunder from the students at least. Yeah, please. Thank you.
Thank you so much, ma'am. Now, I would like to invite Dr. Pooja, Dean Academics, Professor and Head, Department of Pathology, SHKM Noon, to please come on stage and present mementos to our respected chairpersons. May I please call Dr. Gajinder Yadav, sir. A huge round of applause, please. Dr. Santosh Kumar, sir. And Dr. Rahul Sadarkar, sir.
Thank you all the chairs and Pooja ma'am for honoring us. Myself, Dr. Bhavna, and I really extend a very warm welcome to all sitting in the hall, all the guests, all the delegates, all the students. You are most welcome to the conference which is going to happen here. So to glorify the next session, may I invite Dr. Uma Singh ma'am, consultant Vidya Pathology Center, Rohtak, Dr. Indu Jyoti Sharma ma'am, consultant pathologist RD Path Lab, Gurugram, and Dr. Mukta Pujani ma'am, professor and head pathology, ESIC Medical College and Hospital, Faridabad, to please grace the chairs. Lymphoma diagnosis and categorization is a difficult area, not only for postgraduates, but for relatively experienced pathologists as well. The evolution of lymphoma classification has occurred at a varying pace over the last century and a half, and I hope it will continue to do so as the world continues to turn. But luckily, we do have a single well-accepted WHO classification and blue book describing how to use it. But we recognize that each time there is a new edition, and we have to be very well versed with that. To cover few updates in the recent WHO on the aggressive B-cell lymphomas, let me call our next speaker, Dr. Sumit Gujral, the most active person in the hall who has already reached the dais. He is Professor, Tata Memorial Center, Mumbai. He is a leading groundbreaking researcher and a renowned figure in pathology world who has incredible insights, expertise, and just a whole lot of heart and passion for lymphomas. So over to the chairpersons for a small introduction of Sir, though he doesn't need much, but still.
Baby in pathology, then he grew up to become a professor in Tata Memorial and has had a long experience of about 30 years in the oncology and general histopathology also. And I can't read his curriculum vitae in detail, but I know that he has got lots of applause and he has got lots of importance in his field, and we look forward for his well-prepared lecture. And lymphomas are real problems, and he will do justice to this. Which I've got it now. Okay, I can read out now his experiences. Yes, oncopathology and hematopathology, and he's got more than 170 publications and national and international journals, and his academic qualifications are really very good. MBBS from PJMS Rohtak, our place, and MD Pathology from AIMS, New Delhi. And he has worked he has had an editorial board. He is in cytometry, he is part B, clinical cytometry, Indian Journal of Cancer, Indian Journal of Pathology and Microbiology, Indian Journal of Hematology and Blood Transfusion, and what more is needed? Just his speech now, this lecture. Thank you.
IT people to be little quick in displaying the PowerPoints. They are required.
That's fine. Thank you very much, madam, for kind words, and thank you very much for inviting me here to Haryana. It's a love coming to my state, and it's a privilege. So I will be talking about aggressive B-cell lymphomas over next 45 minutes to 1 hour. I think 45 minutes I'll take, then we have some time for questions. Briefly, to give you an overview of blood cancers in Tata Hospital. When you say blood cancer, it means both leukemias and lymphomas. Both are blood cancers. Lymphomas are in the tissues, solid tissues. Leukemias are in the liquid tissues. So we have the commonest cancers in Tata Hospital in India are from head and neck because of tobacco, followed by gynae and breast. Then comes GI, then comes thoracic and hematolymphoid. Then comes soft tissues and brain. They are a little less common. So 8% of all cancers in Tata Hospital, so I could say that in India, are hematolymphoid. Neoplasms, lymphomas 4% and leukemias 4%. And if you study lymphomas, 90%, 85 to 90% of them, this pointer won't work here, 85 to 90% are non-Hodgkin's lymphomas and 10 to 15% are Hodgkin's. So this is important for postgraduates. Lymphomas, 90% are non-Hodgkin's, 10 to 15% are Hodgkin's. And if you see the non-Hodgkin's are B cell, T cell, NK cell, dendritic cell, histiocytic. And Hodgkin's are always B cell type. So Hodgkin should have been a B cell non-Hodgkin's lymphoma. That's a question. Why we have kept another category for Hodgkin's? We could have easily put this B cell into the top, in NHL only. Hodgkin's is a different category for mainly one reason, that Hodgkin's lymphoma is a lymphoma where the tumor cells are very scanty. So that's why for many years it was called as Hodgkin's disease, as if it's an inflammatory disease. So we still continue to carry Hodgkin's lymphoma as a different lymphoma, though it is a B cell lymphoma. Maybe when these postgraduates, oh thank you. Maybe when the postgraduates become senior, you'll realize that this Hodgkin's lymphoma entity is no more because it's a B cell lymphoma. So if you look at the B cell lymphomas, they can be indolent, low grade and aggressive. Today's topic is aggressive. I'll be talking about these 4 lymphomas. And T cell almost always are aggressive. So T cell lymphomas are rarely low grade, rarely. But B cell lymphomas can be low grade, can be indolent, can be very aggressive. So diagnosis of lymphomas, leukemias is multidisciplinary, we know that. So this is important slide for postgraduates. It starts from history. So you are all doing pathology and we are all pathologists, but history taking, clinical examination is extremely important. So because many times, like today I had a case, I'm on my way from Bombay, yesterday I have a case of ALL, which has relapsed as T cell lymphoma. Young lady, it cannot be T cell lymphoma because T cell lymphomas do not occur in children. T cell lymphomas occur only in elderly. So we have to see that case again and again. We realize it's infectious mononucleosis. It's a viral infection which can look like T cell lymphomas. Infectious mononucleosis, we all know, it's an Epstein-Barr virus induced proliferations of lymphoid cells. It can look very bad. The cells can look very bad like tumor cells. But then we knew the age is a young lady. So young lady cannot have T cell lymphoma. It's very, 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 very rare to call a peripheral T cell lymphoma in a young adult. So we need all these techniques. Then obviously we need our H&E section for morphology, and we need IHCs, flow, cytogenetics, molecular, and we need radiology. When I mention these techniques, these all are available in India. There are at least 25, 30 good centers in India doing all these techniques. All means all. When we were students, very few centers were doing molecular, hardly any. But yes, the centers had started doing IHCs and flow, but now you'll find molecular, even NGS, there are many centers doing in India NGS. So you are lucky, the students. So if you read the new WHO book, which is a Bible, like blue book we call it, for leukemias, lymphomas, it divides leukemias, lymphomas into 6 chapters. 6 chapters. I'll be talking mostly about B, and that too, the part of B which is aggressive. So if you read that book, there are more than 400 types of leukemias, lymphomas, 400. And why do you need to know 400 types? Because prognosis is different, treatment can be different. Not all patients will die. Many patients can be cured. Like pediatric cell AL, B cell ALL, or 90% patients can be cured. Adult peripheral T cell lymphoma, AITL, are difficult to treat. We have now newer therapies coming up, very targeted therapies, very expensive. CAR T cell now we are doing in Tata Hospital, and many other hospitals in India are doing CAR T cell. These are very expensive treatment, but very good treatment. But in our country, still we have limited resources. We don't have many trained oncopathologists and hematopathologists. We need many more oncopathologists and hematopathologists. Now these are few targeted therapies. We know of rituximab, which is used in lymphomas, B cell lymphomas, and we know of imatinib in CML. Now imatinib in CML has made a revolutionary changes. When we were students, CMLs were treated by hydroxyurea. CMLs will not live more than 3 years, 5 years. Now CML patients are living on this targeted therapy, which has very least side effects for 20 years. So there are surely advantages of molecular diagnostics. We can't say molecular diagnostics is not important for those who think that only H&E is important. So however, I will say H&E is important as well as molecular is important, as well as AI is important, artificial intelligence. AI cannot replace the natural intelligence. So all of these are complementary techniques. But you can't remember 400 types of lymphomas. So commonly in adults, these are the common leukemias. CLL, CML, AML, MDS. In children, the commonest leukemias is B-cell ALL. And if you talk about lymphomas, these are the 5 common lymphomas in adults. DL, BCL, Hodgkin's lymphoma, peripheral T-cell lymphoma, angioimmunoblastic T-cell. The new name is T follicular helper cell, follicular lymphomas in adults. In children, common lymphomas are classical Hodgkin's, lymphoblastic lymphoma of T type. This occurs in mediastinum. Burkitt lymphoma, ALCL. So if you know these 5, 6, 7 lymphomas, you don't have to worry too much about reading that fat book. Aggressive lymphomas. Now, as I told you, most of the T-cell lymphomas are aggressive, and they occur in adults, not in the youngsters. B-cell lymphomas can be low grade, can be high grade. Amongst the high grade B-cell lymphomas, these are the 4 types. Large B-cell lymphomas, which could be DLBCL or could be high grade B-cell, Burkitt's, mantle cell lymphoma, blastoid variants, and B lymphoblastic lymphomas. There are 15 types of large B-cell. I'll show you all. Basically, I clumped into one category. So broadly, 4 categories of aggressive B-cell lymphomas. Now, most aggressive B-cell lymphomas have a morphologically diffuse pattern. Means these are like blastic lymphomas, Burkitt's, ALK positive large B-cell, ALCL, plasmablastic, high grade, large B-cell lymphoma with IRF4 gene rearrangements, blastoid transformation in follicular, blastoid mantle. They all have diffuse patterns. Rarely they have nodular patterns. Nodular lymphomas are generally low grade, not always, but generally like Hodgkin's, Mars syndrome, follicular low grades. But mostly high grades are aggressive. Likewise, in T-cell lymphomas, most T-cell lymphomas are high grade, and most of them are diffuse patterns. Could be AITL, T-cell lymphoma, lymphoblastic, or adult T-cell leukemia lymphomas. I'll just show you a case scenario now, just to how do you approach a case of aggressive lymphoma. Now, this is a young male which came to Tata Hospital with left cervical lymph node. This is a high par view. I should have shown you the low par, but just to cut short the time, this is a high par view, and you can see this tumor cells. There are some apoptosis debris in the background, some polymorphs, but mostly tumor cells are large, pleomorphic, mitotically active. So large pleomorphic cells having a nuclear eye. So we, as a pathology student, we are told this is a poorly differentiated malignant tumor. So we think of what all difference, carcinoma, lymphoma, or a melanoma. So we could do these 3 common states, one LCA for lymphoma, cytokeratin for carcinoma, S100 for melanoma. Now this is LCA positive. So we know it's a lymphoma. It's a large cell lymphoma. Why large cell? Because the tumor cells are large in size. It's not a small cell lymphoma, it's a large cell lymphoma. Now I need 2 more states, CD3 and 20. 3 for T cells, 20 for B cells. 3 is negative. Some background cells are positive, normal T cells. 20 is positive in all cells. So my diagnosis is now large B cell lymphoma and diffuse because it has a diffuse pattern. So this is my diagnosis. I will continue this case after a few slides. This is not completely worked up. So now, as I told you, the commonest lymphoma for postgraduate, you should know that commonest lymphoma in your practice would be large B-cell lymphoma, DLBCL. Is the commonest lymphoma. Almost 30% of all lymphomas are DLBCL. But you should also know that not all large cell lymphomas are B-cell phenotype. They can be T-cell, they can be NK cell, they could be plasma cell. Just to show you 4 cases here. They're all large cell lymphomas. Now if you look at, this is Hodgkin's with heavy tumor load. This is a histiocytic sarcoma. This is 163 positive. This is anaplastic large cell lymphoma in the sinuses. This is plasmablastic lymphoma. You can see they look like plasma cells, have a prominent nuclear eye. These all are large cell lymphomas, but they're not all B cell. Like this is a plasma cell, it's a mature B. ALCL could be T, histiocytic. Hodgkin is a B, but it's lost to 20. Now, another important statement to make. Many lymphomas can be LCA negative. So if you believe that LCA is negative, cannot be lymphoma, you're wrong. There can be lymphomas which are LCA negative. So Hodgkin lymphoma can be negative. Lymphoblastic lymphomas can be negative. ALK positive DLB plasmablastic lymphomas are negative. ALCL can be LCA negative. Also, many B-cell lymphomas. Now B-cell lymphomas we define by CD20. As I told you, do CD20. But 20 is not the best marker for B-cells. We'll see that many B-cell lymphomas are 20 negative. So if you are doing only 3 and 20, you'll miss out on many B-cell lymphomas. So which are those B-cell lymphomas you'll miss if you do only 20? There could be large cells, there could be small cells. These are the, Hodgkin's is a large B-cell lymphoma, but 20 is negative. You need to do PAX5. As positive plasmacytic lymphoma, you need to do MUM1 or 138 or 38. So 20 is negative here, but these are B-cell lymphomas. Similarly, small cell, like B-blastic lymphomas, they are 20 negative. You need to do 19 or PAX5 or CD22 or 79 alpha. This is CLL. Now CLL can be 20 weak, so you have to be careful. CLL is 20 positive, but can be 20 weak. So better B-cell markers. So 20 is not a good marker for B-cells, even for aggressive B-cell. 19, 79 alpha, PAX5, CD22, these are better markers for B-cells. If you have to select one B-cell marker, go for 19 or PAX5, not 20. 20 we use because our clinicians give rituximab. They give a drug which is targeted therapy to anti-CD20. So those B-cell lymphomas which are CD20 negative, we do not give rituximab. Like in Hodgkin's lymphoma, we do not give rituximab. It is a B-cell lymphoma, but it is 20 negative. So in our practice, in my practice, these are the 4 common stains I do. I don't do LCA. LCA we don't do, hardly we do, because we do hempath practice, so lymphomas come to us, so we don't do, but if you're a general pathologist, you need LCA. These are the common stains, 3 for T cells, 20 for B cells. MIB1 is a proliferation marker, Ki67, and CD23 to highlight your FDC networks. So these 4 stains give you a rough idea whether you are dealing with a tumor, benign. It gives you good architecture. CD3, CD20, MIB1, and 23. Now, if you are lucky to be in a bigger hospital which has good money, funds, and you can do many, many more stains. So large B-cell lymphomas, as I told you, you do 3 and 20 and MIB1. But the literature, the WHO defines, you need to do many, many more stains. Now, large B-cell lymphomas is not one type, it's 18 types. 18 types. If you read this, the commonest type is DLBCL, which I was mentioning to you. Then there are other 17 types. You don't have to read all this. But these are basically based on some molecular abnormalities or some ILCs or some site-based or viral infection-based. This is in the lungs, this is EBV positive, this is skin, this is intravascular. The commonest is DLBCL. So now, as I told you, there are 18 types of large B-cell lymphoma. And all of them are given same treatment. The treatment is R-CHOP. CHOP is C-H-O-P. There are 4 chemotherapies. And R is rituximab. R is rituximab, which is a targeted therapy anti-CD20. Now, it has been seen in the literature, even in Indian content, in our continent, that 40% of these patients survive, but 60% of these patients die within 2 to 3 years. So, diffuse large B-cell lymphomas, you treat them, there are 2 patients, one patient will die, one will survive. Now, as a pathologist, it's my role to tell the clinicians which patient will do better. So what do you do next? That's I'm going to talk. So, DLBCLs could be good, which are the curable, the bad, which may relapse, and ugly, which will die soon, maybe 6 months, 1 year. So as a pathologist now, my role is not only to give diagnosis, my role is also to tell which is the good one from the bad one, from the ugly one. So genetically, after studying maybe few thousand cases of lymphomas by genomics, scientists in the West realized we have 2 types of lymphomas, activated B-cell and germinal-centered B-cell. This was in 2000 by Alizadeh group. So this is the bad ones, G for germinal-centered, G for good. These are the good ones. You can't do genomics everywhere in the world. So we need to do surrogate markers of genomics. So we came out with the Hans algorithm, which says you just do 3 antibodies, CD10, BCS6, and MUM1. Now these 3 antibodies would differentiate your ABC from GCB category. Based on if CD10 is positive, it is a good one. If CD10 is negative, you do this. So ABC is a bad one, GCB is a good one. So these markers anybody can do anywhere in the world, these IHCs. So now going back to the case which I started, we had DLBCL. Now I mentioned 320 MIB1 we did, it's a DLBCL. Now I have to differentiate the good from the bad from the ugly one. What do? I use Hans algorithm. So I'll do 3 IHCs, 10, BCS6 and MUM1. So I do this, I follow this algorithm. But it has been seen that only 80% concordance between Hans algorithm and the genomics. And 20% is a huge number in medicine. So in many centers now, WHO does not recommend to follow this. You can follow, but it's not mandatory from WHO. You need not do these 3 stages. you can do. So I'll tell you the reason why to do. So we did 3 stains, 10 BCL, sigma 1. 10 is strongly positive. So if 10 is positive, I'm dealing with DLBCL GCB type. And we know that GCB is a good one. Now, next step is to do another 2 stains. MYC, MIC and BCL. Now MIC is best done by fish, not by IHCs. But we do IHCs because if you know that if more than 90% is MIC positive, possibly the fish will also be positive, possibly. And BCL2, if more than 57-60%, again it tells you it's a double expressor lymphoma. Now if these 2 markers are positive, we call it double expressor lymphoma. So initially we had DLBCL GCB type, now we have DLBCL double expressor type. Now this is a bad one. But this is not the important level. We need to go next, which is more important. Double expressor lymphomas are bad lymphomas. They are mostly ABC type. We know that ABC is a bad one. Now here, MIC amplification becomes mandatory. We need to do FISH, fluorescent in situ hybridization for MIC. And in this case, we did IgC-MIC and C-MIC break apart. It was positive. So this becomes diffuse large B-cell lymphoma with MIC and BCL2 rearrangement, which is the ugliest lymphoma. Now this is the worst lymphoma, worst. So I will not spend time on these pictures. I think I will, just to share with you, I told you the good DLBCL is GCB1. The bad one is double expressor one. And ugly one is MIC one. But irony is, all these bad, ugly ones, they come from GCB category. So by Hans algorithm, 50% are GCB, 50% are ABC. The 50% of GCB have a very good prognosis, but the worst category of this one, this lymphoma, comes from this category. So the recommendations are, if you have a case of DLBCL, which is CD10 positive, you have to do CIMIC. If it is ABC positive, you don't have to do, because they are bad lymphomas. But in the GCB category, if you want to tell the patient you are a good patient, you have to do CIMIC, and if CIMIC is negative, you can tell the family, this patient is going to survive. And if CIMIC is positive, which is 2 to 8% of, 4 to 8% cases of GCB are double hit. This is double hit lymphomas. In the older classification, we used to call it double hit. They arise from the dark zone which is rich in centroblast. In the, if you see the normal lymph node, we have dark zone and the light zone. Light zone has more FDCs, these are more centroblast. The high-grade lymphoma, double hit lymphomas come from dark zone. There are very few chemotherapy protocols. Mostly we use R-CHOP, mostly 80 to 90%. For Hodgkin's, we use ABVD. Then there are some more dose-intensive REPOC and few more protocols for blastic and Burkitt lymphomas. Now WHO 5th edition, which has just come, one interesting thing has come here, that if you are working in a premier institute, you can call them DLBCL with MIC. But if you are working in a place where there are not much markers, no fish, no molecular, you could just do CD3 and 20 and MIP1, and you could call it a large B-cell lymphoma, DLBCL. You can stop here. You need not do CD10, BCL6, MUM1. You need not do fish. So this is also enough. But to give prognosis, you need to do these markers. Yeah, I think I will, I'll go now to aggressive B-cell lymphomas. Now, aggressive B-cell lymphomas are broadly, can be divided into 3 types. One is the de novo. They come as aggressive, present as aggressive. Second is, they are transformed, like from follicular lymphoma. Follicular lymphoma becomes DLBCL. So those are rare. And third is now we picking up more immune deficiency related, like Hashimoto thyroiditis, or some immune deficiency related, post-transplant related, post-methotrexate, some drug related, virus related. So drugs related cases, these are also not uncommon. Now, how do you approach such cases? I've told you already, morphology is the most important. H&D section is the most important. The aggressive B-cell lymphomas are 5 types. Large B-cell lymphoma, high-grade B-cell lymphoma, mantle cell lymphoma, Burkitt's, blastic. Now, these 2 have overlap. These 3 have very classical morphology and immunophenotype. Mantle cell lymphomas are 5 positive, cyclin D1, FOX11. Burkitt lymphoma is BCL2 negative, MIB 100%, CMYC positive. Blastic lymphomas are TDT positive. These have some overlap. Like I've shown you, these have overlap. They are very classical, more distinct subtypes. Like DLBCL is more pleomorphic, high-grade B-cell lymphoma is less pleomorphic. Though I've written the definition, it's given in beautifully in the WHO book, I don't want to read it again for you. So based on morphology, we decide it's high-grade B-cell or DLBCL. They are more pleomorphic, they have a prominent nucleoli. They are more vesicular chromatin, more blastic morphology. If you have a case of DLBCL, you do these 3 stains, obviously, you're done. Then you do CD10. Now, if CD10 is positive, it basically means it's a GCV type, it's a good one. You have to do CMYC. If CD10 is negative, you can just stop there, tell the clinician to treat. Now, CD10 is positive, so you have to break apart fish. And based on this algorithm, we have these different entities. High-grade B-cell lymphomas with MYC BCL2, this is a common one. Then we have high-grade DLBCL and high-grade, and then we have NOS. Then we have rare tumors which look like Burkitt's, high-grade B-cell lymphoma with 11 Q aberrations, and large B-cell lymphoma with IRF4 gene mutations. So if you are working in a smaller center, these are the enough markers which are mandatory, CD3, 21, 3 and 20 and MIP1. But if you are working in a bigger lab where you can afford to do markers, you have a long list, also markers by fish. As I told you, morphology is extremely important here, which takes the, which guides us how to go forward. So how do you classify aggressive B-cell lymphomas? You can classify based on size, based on, they can be small to medium, they can be large size. You can define them based on disease site, like immune prevalent site, like testes, brain, vitreoretinal, these are immune, skin, cutaneous lymphomas, mediastinum. Then you can have on the context, like long standing secluded areas of fibrin, DLBCLs, fluid overload DLBCL, effusion-related lymphomas. There could be virus-associated, EBV positive DLBCLs, Kaposi sarcoma positive DLBCLs, microenvironment, T-cell histocytic B-cell lymphomas, lymphomatoid granulomatosis, chronic inflammation DLBCL. Then classification driven by EBV association and other clinical features like LG, EBV positive. So based on these contexts, we can classify aggressive B-cell lymphomas into different types. Now the important thing I'm coming now is genetics. How do you define DLBCL based on genetics? Now which we are doing in Tata Hospital. Many other centers in India also started doing DLBCL, you define based on genetics. Now this is 2000 paper by Alizadeh. Now the recently came Wright's paper which defined 7 types of DLBCL based on molecular. These 7 types. MCD, BN2, N1. MCD is an N1. It has been seen that these 2 types, which are ABC, so should be bad. But if you give one more drug, which is ibrutinib, these patients are 100% curable. So MCD and N1, these are the types of DLBCL, molecular type. MCD means M for MYD88 mutations, CD for CD79 beta mutations. N1 is Notch1 mutations. These mutations in DLBCL, if you see, these are associated with ABC subtype, but these are 100% curable if you add one more drug with R-CHOP, ibrutinib. So we are all learning. This has not come as a recommendation in WHO, but these are the recent articles. I think I'll skip this. Yes. Now I will show you some examples of aggressive lymphomas. I would like you to participate. If you want to participate, it will be nice. This is the first case. A young boy, abdominal mass biopsy. So we can see some part of maybe small intestine, maybe say ileocecal area, and there's a very infiltrative or is a tumor here which looks like a lymphoma. So based on history, if it's a lymphoma, there is only one lymphoma which can go there in this age. Which lymphoma? 10-year-old boy, abdominal mass biopsy. It's not a rhabdomyosarcoma, I think. It's a lymphoma. So which lymphoma it would be? Monomorphic, small to intermediate size cells. Burkitt's. Only one lymphoma. Burkitt's. There's no other differential here. So you don't need many markers. So Burkitt's is classical. So you do, they are small to intermediate round monomorphic tumor cells in a diffuse pattern full of apoptosis and mitosis. monomorphic, intermediate size cells, and they occur in ileocecal region. They present as intersusception. So if a patient has an obstruction and surgeon says it's interception, and on your frozen section you think it's a lymphoma, it would be Burkitt's lymphoma. Look at LDH, will be very high. The patient going to tumor lysis syndrome, you have to treat them aggressively. They are 20 positive, 10 positive, MIB1 is 100%. 100%. This is the only lymphoma where MIB1 is 100%. And this is the only lymphoma which is BCL2 is negative. EBV, Iberish is mandatory now as per WHO in all Burkitt's. So there Iberish is positive. CMIC by IHC is not helpful. We do not do. I just taken it for picture for this case. TDT was negative. It was not blastic. So classical Burkitt's lymphoma, extranodal. So this was the diagnosis, extranodal non-Hodgkin lymphoma, Burkitt lymphoma. So history is very important, site is very important. So without that, pathology, we cannot do good pathology. I go to second case. 50-year-old male, seropositive buccal mucosa growth. So these are mucosal lining, and these are tumor cells. Full of mitosis, large size cells, prominent nuclei, vesicular chromatin, some kind of squaring off, mitotically active. Mucosal lining and dense infiltrate, very, very mitotically active, apoptosis. There's only one diagnosis based on history if it's lymphoma. If it's lymphoma, there's only one diagnosis. In HIV, plasmablastic lymphoma. So obviously I'll do IHCs. It may be melanoma or something else. I'll do cytokeratin. I will do, because commonest tumor in buccal mucosa is carcinoma. So I'll do cytokeratin. It'll be negative. I'll do S100, negative. I do LCA, negative. I'll do 3 and 20, negative. So it's still a lymphoma because plasmablastic lymphomas are 20 negative. LCA negative. So here 138 and MUM1 and CD38. CD38, CD138, MUM1 are important markers. Iberish was positive. So it's classically seen in HIV patients, plasmablastic lymphoma, oral mucosa and the anal mucosa associated with homosexuals. We used to see lots of it, now the number has come down. We don't see that many. But in early 2000, we used to see many HIV lymphomas. I go to case 3, a 37-year-old male, right cervical lymph node, diffuse pattern, monomorphic small cleaved cells. So you have to believe me, they are monomorphic small cleaved cells, diffuse pattern. Previous case was also monomorphic, diffuse, but it was round cell. So Burkitt lymphoma is monomorphic, diffuse, round cell lymphoma. Now this is not round, this is cleaved. Monomorphic, small but cleaved. Only one diagnosis on a chip. It could be either follicle lymphoma grade 1, but it's not a follicular pattern, it's a diffuse pattern. I don't think it's a follicle. So there's only one differential. Small cleaved cells, monomorphic, mantle cell lymphoma. So your mantle cell lymphomas are lymphomas which do not have a single nucleolated cell. No large cells at all. If you find large cells in a lymph node, you are not dealing with mantle cell lymphoma. Pleomorphic mantle cell lymphoma is rare, but then all cells will be large. That will be DLBCL. So here you do 3 and 20. 20 is strongly positive. We did CD5. You see, look at 3 is negative, 5 is positive. I repeated 5 twice here. Cyclin D1 is positive. MIB1 is very high. PAX5 is another B cell marker. I always do with 20. So I do 2 B cell markers in all my lymphomas, CD20 and PAX5. PAX5 is a nuclear marker, very good marker. So it's very crisp. It doesn't give you any false staining. So this is a high-grade mantle cell lymphoma, blastoid variant. MIB1 is very high. So my final diagnosis was an NHL blastoid variant of mantle cell lymphoma. Mantle cell lymphoma. Small, monomorphic, cleaved cells. And similarly, small, monomorphic round cells were Burkitt's. So these are old classification, Rappaport types, when they used to call it small, round, monomorphic Burkitt's. Small, round, cleaved, mantle cell. Now we call it mantle cell. I go to next case, case 4. Again, an adult male, left cervical node. You see a diffuse pattern, blastic morphology. Very, very blastic, mitotically active, diffuse pattern. So if it was a 7-year-old boy, I would think of lymphoblastic lymphoma. Since it is a 57-year-old, it's rare to have lymphoblastic lymphomas in that age. So what are the blastic lymphomas in that age? Mental blastic. Mental blastic are more common in that age. Mental blastic are TDT negative. Lymphoblastic are always TDT positive. Mental blastic is a mature lymphoma. So what we do again stage 3 and 20 is positive. And we did 5. 5 was positive, those weak. These are the normal T cells which are strong like this, but the background is weak. MIB1 is strong. PAX5 is positive, cyclin D1 is negative. TDT is also negative. So now I'm dealing with a lymphoma which is like this. In an adult, diffuse pattern, monomorphic, small cleaved cells, blastoid morphology, mitotically active. So I thought of blastic lymphoma, lymphoblastic, but it's an adult. So lymphoblastic was low down in differentials. I thought of mental cell blastic lymphoma. Cyclin D1 is negative, 5 is positive. What do I do next? I do another marker for mental cell lymphoma, SOX11. Now you have to do, if cyclin D1 is negative, you're still suspecting mental cell lymphoma, you need to do SOX11. You can't stop there. Now this is SOX11 positive, so this is again a mantle cell lymphoma. So we have cyclin D1, cyclin D2, CCND1, CCND2, CCND3. So SOX11 becomes important here. So this cyclin D1 negative, mantle cell lymphoma, but blastoid variant. So small cleaved cell lymphoma, monomorphic, mantle. Not even a single nucleolated cell. Next case, 5-year-old boy, right orchidectomy. These are the seminiferous tubules, and you can see this infiltrative pattern of a tumor. So what can be the diagnosis of based on history? Only one. Based on history and morphology. I'm not doing rhabdomyosarcomas or Rieving sarcomas. I'm doing only lymphomas. So there's only one lymphoma which goes to testes in children, lymphoblastic lymphomas. Lymphoblastic lymphomas, the century sites are testes and brain. You go to CSF in patients of ALL because the tumor cells can go to CSF and brain. And also they go to the testes. So here it's very classical pattern. The blastic morphology, infiltrative pattern of, you can see the tubules are still intact, but the tumor cells, and if you do 3 and 20, they're both negative. So it is not a lymphoma, it still could be lymphoma. As I told you, 20 is not the best marker, 20 can be negative in blastic lymphomas. You need to do PAX5 or CD19. PAX5 is strongly positive, is a B-cell lymphoma. 10 is positive, TDT is positive, 34 is positive. So this becomes lymphoblastic lymphoma in the testes. It was a known case of ALL who relapsed in testes. Bone marrow was normal now, but relapse happened in testes. 25-year-old male, I'm coming to my last 2-3 cases, 3-4 cases. 25-year-old male, anterior mediastinal mass. This is needle core biopsy, you see diffuse pattern. There are tumor cells of large size, intermediate to large size. There's a lot of fibrosis in between, fibrotic pattern, you can see that. There's some kind of compartmentalization in mediastinum. Very classical picture of primary mediastinal large B-cell lymphoma. PMBCL occurs in 30-35 years old ladies, and they are differential of Hodgkin's and gray zone lymphoma. But if you do CD20, they'll be diffusely positive for CD20. They also express 23 and 200 and 30. So 30, 23, 200 are classically seen in PMBCL. Now 20 and 30 can also be seen in gray zone lymphoma, but the morphology is very different. So this is primary mediastinal large B-cell lymphoma. Next case, 35 male supraclavicular mass. You see the nodules, nodular pattern, and the fibrosis. Now this is a lymphoma which has a nodular pattern, but it is aggressive. It's in supraclavicular region. Now we know that supraclavicular region is part of mediastinum. So what are the lymphomas in mediastinum? There are 3 lymphomas: Hodgkin's, gray zone lymphomas, and primary mediastinal large B-cell lymphomas, apart from germ cell and other tumors. So if it's a lymphoma, I would think of Hodgkin's. This doesn't look like PMBCL. It looks more like Hodgkin's because of nodules, fibrosis, and RS-like cells, and some necrosis somewhere. 3 and 23 is positive in small cells. All the large cells are 20 positive. Now when in mediastinum, I have a Hodgkin's morphology and the tumor cells are strongly positive at 20, I think I'm dealing with a gray zone lymphoma. 30 is positive, 20 is positive, both 30, 20 positive. 15 is strongly positive. So PAX5 is strong positive, MUM1 positive, BOB1, OP2. So we need to do a host of markers. So this is a case of mediastinal gray zone lymphoma. Now, this is a rare case I'm showing you. It's not common now. 21-year-old boy, colonic mass. You can see some mucosal lining, and there's a tumor here showing intrasinusoidal kind of cattle or nested cattle. Looks like ALCL here also. Large cells. We did markers. 3 and 20 were negative. CD138 is positive. So it comes positive in plasmablastic lymphomas, but MUM1 was negative. So MUM1 is negative, 138, it could be carcinoma, because 138 can come positive in carcinomas also. So here we need to do cytokeratin, we did, it was negative. 30 was negative. So which lymphoma is this? This looks like ALCL or plasmablastic lymphoma, and is positive only for 138. Negative for 30 is not ALCL. Negative for MUM1, it's not plasmablastic. So ALK1. Now there's an entity called as ALK positive diffuse large B-cell lymphoma, which is more commonly seen in Asian continent. We see a lot of cases in India. In Western literature, they don't see many cases of this. Again, we do not know the reason. And any case of plasmablastic lymphoma, if you have a doubt, it's not fitting into plasmablastic, please do ALK1. Then only you'll pick up these types of lymphoma. They look like plasmablastic lymphomas, but they do not occur in HIVs. They do not occur in buccal mucosa. They occur in nodal sites and other extranodal sites. Like this was in GI. A young boy, ileal mass, as I told you, small, round, monomorphic Burkitt's, very classical morphology. IHCs, I told you, 100% MIB1, 100%, 10 positive, 20 positive, BCL2 negative. You need to do FISH for Burkitt's. In Tata Hospital, we don't do. We base our diagnosis based on HNE and IHCs. But literature says for all Burkitt's, you need to do two things: MIC by FISH and also Iberish. We don't do both. We try to still save money here. And Burkitt's lymphoma, you have multiple differentials. But it's very classical morphology. I think I'll skip this case of flow. Now this is a new entity which has been recognized as a chapter in WHO, high-grade B-cell lymphoma with 11q aberrations. Now you cannot diagnose this entity unless until you do MIC in all Burkitt's. So you think that there's a case which looks morphology Burkitt's. You think it's morphology Burkitt's. IHC Burkitt's. So you can Cyanotos Burkitt's. But MIC is negative. Those cases you need to do 11q, and most of these cases are this category. So those cases of Burkitt's lymphoma, which are morphologically, immunophenotypically Burkitt's, but they are c-MYC negative. Because Burkitt has to be c-MYC positive. Those are 11q aberrations. They look very like Burkitt's, but here there's the literature says the debris is more apoptotic, more coarser debris. We have seen very few cases in Tata Hospital because we do not do MIC in all Burkitt's. We have been taught in school and in medical college until now, I was teaching my students also that any blast which have vacuoles is Burkitt's. It's not true. This is a case of ALL, which on relapse has vacuoles. And this is a case of, again, prominent. This looks like Burkitt. This is not Burkitt. This is a case of B-cell ALL. So based on vacuoles, we can't say L3, which we used to teach. No, though it's rare. But I'm just sharing with you, we have burnt our fingers. We thought it's a Burkitt. But it was not Burkitt by any markers, by TDT negative, mature B cells. So you have to be very careful. Based on morphology has its handicaps. We need to work up if you have the facilities. Next case is very interesting. This is a young boy. This is an inguinal mass. But generally this lesion occurs in tonsils. So if you have a young boy or middle age or young adult, tonsillar mass looks like a high-grade lymphoma. High-grade lymphoma, diffuse or nodular pattern. Looks like blastic morphology, but large size morphology. Large size, but blastic. These kind of cells, intermediate to large, blastic. Occurs in tonsils. You have to think of one, you keep in mind one entity. Do 20 is positive, and there will always be 10 BCL6 positive, and MUM1 will be very strong. Very, very strong. This is called as IRF4 positive DLBCLs. This is a new entity in WHO. These have a better prognosis than DLBCLs. You need to do FISH for IRF4, break apart. This is a rare entity, but it's seen in tonsils in young individuals. MUM1 strongly positive. Any high-grade B-cell lymphoma in tonsils, which is MUM1 strongly positive. Keep in mind IRF4. Now this is the classical follicular dendritic cell sarcoma. I don't want to spend time. This is not a B-cell lymphoma. Just to change taste from B cells, they are very spindling ovoid cells. They can show you whorls, interstitial patterns, spindling. They can show you fibrosis, astoriform patterns. They can show you, and you need to do FDC markers, CD23, 21, 20, 35. You need to do Iberish because there are two types of sarcomas. There are inflammatory FDC sarcomas and then FDC sarcomas. Inflammatories are those which are EBV positive. They are a little more benign, they are more malignant. Little difference there. There are differences given in literature, but I'm not going to. So the EBV positive has more indolent course, this has more variable course. So just to conclude my presentation, we know that common types of lymphomas are 4 in adults, 5. DLBCL, classical Hodgkin's, follicular, PTCL and T follicular helper cell lymphoma. The old name is AITL. In children, classical Hodgkin's, NLPHL, T lymphoblastic lymphoma in media sanum, Burkitt's, nodal, extranodal. Burkitt's occur very commonly in extranodal site, breast, GI, ovaries, anaplastic large cell lymphomas. So broadly, 3 types of aggressive lymphomas, they have a problem. Mantle and blastic have different morphology, I told you. DLBCL, Burkitt's and high grade. They have little overlap. These two surely have an overlap. Mandatory stains, this much. If you can afford, you can do more. WHO has essential criteria and preferable and desirable criteria in all books. So I was lucky to be part of the WHO lymphoid book. So I had, this was one of my, I was very strong proponent of these two, essential and desirable to come to WHOs. Now flow has picked up in the last 10 years in lymphomas. So if you are doing flow cytometry, please send sample to flow lab also, do FAD. We've diagnosed lots and WHO is giving much more importance to flow in this new edition. These cases of AITL, which we used to call it DLBCL, we have picked up on flow. 3 negative, 5 positive. Margin zone lymphomas were called as AITL. Hodgkin's lymphoma becomes AITL. So there are complementary techniques. We can't say one is better, another is not better. My colleague Gaurav Chatterjee, who we work together, he has just established a 250 genes panel for lymphomas, and it's a project, and hopefully by next year we should put in the service. We're right now doing myeloid leukemias by genomics for last 7 years, but Nikhil Patkar is doing. Now Gaurav is just starting this project, and maybe early next year we should be giving reports of lymphomas by NGS, where we put the sample into the machine and you can study 250 mutations. You don't have to do one mutation separately. So this is my last slide. I think B-cell lymphomas can be LCA negative, 20 negative. Lymphomas can be LCA negative. So don't, just doing LCA doesn't mean it can't be lymphoma. T-cell lymphomas, you need, CD3 can be weak. So you need 3 and 7. 3 is specific for T, but 7 is very sensitive for T. If you're doing lymphomas, IHC is mandatory, and it's preferable to have automated IHC, not the manual. Automation is expensive, but it gives you good quality. Manual, you can't maintain the quality. It's very, very difficult to maintain the quality. This is my team at Tata Hospital and my few friends from outside who have helped us develop our hematopath labs. Thank you, everybody.
Thank you so much, sir. Before we move to the chairpersons, may I request our chief guest, director, sir, and MS ma'am, and along with the senior dignitaries who have entered the hall and graced the occasion. A huge round of applause for them. We wholeheartedly welcome you, sir. Over to the chairpersons for their inputs, please.
Sir, I congratulate you for an excellent session today. And today's session just reaffirms why our name is synonymous with lymphomas. And it's a proud moment for Haryana chapter that you are presenting here, and you are one of our own from PGIMS Rohtak. So it's again a proud moment. Thank you for being here.
Thank you.
Extensive workup
can be done only in some centers, and you're really placed in a very good center in India, and your presentation was very nice, explainable and colorful also, but I think these markers are beyond many people, many of us. But we have to work on these markers, because I think the future treatment is also going to be based on these. So we have to go through these markers, and thank you for such a good presentation all the way. And I think you have voted for the right person in Bombay and have come all the way.
Thank you for having me. It's my home. I've always looked for invitation from Haryana. Dr. Sunita has never called me to Rohtak. I've been waiting for before I retire and before she retires. I love coming to back home. This is my state. I'm born and brought up here.
Yeah.
And thank you for having me.
I think any questions or can be taken up personally with Dr. Gujral.
Yep.
Because it will be difficult to answer in this group.
Thank you.
Sir, please stay back. Sir, please. Thanks for filling up the lacunae in our existing knowledge, sir, and that too via this beautifully crafted presentation. There was hardly any text. I feel it was really colorful. So thank you so much again, sir. And this topic has really become a little bit approachable now, I guess, for every one of us. And we are really grateful to have you here. And we are really thankful to you for starting the OT-PPGP program, which is really helpful for all the postgraduates and even for us as well. So thanks a lot. With that, I request the chairs to please present a plaque of appreciation to Dr. Sumit Gujral, sir. There should be a big thunder in the hall, please. We are not less. Sir has traveled from Mumbai just for us, so big thanks to him and to the chairs for gracing the occasion. Thank you so much, sir. I would like to request Dr. Sangeeta Singh, ma'am, Professor and Head Biochemistry, SHKM GMC, to please felicitate our chairs. So, sir knows everyone, I hope. Thank you, ma'am. Kindly honor Dr. Uma Singh, ma'am. Ma'am is guru of lot of us, so I expect a huge round of applause. This won't work, please. Yes, thank you so much. Ma'am, kindly felicitate Dr. Indu Jyoti, ma'am. Ma'am, please felicitate Dr. Mukta Pujani, ma'am. Thank you, ma'am, and thank you, chairs, for gracing the session. Thank you so much. Thank you, ma'am. Thank you, ma'am. Thank you. Thank you, ma'am. Vidya dadati vinayam, vinayadayati patratam, patratvat dhanam apanoti, dhanat dharmam tatah sukham. Namaste and a blissful morning again to everyone. On behalf of organizing teams of SHKM GMC NU and APP Haryana, I, Dr. Bhavna, wholeheartedly welcome our Honorable Chief Guest, Director SHKM, respected Dr. Mukesh Kumar, charismatic and distinguished guests, esteemed colleagues, and all the inquisitive scholars to the second annual conference of Regional Society of Pathologists, IAPM Haryana chapter, and 14th HAPPCON of Association of Practicing Pathologists, Haryana. Today's conference is a joint venture of Department of Pathology, SHKM GMC NU, and APP Haryana, organized under the aegis of Regional Society of Pathologists, IAPM Haryana chapter. Pathology, as we all know, lies at the heart of medical diagnostics, and I feel everyone will agree that this branch has significantly evolved and transformed in recent years, and it's continuously shaping the future of healthcare. With the theme of Pathology Insights, Foundations to Future, we wish to emphasize and commit to a legacy that grows stronger with each step. We are honored to have among us profound intellectuals, experts in academia, and stalwarts from the field, making this conference all the more meaningful. With this learning platform, we invite everyone to honor the past, engage in the present, and contribute to shaping the promising future in the field of pathology. With a great sense of honor and pride, I would like to begin the ceremony by taking the privilege to invite our special guest for the day, Dr. Mukesh Kumar, Director and Patron, SHKM GMC NU, to kindly grace the honorable chair on the stage. Thank you, sir, for joining us. With immense pleasure and regard, I would like to invite retired Director General Health Services, Dr. Parveen Garg, observer from Haryana Medical Council, to please glorify the dignified chair. We welcome you, sir. May I request our respected Medical Superintendent, Dr. Sulbha Nayak ma'am, to please grace the esteemed chair on the stage. Let me take the privilege to invite Chairperson, Regional Society of Pathologists, IAPM Haryana Chapter, and Senior Professor and Head Pathology, PJMS Rohtak, Dr. Sunita Singh ma'am, to please glorify the stage with her captivating presence. The hall should not be silent. It's my humble request to everyone. Thank you so much. I am delighted to invite Dr. Harendra Kumar, Treasurer IAPM, to kindly honor us with his presence on stage. I am profusely elated to invite Organizing Chairpersons APP Haryana, Dr. Indu Jyoti Sharma ma'am, and Dr. Santosh Kumar, to please proceed towards the distinguished chairs. With equal pleasure, I would like to call the big supporting pillar for the conference, Secretary and Treasurer APP Haryana, Dr. Prashant Gupta, to please join us on stage and take the esteemed chairs. May I request our organizing chairperson, respected Dean Academics, and Professor and Head Pathology at SHKM GMC, Dr. Pooja ma'am, to please take the honorable chair on the stage. Thank you, ma'am, for joining us. Next, I would like to call Organizing Secretary SHKM, Dr. Sheetal Gole ma'am, to please join the dignitaries on stage. Thank you all for joining us and gracing this occasion. May I request Dr. Pooja ma'am to kindly honor and welcome Director sir with a floral bouquet. May I request Pooja ma'am to kindly honor Director sir. I request Director sir to please come forward. I request Pooja ma'am to honor and welcome Dr. Parveen Garg sir. I would again request ma'am to present a bouquet to Dr. Sunita Singh ma'am as a gesture of regard and welcome. Ma'am, please again do the honor. Please welcome Dr. Nayak ma'am, RMS ma'am. I would again request you to please extend a genuine welcome to Dr. Indu Jyoti Sharma ma'am. Now I request Dr. Sheetal ma'am to cordially welcome Dr. Harendra sir. I request Sheetal ma'am to please do the honor again and welcome Dr. Santosh Kumar sir. Ma'am, please stay back and welcome Dr. Prashant sir. I thank Pooja ma'am and Dr. Sheetal ma'am for honoring us. As we stand at the threshold of this new journey, let's indulge ourselves in the tradition of worshipping and invoking the Almighty by dedicating a prayer to Ma Saraswati, the embodiment of knowledge and the giver of boons. I would like to request eminent dignitaries to kindle the lamp of knowledge and wisdom and make this event a blessed one. Shubham karoti kalyanam, arogyam dhan sampada, Shatru buddhi vinashaya, deep jyotir namostute.
वो हम कर ही चुके हैं.
आज हमें बहुत गौरव का अनुभव हो रहा है कि हम अपने 70 प्लस पैथोलॉजिस्ट को ऑनर कर पा रहे हैं और डॉक्टर बीएल गोयल बहुत ही डायनेमिक, और मैं सर का बहुत बहुत धन्यवाद करूंगा आज यहाँ आने के लिए. सर, डॉक्टर बीएल गोयल, अगर मैं याद करूं, एपीपी फरीदाबाद जब हमने बनाई थी, डॉक्टर मनीष, डॉक्टर बीसी गुप्ता और जब भी हम मीटिंग करते थे एपीपी फरीदाबाद की, तो सर हमेशा सपोर्ट करने के लिए टाइम से हमारे लिए वहाँ पे खड़े रहते थे। तो मैं डॉक्टर बीएल गोयल का बहुत बहुत आभार व्यक्त करता हूँ और कामना करता हूँ कि उन्होंने जो हम लोगों को शिक्षाएं दी हैं वो हम किसी तरीके से काम में ला सकें। और साथ ही साथ हमारी जो तीसरे डॉक्टर जेपीएस नलवा सर वो नहीं आ पाए, और डॉक्टर उमा सिंह, इन लोगों को हमने फेलिसिटेट किया, और हम चाहेंगे कि आगे भी ये लीगेसी कामयाब रहे और जो हमारे सीनियर पैथोलॉजिस्ट हैं हम उनसे कुछ सीख सकें। थैंक यू।
Thank you so much, sir. Now, to steer us through this session, it is my pleasure to introduce and invite our esteemed chairpersons, Dr. Rajiv Sen, sir, Professor and Head Pathology, SGT Medical College, Dr. Jyotsna Madan, ma'am, Professor and Head Department of Pathology, Postgraduate Institute of Child and Health, Noida, and Dr. Shivani Kalhan, ma'am, Professor and Head Pathology, Government Institute of Medical Sciences, Greater Noida. Please join us on stage and share your profound insights. With raising incidence of acute leukemia in today's era, early diagnosis is becoming an important and crucial step in management of our crucial step in our management. And our next step focuses on the diagnostic workup of acute leukemia. So I would like to invite our next speaker, who truly needs no introduction and is a pioneer in the field of pathology. And it is a great honor and privilege for me to please welcome with a huge round of applause, respected Dr. Tejinder Singh, sir. I would also like to request Dr. G.N. Verma, sir, Consultant Pathologist, Dr. Verma Path Lab, Sirsa, to please join us as our esteemed chairperson. I would request our esteemed chairpersons to kindly introduce our speaker, Dr. Tejinder Singh, sir.
Examiner, sometimes as panelist or speaker in some conferences, and learning from him. So besides other things which most of us know, I know him as a wonderful human being and a very passionate teacher, and he speaks with lucidity that is unparalleled, and I hope we all will listen and learn from him.
Thank you, Dr. Rajiv, and good afternoon, everybody. At the outset, I would like to thank Dr. Pooja and her team for inviting me and interact with you. It has been a pleasure meeting old friends after a long time. So today, I'll be very briefly talking about diagnostic workup of acute leukemias. चल रहा है, ये भी नहीं चल रहा, उसको नहीं करूँगा। एक मिनट। नहीं हो रहा उससे. All right. Now you all are familiar with this picture either in the book or on the slides. And what you can see are sheets of blast cells. You can see large nucleus, thin rim of cytoplasm, open chromatin, and prominent nucleoli. Now this is the basic picture of blast cells. Whether they are lymphoblasts, whether they are myeloblasts, or they are megakaryoplasts. Now, Sumit told us about the new classification of which he is a part of it, that WHO classification. And many more Indians are also part of this new classification of hematolymphoid neoplasms. And now what we have is the 5th edition of the WHO classification of hematolymphoid tumors. Now this book, blue book, is available in the market. Now talking about the hematolymphoid tumors, first of all the lymphoid ones. You will find in that book there are two types of B cell neoplasm. One is B cell precursor neoplasms and second are the B cell neoplasms. Now what is the difference in the two? The B cell neoplasms are of B lymphocytes of various stages which give rise to lymphomas. What he talked about was the B cell neoplasms. What I am going to talk about is precursor B cell neoplasm. What we call morphologically all of them as lymphoblasts. So the tumors arising from this are acute lymphoblastic leukemias. Now the classification is here based on, as you can see, ploidy changes, chromosomal rearrangements, genetic drivers, and then we have B cell NOS for cases that cannot be put in any of the categories. Now most of them what you will find is that these are IMP21 associated with BCR-ABL1 or KMT2. I am not going into the details because these tables are given in the book as well as you will find them in the new WHO book. Then we go on to AML. Now here there are 4 groups of AMLs. One of the groups is AML with defining genetic abnormalities. That is a well-defined genetic abnormality, and that is like PML-RARA, which is seen in acute promyelocytic leukemia, RUNX1, T1, KMT2A arrangement, BCR-ABL, NPM1, and SEPA. Now these are some of them. So this is the table which is given in the book. Now what has happened is where we have a known abnormality, like in cases of PML-RARA or in cases of translocation 821, for them the 20% cutoff is not there. For them it should be more than 10%, provided that genetic abnormality or that mutation is present, only then. Then we have acute myeloid leukemias which are defined by differentiation. Now by differentiation it is something like FAB classification. In FAB classification we had M0, M1 to M7. Now that term FAB classification is not being used. What is being used is as defined by differentiation of the cells. So the cells with minimal differentiation we have AML. When the slight maturation starts occurring, then we have with maturation, this is without maturation, then we have acute basophilic leukemia, a rare type, then we have where there is differentiation towards both myelo as well as monocytic. So we call it as AMML, acute monocytic leukemia, then we have acute erythroid and acute megakaryoblast leukemia. Finally, we have AML which is related to myelodysplasia. That means the patient has had MDS for some time, then that MDS we know is potentially going on to AML later on. So these patients go on to AML later on, and there we find, say, 5q deletion, monosomy 7, 11q deletion, and so on. Then the other somatic mutations are ASX1, SF3B1, SRSF2. These are the various mutations which you will come across. Now today what I am going to talk about is how to diagnose a case of acute leukemia. First thing is needed is history and clinical findings. That is the most important thing. And then we examine peripheral smear, bone marrow aspirate, along with the CBC. What about the platelets? What about the neutrophils? What about the lymphocytes? All those cells. So what we do is we assess the morphology of the blast cells. What we have on the bone marrow is 500 cells differential count, because the distribution of the cells in the bone marrow is not uniform. At some area you may find there are sheets of blasts, in the other area the blasts are few. So we should count 500 cells so that we get the exact blast cell count. Then we are looking at the morphology for myelodysplasia. Suppose I find multinucleated megakaryocytes, I find hypogranular myeloid cells which are suggestive of myelodysplasia. That means this patient has had MDS. Now this patient has developed AML, so his prognosis is worse, because MDS related changes going on to AML, the prognosis worsens. Then we do, after doing the differentials on the PS bone marrow, cytochemistry. Cytochemistry is the most important thing. When we didn't have the cytogenetic abnormalities, we didn't have the mutations, I'm talking about the 60s and 70s, what we used to do, we would do cytochemistry to distinguish whether it is AML and ALL. And the management, by and large, still remains the same. What I mean by and large is, earlier when we were students in 70s, it was, is it ALL, is it AML? That is what they wanted to know, because the treatment for ALL is different and treatment for AML is different. Whether we told them that it is M4, whether it is M2 or M1, treatment remained the same. They would insist, just tell us, is it ALL or AML? So for that, what is needed is cytochemistry. I must tell you, even today, all the clinicians want a rapid diagnosis. Tell us ALL or AML. They will start the therapy. They will collect the sample in heparin or EDTA, whether it is for mutation studies, whether it is for NGS. They will send the sample to the lab. The report will come after 2 weeks, 3 weeks. But the treatment has already started on what you diagnosed as ALL or AML. So they are not bothered. We keep on telling it is M5A, it is M5B. They are not interested in M5A, M5B. They are interested in knowing is it ALL or it is AML. Then we do nowadays immunophenotyping. That is, we want to know the lineage. Lineage is it AML or ALL? Basic. If it is ALL, is it B-ALL or T-ALL? And if it is myeloid, is it only M0, M1 type, or is it M3 like promyelocytic leukemia? And for immunophenotyping, we have two methods. One is by flow, second is by immunohistochemistry. Now, immunohistochemistry, all of you are doing on the lymph nodes or in undifferentiated carcinomas or undifferentiated sarcomas. Same method is employed on the bone marrow trephine biopsy. So that means what has been added over the years is, earlier they used to do only bone marrow aspirate. Now they do bone marrow aspirate, they do bone marrow trephine biopsy also. And then we do cytogenetics, and finally we go for the molecular. Now all these steps have to be taken in each case of acute leukemia. So for acute leukemia subtyping, what we need is clinical background, then we have the morphology, then we do cytochemistry, immunophenotyping, then we have cytogenetics, in which we do conventional karyotyping, and then we have the molecular genetics, and we have various mutations. I'll talk about those mutations later on. So this is the roundabout about which we have to go to diagnose a case of acute leukemias. Now, why do we need clinical information? So you will find that clinicians send you the bone marrow, they'll send you the bone marrow biopsy, but they will not send the clinical data. But we do need the clinical data. If liver is enlarged, spleen is enlarged, lymph nodes are palpable or not. Is it a case of Down syndrome? If it is a Down syndrome, then we know that what we are looking for is probably a M7 type of acute leukemia. Is it a myeloid neoplasm with germline predisposition? You may find now family history is present. As we take the detailed history, we come to know some cases could be of germline mutation. Prior therapy, if the patient has been given therapy, say for breast cancer or testicular cancer, and then you find later on they've developed a case of acute leukemia. So the double malignancy. And then whether the patient has been given G or GM-CSF. Now these, we know these are very good drugs as far as the case of neutropenia is concerned. But then such cases may develop acute leukemia. Then about the vitamin B12 or folic acid therapy. Now what samples we have to take, because patient will not go for bone marrow aspirate or biopsy every day. Once he comes for the aspirate or biopsy, you should collect the samples for all the possible tests and keep it at a lower temperature in a fridge or whatever the indications are of about the temperature. So what we have is peripheral blood, bone marrow, aspirate and touch imprints. Touch imprints is that you roll the biopsy between two slides and you will get the touch imprints. Stain them with Giemsa, you know, have the morphology. Stain with myeloperoxidase, then you have the MPO stain is available. Then peripheral blood can be used for ancillary studies if bone marrow is inadequate. Why do we insist that there should be bone marrow aspirate available? Because the bone marrow aspirate by and large contains more number of blast cells as compared to the peripheral blood. If in peripheral blood there are 6 blasts, bone marrow may contain 40%, 50%. Then peripheral blood may give an indication of MDS, but the bone marrow aspirate tells us no, it is not MDS, there are 40% blasts. So this is a case of acute leukemia since the blasts are more than 20%. And then we go for extramedullary disease, and then finally what we do is AML, BALL and TLL we have found out on the basis of flow cytometry and immunohistochemistry, and then acute leukemia of ambiguous lineage. For lineage assignment, immunophenotyping is essential. And then we may do conventional and molecular. Now this is the basic difference in a case of AML. What we find is that cases of AML will show us OR rot. OR rot is an indication of malignancy. You will find sometimes OR rots in occasional blast cell in case of MDS. So if you have OR rot demonstration, that means it is a malignant case, whether it is MDS or it is a case of AML. Here you find lymphoblast, this is a myeloblast, and you find the OR rot. Then what we are always doing is a differential on the bone marrow, how many erythroid precursors are present, how many macrophages are present, are they only C blue histocytes, is it a case of CML with C blue histocytes which has gone on to a blast crisis. Of all the cytochemical stains, there are 4 of them. First is the myeloperoxidase, second is non-specific esterase, third is the acid phosphatase. Now of these, the most important one is MPO. If you find cytochemistry MPO positive, it is a case of AML. Even the 2022 classification of AML, they say, WHO says that MPO should be positive, demonstrable either by immunophenotyping or by flow or by the usual cytochemical stain. So that is what all of us are doing in clinical practice. We get the smears, examine the peripheral smear, bone marrow, do MPO and tell them whether it is a MPO positive, that means it is likely to be a case of then we think on the lines that it is either T-ALL or it is the case of B-ALL. Now, how many cells should be positive? Here you find 3 blast cells which are showing the myeloperoxidase positive granules are seen. See, the Sudan black positivity goes hand in hand with the myeloperoxidase. So the cases which are positive on MPO are also positive on Sudan black B. But I must tell you that Sudan black B positivity is also seen in 1 to 3% of the ALL cases also. And also we find that in L3 there are vacuoles in the cytoplasm, and those vacuoles are positive with Sudan black B, also with orange or red O. These are positive cases. Then we have non-specific esterase and then double esterase. Now this is MPO stain. Here we find a case of AML. We find some granules are present in the cytoplasm. This is an OR rod. The moment OR rod is present, we know it is malignant. Okay, and then we find myeloperoxidase stain. You can see these granules positive in the blast cell. Not only that, the OR rods also stain positive, because the OR rods is actually a collection of the MPO positive granules. Then we have, this is a case where we find multiple OR rods in a case of promyelocytic leukemia, phago cells. These are known as sheets of these OR rods, crisscross pattern. You find all the all the promyelocytes are extensively positive. Another stain which we can use instead of MPO is chloroacetate esterase. Now this is a double esterase picture. Double esterase is showing orange colored granules in some cells, and this is showing blue colored granules in some. Chloroacetate esterase stains the myeloperoxidase positive cells. So you can do Sudan black B or MPO or chloroacetate esterase. Now this is a double esterase stain. Double esterase is, this is alpha naphthyl acetate where we are doing non-specific esterase. This is chloroacetate esterase positive, that means it is a myeloid. So if we find both of them are positive, we label these cases as myelomonocytic acute leukemia. Okay? So this is M4 type of acute leukemia. Then we have cases where you find only monocytic leukemia. Now monocytic leukemia, you find blast cells, promonocytes, few monocytes, and see this is non-specific esterase positive. WHO recognizes the importance of non-specific esterase as well, and therefore they have taken that NSC positivity is taken as indication of monocytic differentiation of acute leukemia. Now this is PAS, pyridic acid shift stain, which we do for fungus, and same stain, same fixation in methanol, and you find these case of ALL. And the ALL, what we are finding is, that the cytoplasmic block positivity is seen. Thank you. So this is the block positivity. You find blobs of PS positive material in the lymphoblast. So usually such cells are also CD10 positive and associated with good prognosis. PAS is also very, very useful in cases of M6. M6 is acute erythroid leukemia, where you find the proerythroblasts. Now these are the proerythroblasts with prominent nucleoli, and what you find here is that these cells are negative by and large for every marker except for CD71, CD117 and E-cadherin. These are the positive markers in acute erythroleukemia, but then these are PAS positive. Now this is to differentiate from megaloblastic anemia, because in this country we come across megaloblastic anemia is so common that at times it becomes difficult to differentiate, is it a proerythroblastic leukemia or it is a plain and simple case of megaloblastic anemia. So that is where this stain comes out to be useful if you don't have the other markers available. Sudan black B. Now see, this is a Sudan black B. This is a case of L3 or Burkitt lymphoma leukemia which Sumit showed us today, and here you find that this is positive. Sudan black B is positive in cases of L3. Acid phosphatase. This is uncommonly used, but here when we didn't have the flow, what we used to do was acid phosphatase in a case of ALL, and one would come across this polar positivity, orange colored positivity in cases of TALL. So that was the only method available to differentiate between BALL and TALL. Now this is the FAB classification you are all aware of, M0 to M7, and acute lymphoblastic leukemia L1, L2, L3. This is L1, you find small cells, scant blue cytoplasm, inconspicuous nucleoli, but then you find that most of these cases are PAS positive, and of course these cells are MPO negative. So the first thing is these cells should be MPO negative, only then we think on the lines that it is ALL. This is L2. Now in L2 the size of the cells is same as myeloblast. So on morphology it becomes difficult to differentiate the two. As compared to L1, what we find is that prominent nucleoli are present in L2 which were not prominent in L1. Then you find the variable size, some cells are smaller, some cells are larger, and the nuclear shape you may find that there is a small notch in the nuclei. Sometimes nuclear lobulation is also seen, but all the cells are MPO negative. This is a neutrophil which is positive with MPO. And then we have the L3 where you find Sudan black B positivity, and also you find oil red O positivity is seen, indicating that the vacuoles are because of the fat which is present over there. And this is TALL showing you acid phosphatase. Variants of lymphoblasts, these are uncommon. One is small lymphoblasts. Now it is very important to know age of the patient and detailed clinical history. Sometimes small lymphoblasts are present in the peripheral blood, in the bone marrow, and it looks like that this is a case of CLL. To differentiate CLL from lymphoblasts, we should be aware of the entity small lymphoblasts. Now since we have the markers these days, so you find these cells are CD10, CD34 positive. Then the cells with hand mirror morphology. Now hand mirror morphology does not make the prognosis good or the prognosis poor, but it is just a morphological pattern. And then you find the lymphoblast with granular morphology. The cytoplasm shows coarse big granules. Now it should not be taken that if there are coarse granules it is a case of eosinophils. No, it is not a case of myeloid also. These are all lymphoblasts which are showing us the coarse granules. Then one of the types where you will find that the lymphoblasts are associated with eosinophilic granules or eosinophilia is ALL with associated eosinophilia, which has got a poor prognosis. Then we go on to AML. Now in AML, this is the one where we find 821 in version 16, T911 in version 3. These are the various karyotyping, and PML RARA, KMT2A, these are the mutations which we come across. And then I told you the second one is myelodysplasia related changes, third is therapy related changes, and then the AML based on differentiation, that is M0 to M7. Now what is the AML algorithm to diagnose a case, whether we should say that this is a case of AML or not? If the blasts are more than 20%, Y means yes, it is AML. Blasts are more than or equal to 20%, if they are no, that means the blasts are not 20%, but the blast equivalents are present. Then that means if blast plus blast equivalents are more than 20%, it is AML. Suppose we find that there is a mutation of 821 in version 16, T1517, and the blast and blast equivalents are less than 20%, it is still a case of AML, because these 4 karyotyping or the corresponding mutations like PML RARA, if you find them, the blast percentage is between even 10 to 20%, it is taken as acute leukemia as per the WHO 2022 classification. Now, myeloid sarcoma is equivalent to AML irrespective of the blast percentage in the peripheral blood or in the bone marrow. Now, what are blast equivalents? Now, we are always saying the blast should be more than 20%. So, then what are the blast equivalents? Blast equivalents are the cells which are counted along with the blast cells. Suppose we have a case where there are 15% blast, 5% equivalents. So, what we do is we add the two, 15 plus 5, 20. So, 20% will be taken as a blast cell count, because blast equivalents are counted as blast. So, which are these blast equivalents? These are promonocytes, promyelocytes and erythroblasts. Say for example, promonocytes, these are blast equivalents in M4, M5. Promyelocytes are exclusively in promyelocytic leukemia, and erythroblasts in acute erythroid leukemia. These are the blast equivalents. Therefore, it is very, very important to do 500 cell differential count, because sometimes we are at the borderline. You find the blast cells are 15%, equivalents are 6% or 7%. If you don't count them as blast equivalents, you will land up by saying that it is a case of MDS. But once you add, then it becomes more than 20%, and therefore that becomes a case of acute leukemia. Now, these are the blast equivalents, promonocytes. Now, what are promonocytes? Now, promonocytes are the cells which have got lobulated nuclei and prominent nucleoli. They have the nucleoli as the blast cells have. The only thing is, it is a lobulated nuclei. Now, I will demonstrate to you how do we differentiate it from monocytes then. What about promyelocytes? Now, the promyelocytes may be of M3 type, which is hypergranular, or it may be agranular, what we call as M3 variant, where the nuclei are lobulated, bilobed or buttock shaped. These are also taken as blast equivalents. So, what happens in APML? In APML, the blast cells are usually less than 10%. Blast cells are only 3%, but what we find is that the promyelocytes are 80%, 70%, but then you have to add blast into the promyelocytes, because those are the blast equivalents. And then of course, proerythroblasts in a case of M6, now those are also blast equivalents, so we count them as blasts. So now we have based on the differentiation, AML M0 what it was earlier, now we call it as AML minimally differentiated. That means there is no suggestion that it could be a case of acute myeloid leukemia, except for the fact that these are blast cells, but there is no differentiation, no myelin, no meta, nothing. So that is M0. Then how do we diagnose them? We diagnose when we do the immunohistochemistry or we do the flow. So which are the markers which are present in these cases? Now here you will find the positive are CD34, TDT and CD117 and HLA-DR. Now out of these at least 2 markers are positive. Then why do we say AML? Because at least 2 markers of myeloid series should be positive, like CD13, 33, CD14, 64, 2 markers should be positive, then we label these cases as case of AML. Now this is without maturation, so it looks like again M0. You may find fine azurophilic granules in some of them. Again, since there is no differentiation, 2 markers should be positive, that is cytoplasmic MPO, CD13, CD33, 117, but here you find on cytochemistry, you find that some of the cells are MPO positive, but here more than 90% are blasts in the peripheral smear or in the bone marrow. Now this is AML M2. Now this becomes easy because here you find blast cells, then you find myelocytes, metamyelocytes, polymorphs and promyelocytes, indicating that there is maturation towards the myeloid series. And here you find this is the MPO stain, this is the OR rod, so these blast cells are MPO positive. Then we have the myelomono. In myelomono, we must go by the criteria, that is the blast should be more than 20%, which are out of which more than 3% are MPO positive. Monocytic component is there and the granulocytic component is there. Since both of them are there, so this is what you find. These are the myeloid component, and here you find the monocytic component is present. So here you can do double estrase stain also. Now this is M4, so this is the double estrase stain, myeloid positive, monocytic positive. This is NSC, monocytic positive. This is MPO positive, and these are the blast cells. So in myelomono you have both the components which are positive. Now I told you about the promonocytes. Promonocytes we take as blast equivalents. So here you find these are the promonocytes which have got lobulated nuclei, they have got nucleoli. Now what about these cells? These cells are the monocytes. Monocytes will not have nucleoli. What about the blast cells? Blast cells will have the round to oval nuclei, they will not have the lobulated nuclei. So based on that, these are the monoblasts, these are the promonocytes. And then we have acute monoblastic leukemia, in which we find that more than 80% of the marrow component consists of these blast cells with prominent nucleoli, which are 2 to 4, and this is what the blast cells are seen on a bone marrow trephine biopsy. Now what you find is in monocytic, MPO is negative. So what is positive is non-specific estrase. Then we have M5B. Now in M5B there is a maturation. So we find more of promonocytes and monocytes. So the addition of blast cells plus promonocytes should be more than 20%. So here you find most of the cells are promonocytes with prominent nucleoli lobulated. There is an occasional blast cell. Both of them are NSC positive, and this is on bone marrow trephine biopsy. Erythroleukemia, now the erythroid precursors are more than 80%, but what is the malignant component? Malignant component are the proerythroblasts. So these are the proerythroblasts which you find large cells, basophilic cytoplasm, prominent nucleoli, and multinucleated erythroblasts which are PAS positive. This is the erythroleukemia which we come across. Then we have the M7. Now this is M7 on bone marrow biopsy. You can see these bizarre megakaryoblast and megakaryocytes, and this is on the bone marrow trephine biopsy. This is associated with marrow fibrosis. Because it is associated with marrow fibrosis, when you put in the needle for aspiration, you don't get a good bone marrow aspirate. So what you get is you have to do a bone marrow trephine biopsy. How do we confirm that these blast cells, these are the blast cells, this of course is a megakaryocyte, these blast cells are positive for CD41 or CD61. So you have to do immunohistochemistry on the bone marrow biopsy. This of course is APML, this is variant, these are the multiple OR rods in a case. You find OR rods in variant also. Even if there are no OR rods, if you do MPO stain, you will find all the cells will be positive on MPO stain. And another feature on bone marrow trephine biopsy in MPO variant is that you find eccentric nuclei. And the first look on a low power gives an idea that these are plasma cells, because the nuclei appear eccentric. These are PS positive, and of course all of them are MPO positive. This is the myeloid sarcoma. This was a young man, 25-year-old, who presented with a gum swelling, and what did it show? It showed monomorphic cells. We did all the markers for lymphoma, everything was negative, and finally we did markers for MPO, and see all of them turned out to be positive, indicating that this is a case of myeloid sarcoma. Only then we examined his bone marrow, aspirate was done, the blast cells were 10%. So over a period of 3 months, from 10% these became to 30%. So this was a case of AML. So nowadays we treat all of them as a case of AML. This is granulocytic sarcoma. Now what are the indications for flow? Why do we are doing flow cytometry in each case of acute leukemia? Number one, to know T cell or B cell, because acid phosphatase is not an absolute reliable stain. So we have to know T-ALL or B-ALL because the treatment is entirely different in the two conditions. Then MPAL. MPAL is mixed phenotypic acute leukemia. That means there will be some lymphoblasts, some myeloblasts. What we call as this is a myeloid T cell or myeloid B cell leukemia. Now those cannot be picked up on immunohistochemistry or on stains, so we have to do flow cytometry. Then diagnosis of AML M0, undifferentiated leukemia. Now undifferentiated leukemia is that there is no differentiation towards lymphoid, monocytoid, megakaryoblast or myeloid. So how do we diagnose them? So we put up different markers to see if any one of them turns out to be negative. If none, only then we label it as undifferentiated leukemia, and this has got a very bad prognosis. So then what about the role of immunophenotyping? Now this immunophenotyping we can do, number one, by flow cytometry, which is the most popular method. Second is it can be done even by immunohistochemistry. See, as I told you that the clinicians want to know, first thing, is it AML, is it ALL? And for that immunophenotyping is must. Now everybody does flow, so we also do flow. We are giving them a full report. But then about 10 to 15% of the cases are those where you put in the needle to aspirate, it comes up to be a dry tap. Why is it a dry tap? Because there is a marrow fibrosis or there is a marrow necrosis, so you don't get cells. Since you don't get the cells, you can't tell the clinician whether it is AML or ALL. But now we have the bone marrow trifine biopsy and we have large number of markers available. So what we do is we do immunohistochemistry. Advantage of immunohistochemistry is you can use archived tissue. The architectural and cytological correlation is easy. You know that where is a megakaryocyte, where are the cells present, and then single antibody per slide. That is, suppose I want 6 markers, then you will put MPO on one slide, you will put CD34 on the other, CD is 117 on the next one. So we have different slides. The advantage of flow cytometry is that what we need is a tissue or blood in liquid form. So in liquid form, so the bone marrow should be a fresh sample either in EDTA or heparin, and then you can put multiple antibodies per test. That means suppose the blast cell has got antigens for CD34, CD117, you put in 6 markers or you put in 8 markers depending upon your flow cytometry, whether it is a 10 color or 6 color or 8 color. So both the methods have advantages. Disadvantage here is where there is a dry tap, what will you do? That is a disadvantage of a flow cytometry method. Now we in flow cytometry what we do is that there is a T cell tube, B cell tube, myeloid tube, myelomonotube, cytoplasmic tube. Now of all these, cytoplasmic tube is the most important, because if we find the cells are CD3, CD79A, CD22 are positive or anti-MPO is positive, it confirms the lineage. Okay. If all these are negative, cytoplasmic markers are negative, then we start thinking, is it a case of acute undifferentiated leukemia or not? So the cytoplasmic tube is the most important thing as far as diagnosis is concerned. And then of course we should know, since it is acute leukemia, the progenitor markers like CD34, TDT, HLA-DR, 38, 117, these are the progenitor markers. Then we have the myeloid markers, monocytic markers, erythroid markers and megakaryocytic markers. Now this is just to show you that suppose this is the case, here we find these cells are CD22 positive, 19 positive indicating B, here you find 19 and 10 positive. Now this is immaturity marker CD10, and then we have CD34 is positive, CD10 is positive, so that means we are dealing with a B ALL in which the cells are immature, CD34 and CD10 positive, and then we find that the HLA-DR is positive, but we find 117 and MPO are negative. So the myeloid markers are negative, monocytic markers are negative, CD3 is negative, so we have a case of precursor B ALL. Now similarly, this is a case of here the cytoplasmic MPO is positive, so we label it as a case of AML, and of course these are the positive markers CD34, 117, HLA-DR. So T lineage, B lineage, myeloid lineage. In myeloid lineage we always do myelo-mono. Mono markers are CD14, CD64 and CD36. Now this is to show you MPAL. MPAL I told you is mixed phenotypic acute leukemia. Now this diagnosis is given based on flow cytometry. So here what we are finding is this is the blast clone. Here we find CD33 is positive, 34 positive. 34 positive means it is acute blastic leukemia, but the myeloid markers are positive. 13 is also positive, again myeloid marker positive. CD7 is a lymphoid marker that is positive. CD5 is a lymphoid marker positive. And then we find here the MPO positivity and cytoplasmic CD3. I told you that cytoplasmic MPO is an indication of myeloid lineage. Cytoplasmic CD3 is a indication of T cell lineage. So we have a case which is myeloid and T cell positive. So this is a myeloid and T cell positive. So we call it as mixed phenotypic acute leukemia. Now what about failure of flow cytometry? See, it is not useful for each and every case. Some cases you will find no, it didn't give us a result, or the marrow was diluted, or you find there is a dry tap. So what do we do? In such cases what we do is that we go for, there is a marrow fibrosis, there is extreme hypercellularity or marrow necrosis, so you find that there is a dry tap. So what we do then in these cases is immunohistochemistry. So how do we do it? Now this is a bone marrow biopsy. Now here you see the bone marrow biopsy, there is a marrow necrosis, aspirate was a dry tap. Here again the aspirate was a dry tap because there is fibrosis in the marrow, so you don't get the cells, so you can't put up the flow. Here the cells were so closely packed that aspirate was tried, but the cells were adherent and we could not get the good material. So packed marrow, fibrosis, necrosis, all these factors will lead to a dry tap. So what do we do then? We do the trephine biopsy. We do the trephine biopsy, and then on trephine biopsy we put up various markers, as simple as you are doing for a case of lymphoma. See, here we have put up CD34 positive, TDT positive, 20 negative, PAX5 a B cell marker positive, CD10 is positive, 117 negative, MPO negative. So the myeloid markers are negative, T markers are negative, precursor B ALL. So clinician is happy that we have told them in 3 days that this is a case of precursor B ALL by immunohistochemistry. So wherever you can't do flow for whatever reason, what we can do is immunohistochemistry. Now this is in T ALL, you find CD3 is positive, TDT positive, 99 positive. So the diagnosis is made that it is T ALL. Similarly for AML, you put up the various markers. Now this is monocytic. You find CD68 is positive, which is a monocytic marker. MPO is positive, 117 positive, 34 positive. So it becomes a case of acute monocytic leukemia. Then there is a type hypoplastic, in which the marrow is hypocellular, more of fat, no aspirate. So what do we do is, on biopsy we are looking at these blastoid cells, we confirm it with CD117, CD34. And lastly, role of immunohistochemistry in detection of remission or relapse. So what happens is, you give chemotherapy. At that time the patient was hypercellular, acute leukemia, you gave chemotherapy, the leukemic cells disappear from the marrow. Okay? What happens? Reduced cellularity, hemodiluted aspirate. You want to assess the remission, but it is hemodiluted aspirate. Why? See, this is what happens. These were just, marrow was full of leukemic cells. Now you have given chemotherapy, the cells have disappeared. So what is this pink material? This is gelatinous marrow transformation. So you are looking at gelatinous marrow transformation, but there are no blast cells here. So what are these cells? These are regenerating erythropoiesis, regenerating megakaryopoiesis. See, the leukemic cells disappear, gelatinous marrow transformation comes, and the marrow regeneration starts. If the patient is in remission, this regeneration will increase in no time. So the white cells, hemoglobin, platelets will improve. And the cases, you have done the marrow, what you find in the biopsy? There are clusters of blast cells. On aspirate we didn't find blast cells, which were 3%, but on biopsy we find clusters of blast cells. We confirmed these are CD34 positive, CD10 positive. Patient has not gone into a remission. Rather, the patient didn't respond properly, with the result that there is persistence of blast. So the post-chemotherapy bone marrow, which we do to assess the remission, or in later cases to assess the relapse, that is also very, very important. Not only that, if you find cases on morphology only, that can predict to you what marker to be put up or what molecular test to be done. Say for example, you have a case of M4 with eosinophilia, we know it is due to inversion 16. So you will test for inversion 16. There is no point in doing hundreds of tests. Or there is a monocytic, you will do KMT22A. Similarly, AML morphology, you find megakaryoblast leukemia, then you will go for T122. So depending upon, and then if you find in the blast cells, there is a intranuclear inclusion, a big one like this, that means we are dealing with a case of NPM1 and FLT3 mutation. You need not do any other test. But then what is important is that as a routine now, after cytochemistry, we are doing immunophenotyping. After immunophenotyping, as I told you, we send the sample for cytogenetics, molecular. Okay? So different results you will get. And this is conventional cytogenetics, T1517 in a case of APML. Now what happens in NGS lab? They detect the RNA, DNA mutations separately, and they made a panel. They made a lymphoid panel, they made a monocytic panel, they made a myeloid panel, and see, this is a NGS myeloid panel. See, there are more than 100 mutations which can be detected. Your job is finished. We send the sample, they put the sample into the machine, it separates out the DNA, it separates out the RNA, then one part goes into RNA, another part goes into the DNA, and it checks for various these mutations, and the result comes. Say you will find RUNX1, RARA, PAX5, HMGA2, so all those mutations are being taken care of. But the result is available only after 2 to 4 weeks. So by that time, if the treatment has been proper, you have made the diagnosis after morphology and cytochemistry, the patient would have gone into remission. The only information you tell the patient is that this is a good mutation, so prognosis is good, that's all. Or this mutation is pretty bad, say FLT3 is pretty bad, so the prognosis is bad. But the treatment by and large remains same. So where are these mutations or NGS going to be useful, and when will it become cheaper? The more people go for NGS, more samples are received by the company, you will find that the test will become cheaper. So that is why more and more people are sending, and we are finding that there is some reduction in the rates of these. So these NGS is of diagnostic utility, prognostic utility, therapeutic, and finally for MRD. MRD is minimal residual disease which is left in the bone marrow after giving the chemotherapy or inducing the remission. So MRD, nowadays what we are doing is, suppose we have got a mutation IDH2, and again you find that post chemotherapy IDH2 mutation is still present. That means the disease is persisting. Now what has happened is, earlier there was a single gene era. See, we always said that it is PML rara in a case of APML, that this is the only mutation which can be seen. But now we say that no, this mutation is present, but look for other mutations. There are other 120 mutations. You look out of them, then you find that 4 more mutations are positive. But out of those 4 more mutations, of clinical importance is only 1. So a time will come when we will have drugs which will be targeted against those mutations, then this NGS is going to be useful. As of now, it is giving us some information how to treat such cases and how to go about these cases. So the take home message is that laboratory evaluation of leukemias is very, very important, and morphology, cytochemistry, immunophenotyping, karyotypic analysis should be performed on all cases. Morphology with cytochemistry provides the quickest information. See, what we do is, if we find a case which is APML, promyelocytic leukemia, these cases go on to DIC, they bleed and die. So what we do is, as soon as we find that these cells morphologically are promyelocytes, we do MPO. MPO is positive, or odds are positive. We look for evidence of DIC, inform the clinician immediately that this is a case of APML. So what they do is, they take the sample, keep it for PML rara, but they start therapy. Okay, the therapy for APML is started. That is the advantage of morphology, cytochemistry. Within half an hour, you give the information. NGS will take months for results to come, and that will tell us the prognosis only. So morphology guides us about the cytogenetics and molecular results. Now we are hoping and waiting for that molecular genetic testing will evolve with targeted therapies. Thank you very much. Any questions, comments? If none, thank you very much.
Any questions from the co-chairs?
Actually, there is no question from this side, I think, because the talk was so excellent. It was really, what I was feeling, it was from basic to molecular. Sir have put a lot of emphasis on morphology also, because the residents are here and morphology is very, very important. Whatever molecular testing we are doing nowadays, whatever immunophenotyping we are doing nowadays, but the role of morphology still is there. And Sir put a lot of emphasis on the morphology as well. And there are certain clues also in the morphology which can guide us for further testing, because we are resource poor country. We cannot go for like all kind of molecular testing in every case. So this morphology is very, very important actually. And I think the talk was so good, that is why there's no question from our side, and from the audience, if there is any question, they're most welcome, or they can discuss during lunch hours also, because we are already running short of time, I think. Any question quickly we can go for?
Okay, thank you everybody.
Sir, we are really grateful that Sir accepted our invitation. And I can say for all of us that we enjoyed this elaborative, wonderful session. So please wait for 2 minutes. It is truly an honor and privilege for us to be able to be a part of this session by an idol of knowledge, a man of substance, and a guru for all of us. Thank you so much, sir. Now, I would like to request our respected chairpersons to please present a token of appreciation to Tejinder Singh, sir. Center में A huge round of applause, please. Thank you so much, sir. I would like to invite Dr. Gajendra Yadav, sir, to please come on stage and present mementos to our respected chairpersons. So please present a memento to Dr. Ajeev Sen, sir. Dr. Jyotsna Madan, ma'am. Dr. Jyotsna Madan, ma'am. Dr. Shivani Kalhan, ma'am. Dr. G.N. Verma, sir. Thank you so much.
We thank all the chairs for gracing this occasion and Dr. Gajendra Yadav, sir, for the same. Thank you. Thank you, ma'am. Thank you, ma'am. Before we move on to the next session, I would like to announce a special prize to a person who did the first registration and turned lucky for us. He is an ideal person and an ideal pathologist, Dr. Rajneesh Kalra, sir, and a huge round of applause for him. We always see him as a role model. So, sir is not here, he has to leave a little early, but we will be sending a small token to him very soon. So, thank you, sir, for opening the registrations. Thank you so much. There is a small announcement that we are soon beginning with the poster presentations, which will be at first floor in the same auditorium. So the stairs are just outside the hall. if someone wants to proceed, and whosoever are the presenters, they are requested to kindly reach fast. Next, moving on to the next session, I would like to invite Dr. Tanya on the dais.
Good afternoon, everyone. Myself, Dr. Tanya, welcome you all to our conference. And as we move to our next session, I would like to take this opportunity to invite our esteemed chairpersons, Dr. Meenu Gill, Professor Pathology, Pandit B.D. Sharma, PGIMS Rohtak, and Dr. Sumiti Gupta, Professor Pathology, Pandit B.D. Sharma, PGIMS Rohtak. To please join us on stage. True-cut biopsies are invaluable in breast cancer diagnosis, offering an efficient, accurate, and patient-friendly way to evaluate breast abnormalities. So I would like to invite our respected speaker, Dr. Neeta Khurana ma'am, to kindly take us through the approach to core biopsy of the breast.
Human being above all. So, and she is going to cover a very important topic, that is true-cut biopsy of the breast. She is going to enlighten us on that. So, taking no further time, over to you, ma'am.
Thank you so much, and thank you, Dr. Pooja, and the entire team of HAPPCON for inviting me over here. It's a privilege to share the stage with your teacher and mentor, Dr. Tejendra Singh. I'm really humbled and feel privileged at the same moment. Thank you, sir, for taking us around through the session of acute leukemia, which was a complete overall for us. So, starting with the diagnostic approach, I will be taking a pattern-based approach on the breast core needle biopsy, and what all should we look out for when we are reporting these core needle biopsies, which is there. So, the goal of any biopsy is to provide the right therapy to the right person, but we should know what are the indications of core needle biopsies and who should be doing these core needle biopsies and what is it used for. The core needle biopsy basically has objectives to provide the diagnosis for a plan of further management. So you should be able to guide the surgeon for the further management and oncologist to guide the further management. In case of a mammographically benign lesion, if FNA is inconclusive, you are able to soothe out the patient and you are able to soothe the clinician. There is no hurry to go in for an excision. For confirmation of malignancy before mastectomy, please do not let the patient undergo a mastectomy before the core needle biopsies, because sometimes the reactive atypia with inflammatory conditions may be so pronounced that even as the experienced cytologist, we may be making mistakes. In mammographically malignant lesions, if we are planning neoadjuvant chemotherapy or hormone therapy is planned, then definitely, because you need to assess the hormone receptors and the HER2/neu and to molecularly classify these lesions. So we need to have the additional material which is provided by the core biopsies. And in case there is no associated lesions, but you are only finding microcalcifications, so sometimes you need to go in and do a guided biopsy in areas of microcalcification, even though it has been incidentally diagnosed on a screening mammogram or the screening ultrasound which are being preferred. So I always say that start for the journey of diagnosis, and no journey begins without the patient. So most important for any diagnosis is the clinical examination and history. What kind of lump is there, whether there is a nipple discharge or not, whether overlying skin is involved or not, how long it has been there, whether there is a history of rapid increase in size or not, because these are some of the features which will give you the confidence of giving out a report as a pathologist. So a pathologist is good as his confidence is. So know the imaging findings for an effective clinico-radiological and pathological correlation. That is absolutely a must. Choose the right true-cut needle if you are going to do it yourself, because in many centers pathologists are doing it, in some centers radiologists are doing it, in our centers surgeons are doing it. So the importance is not the degree, not in which specialization you have specialized in, but whether you have the skill to do it and whether you have mastered the skill with the right kind of needle or not. The other important thing to remember is to preserve the specimen properly. Follow the guidelines for preservation of specimens so that the pre-analytical variables for testing of further hormone receptors is taken care of. The fixation cold time, which is the time after taking the biopsy, putting it into the buffered formalin, should be within an hour. You should not delay it more than an hour, because then your receptor status will not be standardized or within the reporting time. The total fixation time should also not exceed more than 72 hours, and even though the patient is in a hurry, 3 baje biopsy kara hai, you are trying to put the sample in formalin and for 1 hour only, and you are trying to put it in the automatic processor, you know it will not be there for 6 hours in the formalin, even in your automatic tissue processor. Wait, 1 more day will not harm it, but you will be able to get it. Ideally, all specimens should be radiographed to find out whether the microcalcific areas, they have been taken up or not. But even if you don't have it, at least process all the cores. You have multiple cores, 6 cores, 8 cores. Don't make a single block, because multiple blocks will give you multiple cores in different sections, and you will be able to do multiple testing in all those cores. So make multiple cores. So as I told initially, it would be a pattern-based approach. So what are we looking at the pattern? Let's start with the simplest of the pattern. There is duct, there is stroma, and both are benign. So you are seeing the simple normal duct, terminal duct alveolar units, lobular units. So this is what you would be seeing it. So here one can see the normal lobule which is there formed of the acini, and these acini would have the luminal cells and the basal cells. I think this is okay. Fine. So you should be able to see the luminal cells as well as the abluminal cells, also called as the myoepithelial cells or the basal cells, and be able to identify morphologically that these are present, because that way you will avoid unnecessary markers being done on all these things. So find out whether it is a normal terminal duct lobular unit or there are variations in these terminal duct lobular units. Sometimes rather than the myoepithelial cells being compressed as the peripherally compressed nuclei, you may see the vacuolated cytoplasm of the myoepithelial cells. So no, it is a normal variation of the myoepithelial cells which can be present in many biopsies. So you can see the luminal epithelial cells with dense eosinophilic cytoplasm and the myoepithelial cell layer with the clear cytoplasm. So whether compressed or present with the clear cytoplasm, these are the most comforting cells in any breast biopsies. So one should be aware of that. And in this condition, in this true cut course, we are only seeing the interlobular fibrosis. The lobules have been compressed, the epithelial and myoepithelial cells are all present. So ducts and stroma both benign, and we are comfortable calling it. What about this? More number of acini. So more number of ductular structures, but intraluminal cells as well as the abluminal myoepithelial cells or basal cells, they are all present in all of these. Fine. So simple area of adenosis. So features of adenosis. Sometimes we can see these cells which have abundant dense eosinophilic cytoplasm with presence of secretions inside them and the presence of these snouting of the apocrine of these cells. So these are the areas of apocrine metaplasia, cystic dilatation of the ducts, blunt duct adenosis which we used to call it before, and these are the very comforting cells. You know these are all benign, and one can easily report it out as the benign fibroepithelial lesions, could be fibrocystic disease or anything. Be very careful when you are looking at the apocrine metaplasia using the terms, because you should be able to see the dense granular eosinophilic cytoplasm apart from the eosinophilic snouts and the secretions which are present in them, because this is apocrine metaplasia. Why I insisted on giving the description of the dense granular eosinophilic cytoplasm is because that is distinctly lacking in this ductules. We can see these apocrine snouts very clearly. We can see the secretions, but we are not seeing the dense granular eosinophilic cytoplasm, so this is not apocrine metaplasia. Over here, the similar appearance that you are seeing over on the left hand side is seen with areas of microcalcification. So what is it? Look at the nuclei. The nuclei are all perpendicular to the basement membrane. Myoepithelial cells are still present at the periphery as compressed nuclei, dark staining nuclei at the periphery which we can all see. So this columnar appearance of the nuclei which you can see over here is a feature which is characteristically grouped under the features of the columnar cell lesions of the breast, a precursor lesions for development of the infiltrating ductal carcinomas, and over here one can see that there is occurrence of microcalcifications even in the columnar cell lesions. So the columnar cell lesions form a spectrum. This is the earliest one which we call as a columnar cell lesion, And when you have increased number of nuclei, increased number of stratification, but the perpendicular appearance of the nuclei is still maintained without any atypia, this is columnar cell hyperplasia. And when you see the rounding up of the nuclei, though apocrine snouts may be present focally, this is columnar cell hyperplasia with atypia. So this is the one which will further go up and become a flat epithelial atypia, which we all know is a precursor lesion for development of infiltrating duct carcinomas and would be the precursor lesion for infiltrating carcinomas. Here one can see the columnar cell lesion with atypia forming these Roman bridges and developing into ductal carcinomas in situ, which it could be associated with. So apart from the ductal carcinomas in situ, the columnar cell lesions may also be associated with invasive lobular carcinomas, especially the low-grade invasive lobular carcinomas and invasive tubular carcinomas which may be seen. So flat epithelial atypia developing from the columnar cell lesions, so that would go and intermingle into it. So what should you do, and what is the guideline for the surgeon to do it when you diagnose a columnar cell lesion with hyperplasia or with atypia on core biopsy? As of now, there are no specific guidelines if there is no associated malignant lesion found on the core needle biopsy. Only wait and watch, screening mammography and self-palpation. If there is a palpable lesion, the patient is anxious, you may go in for a local simple excision and look out for whether it goes on to further any associated other lesion is present or not. Or you may do a guided biopsy from a more solid area or a more denser areas to find out if there is any associated lesion. If not, it is only a wait and watch policy which has been described as now. So coming on to the second pattern, in which the normal duct lobular unit, rather than having 1 or 2 cell layers, we are having intraductal proliferations. So all the cells are proliferating and expanding, coming into the lumina of the ducts, as well as a result the lumina are all appearing filled up. These are the filled up luminas which cause us the maximum anxiety when we are signing out as the signing pathologist, because we know the spectrum of lesions which can be seen with intraductal proliferations are huge. The columnar cell hyperplasia with atypia, usual ductal hyperplasia, atypical ductal hyperplasia, ductal carcinomas in situ, lobular carcinomas in situ, and if you can see the papillary course, whether we are dealing with intraductal papillary lesions. So if you are seeing the papillary course, guidelines are simple: excise all papillary lesions of the breast, as are the guidelines in, for the cytology also. But most important is, we want to know whether it is severe usual ductal hyperplasia or a marked usual ductal hyperplasia or an atypical ductal hyperplasia which is there. And for those ones, these are the morphological features you should be looking at. Clear-cut rounded appearance of these lumina present in the center of these ducts, as if you have used a cutter to cut the cookies. बिस्किट्स बनाने के लिए जो आप कुकी कटर यूज करते हो, अगर आप वैसे ही गोल गोल राउंड राउंड देख रहे हो, so this is not biscuit, this is more dangerous, this is the atypical ductal hyperplasia. While when you are seeing this small slit like oval appearance and present both in the center as well as the periphery, majority at the periphery, you are looking at the usual ductal hyperplasia. In usual ductal hyperplasia, both epithelial cells as well as myoepithelial cells will proliferate. While in atypical ductal hyperplasia, it is only the luminal cells will be proliferating, unless it is a basal type of DCIS, when the basal cells will be proliferating. So in this you can see very carefully that the myoepithelial cells are preserved only at the periphery. Center mein there are no myoepithelial cells, while in this the myoepithelial cells will be present. How else do we differentiate? Look at the two type of nuclei which would be present. The other indicator is these cell nuclei in usual ductal hyperplasia, they stream along the lumina. Lumina के साथ साथ घूम रहे होते हैं ये nuclei, while in this they are perpendicular to the lumina. So this is the one which gives you a very characteristic morphological feature of atypical ductal hyperplasia over here and usual ductal hyperplasia over here. What if I am not confident whether myoepithelial cells are present or not? Go ahead, do your immunohistochemistry, and myoepithelial cells markers would be present in the center of all these lesions of usual ductal hyperplasia, along with the luminal immunohistochemical markers of cytokeratin 19, and the myoepithelial markers being S100, glial fibrillary acidic protein, smooth muscle actin, smooth muscle myosin, heavy chain, You can even use the nuclear marker P63, which is a very excellent myoepithelial marker. So those are the markers, lots of them in the kitty. You may use 1 or 2, minimum 2 should be used to find out whether they are absent or not. And in atypical ductal hyperplasia, you will find them only at the periphery. While in usual ductal hyperplasia, they will be center. So does IHC help? In low-grade morphology, you need to do it many a times because you are not sure whether it is atypical or usual ductal hyperplasia. In high-grade morphology, it becomes easier because we have been taught since our 3rd semester, look for anaplasia, high nucleocytoplasmic ratio, mitosis, necrosis. So that is easier. But in case you are not, then even the basal cell marker cytokeratin 5-6 positivity and patchy ER positivity would be seen in usual ductal hyperplasia, while cytokeratin 5-6 negativity and strong ER positivity is seen in ADH and DCIS. There is no difference in the morphology of ADH and DCIS. It is the extent of the lesion which makes it ADH, atypical ductal hyperplasia, less than 2 millimeter or less than 2 complete ducts involved, or more than 2 millimeter or more than 2 complete ducts involved, which when you call it DCIS. So morphologically there is no difference, and in high grade one it is different. Is immunohistochemistry always helpful? Yes, it is a friend if you use it very carefully, but remember apocrine lesions are ER negative. So even both benign and malignant apocrine lesions, you will have to still go in for nuclear morphology. They will be positive for androgen receptors but not for estrogen receptors. Columnar cell lesions, though benign columnar cell lesion, columnar cell hyperplasia, will be strongly ER positive similar to ADH and not like the usual ductal hyperplasia. Basal like DCIS will be CK5-6 positive even in the center, and ER would be negative, and normal luminal epithelial cells will be CK5-6 negative, only the basal cells would be positive, so luminal cell marker is not there. So ADH or DCIS, high grade morphology, high nuclear variation in the nuclear size, central breakdown with necrosis, कोई मुश्किल काम नहीं है, दो complete ducts involved हैं, lobules involved हैं, तो you call it. If it is a low grade one, then lobular carcinoma in situ has to be distinguished, and there you can take the help of E-cadherin and P120 markers, which would be positive. E-cadherin would be positive in the ductal carcinomas in situ, while E-cadherin loss would be there in lobular carcinomas in situ. So, what about this? Nice ductal carcinomas in situ. Very good, we are finding it. How do I differentiate it between the invasive cribriform carcinomas, which will give you a similar appearance, versus cribriform carcinoma in situ? In cribriform carcinoma in situ, because again the invasive pattern would look cribriform only, in cribriform carcinoma in situ, the myoepithelial, the basal cell markers would be present at the periphery, while they would be lost if it is an infiltrating cribriform carcinoma. So low grade infiltrating cribriform carcinoma would be there. The other place where you might have difficulties with, should I call it DCIS or should I call it microinvasive carcinomas, both can show necrosis. Central areas of punctate or comedonecrosis can be seen in DCIS also. So look out for these areas of breach of basement membrane at the periphery and presence of the inflammatory cells at the periphery, or go ahead and do the myoepithelial markers. And here one can see that the P63 is nicely positive all around the center. So this is a focus of the ductal carcinoma in situ, while it is lost in the infiltrative foci. So there will be loss of the basal cells in the infiltrative foci. So how do I report? I have got the biopsy, I have determined it is DCIS. So how do I report? Do multi-level sectioning, exclude frank or micro-invasive foci, report on the nuclear grade, report on the architectural type, whether it is solid, micropapillaries, flat clinging type or cribriform type, look for presence of necrosis, comedo or punctate, and document microcalcification if seen, which is present or not. Now this is a nice lobule, completely solidly filled. Lobular neoplasm or cancerization of lobule by ductal carcinoma in situ, low grade type. Difficult? Yes, we all face these difficulties when we are signing out. E-cadherin comes to your help, as well as the surrounding areas. If there are invasion, look out for the infiltrating areas with the India file pattern, which gives you a large amount of it. So cancerization of the lobule can occur with ductal carcinomas, as well as, or one can show a great resemblance to the lobular neoplasia. In the high grade morphology where you are seeing it over here, it becomes easier. In the low grade morphology, do E-cadherin, loss of E-cadherin would be there, and if E-cadherin is not completely lost, it is partially coming positive, you don't know whether to call it completely positive because partial loss is there. It could be because of a truncated mutation of E-cadherin. So remember, the mutation could be a complete loss of function mutation or it could be a truncated mutation. In that condition, use P120, which will come to your help, because that is another marker which can help you distinguish between lobular versus ductal neoplasias. So lesions which may be upgraded. So when you are writing down, sending out a report of DCIS, make sure the surgeon understands your language, that we are speaking the same language, and he should know that the ADH, lobular neoplasias, flat epithelial lesions, flat epithelial atypia and papillary lesions may be upgraded. If you don't speak the same language, please make down a note so that the patient is not managed only on that. He should reassess the patient. Clinical examination is clinically important. Coming on to the third pattern, benign appearing, low nuclear grade, small glandular proliferations, no stroma seen. All diffuse sheets, but all small glands which are present everywhere, a few large ductules, but majority of them are showing a low nuclear grade, benign or malignant. Fine. So the benign is when you see the myoepithelial cells. So confirm the luminal darkly staining cells and the abluminal myoepithelial cells. Your eyes are good enough, you have trained yourself, you don't need to do a myoepithelial marker. So it could very well be a true cut biopsy from a tubular adenoma or a tubular adenosis or an adenosis tumor, which are the various terms which have been using for it. So which would show minimal stroma, a variant of fibroadenoma, but will look exactly like this. So confirm the epithelial and myoepithelial cells. If you are not sure, go ahead and do the luminal epithelial markers as well as the myoepithelial markers to confirm and satisfy yourself. Now this one, I can see only one cell type, but again small glandular proliferation, small nuclei, scanty, occasional cell showing conspicuous nucleolus, looks all benign. But there is no myoepithelial cell. Even on marker, I could not find any myoepithelial cells. Could there be any benign lesions without myoepithelial cells? Yes, there could be microglandular adenosis, and these cells would be positive for S100. So they are benign, but there are no myoepithelial cells. So generalizations can be faulty and exceptions do prove the rule. So look out for those exceptions. So this was another true cut where we got all these glandular proliferations, but there were these glandular proliferations abutting onto each other, and at places large areas of solid proliferations with small glands over here, which one can see over here. Luminal cells are barely visible, but more are the abluminal cells visible. So am I seeing more of myoepithelial cells than epithelial cells? अभी तक तो यही सिखाया कि एक myoepithelial cell layer होगी. Sometimes there can be myoepithelial proliferation more than the epithelial proliferations, and in such conditions, think of adenomyoepithelial hyperplasia, benign adenomyoepithelioma. Look for cytological features of malignancy with hyperchromasia, atypia, mitosis, necrosis, infiltrating borders clinically and radiologically. It could be a malignant adenomyoepithelioma. So not always myoepithelial cells would be comforting cells, so it has to be in combination with the clinical findings. How many myoepithelial markers should we do? I told you a variety of myoepithelial markers. So it is recommended in the literature that minimum of 2 myoepithelial markers should be done before you say it is not positive. And choose the myoepithelial marker which you are more comfortable with. Try to choose the myoepithelial markers. I personally like the nuclear markers which give me a crisp positivity, like the P63, rather than the smooth muscle actin and the S100, which give me more of a cytoplasmic positivity, especially in cases when the myoepithelial cells are more compressed. So at least 2 myoepithelial markers should be looked. So to summarizing, benign appearing, low nuclear grade, small glandular proliferations without stroma, adenosis, tubular adenoma, adenomyoepithelioma, microglandular adenosis and collagenous spherulosis. The flip side is 2 malignant lesions which have a low nuclear grade. Adenoid cystic carcinoma with a cribriform pattern, and the tubular variant of lobular carcinomas, which will show you one. So tubular variant of lobular carcinomas, easy, E-cadherin would be of help. So again, clinical appearance, what is the size of the lump, infiltrating borders or not, myoepithelial cells present or not, and in adenoid cystic carcinomas, myoepithelial cells would still be present. So if you are looking at the pattern which makes you think that this is looking like a salivary gland tumor, ultimately breast is also an adenexa. So go ahead and do CD117. So MIP positivity, CD117 in adenoid cystic carcinomas will come to your rescue. So a great deal of your suspicion at that particular time, which will help you. So let's move on to the next morphological pattern, benign glands and benign stroma, but the architecture is altered. Yes, simplest, UG level पे भी सिखाते रहते हैं, दिखाते रहते हैं. This is the usual garden variety fibroadenoma, which we are seeing compressed ducts or maintained ductular structures, and a normocellular fibrous stroma at the background with fibrous tissue over there, scanty tiny nuclei of the fibroblastic cells. We are happy calling it a fibroepithelial lesion, possibly a fibroadenoma. Now this also a true cut course, and both these true cut cores are giving me these benign ducts, some present in the center, occasional in the center, but more of it is stroma, and the stromal cellularity is increased, and the glands, the epithelial cells are present only at majority at the periphery. So with increased cellularity of the stroma, when you are seeing fewer of the glands, think of phylloids tumor, and this is what happens when you do a true cut biopsy of a phylloids tumor, a classical leaf-like pattern. They all break down, and you will be able to see the cores with epithelial cells only at the periphery, and we keep seeing the center of the cores going into the high par, missing out on the 4x appearance. So the 4x, the scanner appearance, is the one which will help you know that the epithelial cells, these compressed epithelial cells, are present in the cores and give you a morphology. Look out for stromal atypia, mitosis, necrosis, and classify them as benign, borderline, or malignant, being less than 4 mitosis, per 10 high power field 4 to 8, or more than 8 mitosis per high power field for malignant phylloids tumor. So all these were fibroepithelial lesions. When to recommend excision? If you feel the cellular stroma is there in all the cores with features of fibroadenoma, even then go in for excision biopsy, because there could be areas where you are missing the mitosis, especially the low-grade stromal sarcomas, which may mimic clinically like fibroadenomas. Fine. Half of the cores have only cellular stroma. Stromal mitosis is there with increased cellularity, though the glands are appearing benign and you are not seeing much of the atypia. The lesion is irregular on imaging, even though there is only focal stromal mitosis, and you still can't find mitosis. Focal stromal hypercellularity, but you are not able to find mitosis. Comfort them, because the features which favor benign phylloids are the fragmented cores, as I have told you, and the periphery of the cores has stretched out epithelium with myoepithelial cells still preserved, and they would also be all stretched out. So look very carefully that majority of the cores with cellular stroma are there with or without the epithelium and a history of rapid growth and large size. Another true cut core, lobules hai. Stroma is coming more fibrous than adipose tissue, but some of these lobules are becoming large and hypercellular, more busy. This is showing area of adenosis, but there are more cells over here. Are these infiltrating small glands into the stromas? So have I gone the true cut at the edge of the malignant tumor? Are these all the malignant cells which are infiltrating into the stroma? We can see the fibrous tissue is compressing these glands, and as we are moving towards the periphery of the lobule, we are getting the opened up glands. So this is the classical appearance that you would see in sclerosing adenosis. Myoepithelial cells, though compressed, will be present, and if need be, go in and do the myoepithelial cell markers. So that was about the benign with altered stroma. Malignant cells and benign stroma, the easiest which we keep on reporting, clinically bhi, mammographically bhi, we have seen the SS. Most of our patients are coming late, so we are able to make the diagnosis. So I will, sorry. So whether the ductular structures are preserved and the duct formation is there. So TNM, tubule necrosis, tubule nuclear pleomorphism and mitosis, this is how I try to remember it and try to grade them as grade 1, grade 2 and grade 3 depending upon the score that you give, or look out for the India file pattern for the invasive lobular carcinomas. So no specific type or specific type, any specific type more than 90% should be there to call it a specific type. So in true cut generally we don't call any specific type. We call it with mucinous areas, we call it with cribriform areas, we call it with tubular areas, because we have not seen the entire tumor. So specific types are generally not. This we have said cribriform growth pattern in situ or invasive, so look for the myoepithelial cell layer. What when there is a serous carcinoma? Very hard, dense fibrous tissue, and all these ducts have become so compressed that you cannot see the lumina at all. So in this case, E-cadherin will help you, whether it is a pleomorphic lobular carcinoma or it is a low-grade ductal carcinoma which is infiltrating the breast tissue, and or there are classical lobular type A and type B cells which will give you this appearance. So that will be there. So for the postgraduates who are still present and have not gone for the things, so this is how we generally try to report out our cases. 43-year-old female, 2 centimeter breast lump, true cut course, infiltrating duct carcinoma, NST grade 1, ERPR showing 85% positivity, HER2 new is negative, Ki67 4%. So try to give a molecular surrogate classification, so this will fit into the luminal A subtype, we will all agree with that. Fine. So though the latest classification, though the latest criteria of CAP guidelines for ER-PR positivity is even 1% cells being positive for ER and PR should be called as positive. Previously we used to do the L-rate scoring and all, which is still going on in many centers, but one should know that the latest guidelines for hormone therapy is just 1% ER and PR positivity. So look out for additional features of periductal elastosis, intratumoral fibrosis, 54-year-old lady with a 3 centimeter breast lump. ER-PR was positive only 15%, but Ki67 was very high, 34%, and there was HER2 new positivity. Should we call it only HER2 new positive or should we score it? Now in the era when we are looking at HER2 low and ultra low tumors for which antibody drug conjugates have come, I think we should start giving our reports as whether less than 10% of the cells positive, 0 cells positive, more than 10% weak or moderate incomplete positivity, or it is showing a score 3 full complete positivity, so that the patient is able to get a report and is able go for a reflex fish or a CISH for HER2 new. So based on that, it would be a HER2 positive if the fish is also positive. If the fish is negative but the score is 2, we call it a low HER2, and the patient is eligible for the antibody drug conjugate therapy, not for the trastuzumab, but because the payload chemotherapy is given along with the antibody conjugate. So go ahead and doing it. Yes, this is what the grade 3, the highest score looks like, and we know that this would be easily said to be positive and you don't need to do it. So just to summarize, what is the molecular classification and IHC approximations? Luminal A with low Ki67 of less than 14%, ER and PR positive, HER2 negative. Luminal B may be ER positive, maybe HER2 positive, may not be HER2 positive, so it may be HER2 negative. So rather than putting them as HER2 negative, let us start scoring them and giving them as score 0, 1, ultra low or low, and with a high Ki67 index, HER2 rich, which when ER and PR are both negative, and call them basal like when they are triple negative with basal markers positive, which would be CK56 and EGFR positivity. Because all triple negative cancers are not basal like. So if you have facility for doing the basal like markers, please go ahead and do EGFR, and CK56 would be there. So provide as much possible and predictive information, prognostic and predictive information as possible on the TrueCut, giving the type, the grade, the mitotic index. I report LVI and PNI positivity, nerve infiltration and lymphovascular invasion only if I see them. If I don't see them, I don't give the negative report because I don't know how my surgeon is going to interpret it. Because that would be seen in the big tumor only. In TrueCut, it may not be seen. Tumor infiltrating lymphocytes and doing a PD1 and PDL1 is a new thing for immunotherapy patients, especially in the metastatic breast cancers. So do give that information because the patients would benefit from that. Adipocytic infiltration and the extent of adipocytic infiltration also gives you the prognosis. Necrosis and receptor status are the must to be given. So choose the right block, be aware that there could be a 2% to 25% discordance in ER and PR positivity rate in the literature which has been described, and up to 33% discordance rate in HER2 positivity in the various sites of the tumor, from primary tumor, metastatic tumor, and in the lymph node metastasis also. So should we repeat it? Yes, if they are negative, definitely repeat it because the patient gets a chance to get these therapies, because they are therapy dependent. If it is positive, you may still not repeat it, but any negative, I would like to repeat it in the main tumor when it comes later on, whether pre or post chemotherapy, I get it. Triple negative breast cancer, do I still need to look at morphology, or all triple negative breast cancers are high grade cancers? No, there are certain low grade cancers like adenoid cystic carcinomas and secretory carcinomas which are low grade but are still triple negative, apart from the known high grade carcinomas which are all triple negative. So morphology still does not take a back seat. Seedha IHC will not help you out. Going on to the sixth pattern. Diffuse large nests of monomorphic or minimally pleomorphic cells, no stroma seen, and you definitely know it is malignant, and classically we try to associate these ones with invasive lobular carcinomas. We are very happy that they are low grade or minimally pleomorphic cells, could be a pleomorphic lobular and invasive lobular carcinomas, but look at the nuclear features. Are there stippled nuclei? Because the low grade The small cell neuroendocrine carcinomas in the diffuse areas, in the infiltrating areas, may not show the classical nesting pattern or the trabecular pattern of the neuroendocrine type. So the nuclear morphological details of the stippled nuclear salt and pepper morphology should make you go in for the neuroendocrine markers, because all neuroendocrine markers tumors are high grade carcinomas irrespective of their morphological type. And they would receive a different chemotherapy than the usual ductal carcinomas which you are getting in. Never ever miss out on having a high suspicion for non-Hodgkin's lymphoma and granulocytic sarcomas. They look suspiciously alike. The indicator cells for granulocytic sarcomas are the presence of eosinophilic precursors, especially the eosinophilic myelocytes and metamyelocytes, which may be scattered along with these, especially the M4 type with eosinophilia. So that gives you a clue, and then you can go in and do the markers, because they will all come out to be triple negative. It's easy to call it invasive carcinoma triple negative, but they will all be triple negative, so a high index of suspicion is required for these to be able to diagnose them and do the markers which have been taught to us in the morning by Dr. Sumit and Dr. T. Singh sir over here. So for the lymphomas and the leukemias. Seventh pattern, diffuse sheets of anaplastic cells, definitely malignant, no stroma. Pleomorphic invasive lobular carcinomas is not excluded. High-grade infiltrating duct carcinomas is our instinct, we report them out. Large cell neuroendocrine carcinomas to be considered based on the nuclear morphology. Look out if there is any pigment, because rarely one may miss out on the malignant melanomas which may be primary or metastatic to the breast, or there are other metastatic tumors to the breast. So generally we don't consider metastasis coming to the breast, but that should be on a high index of suspicion to the breast also. And of course the anaplastic NHL and the histiocytic lymphomas amongst the hematolymphoid malignancies, which would also appear similar. So when you are calling them as triple negative and you are not doing the epithelial marker to confirm whether it is a carcinoma or not, we may be missing out on some other tumors. Eighth pattern, benign duct malignant stroma, easy, because we are seeing the classical leaf-like pattern, periductal stromal hypercellularity, and go into the high power and look for mitosis and atypia, and this would be a cystosarcoma phylloid. This is the first one. Clinical picture. Is this tumor located deep into the breast, or it is on the surface of the breast? Because soft tissue sarcomas occurring deep into the breast will also, or on the surface, will entrap the benign lobules at the invasive margin, and those should be the pitfalls in diagnosis. You can't help it. You will commit the same, I'll commit the same mistake again and again, because if this picture comes, we would be doing all the same. The pericanalicular duct pattern with stromal mitosis and mild pleomorphism, keep in mind the low-grade stromal sarcomas which may look like this. So that was one easy pattern which was to diagnose. And this is another easy pattern, malignant duct and malignant stroma. Instinctively we all know it is a metaplastic carcinoma, but is metaplastic carcinoma one thing? No, WHO has given us so many types of metaplastic carcinomas. So let's try to further find out what type of metaplastic carcinoma. Right from the squamous cell carcinomas, squamous cell areas in the high-grade ductal carcinomas, spindle cell carcinomas, or carcinomas with matrix formation, the mesenchymal differentiation with either osteosarcomatous or chondrosarcomatous differentiation, rarely angiosarcomatous differentiation, and uncommonly the liposarcomatous differentiation may also be seen. Those are easy, because they are all coming under the high-grade metaplastic carcinomas. The difficult ones are the lower ones when we are looking at the low-grade adenosquamous carcinomas, and most difficult is the fibromatosis like metaplastic carcinomas, which is which has an extremely low-grade morphology, very scant mitosis, hardly any atypia, and looks like fibromatosis, because fibromatosis can also occur in the breast like an extra-abdominal desmoid tumor. It's not that breast is averse to having fibromatosis or desmoid tumor. So look out for whether it is a pure pattern or mixed pattern. Fibromatosis, yes, if you are thinking, do a beta-catenin, nuclear beta-catenin positivity would be there in fibromatosis along with CD34 positivity. In metaplastic carcinomas, all being basal carcinomas, you can take the help of P63, CK14 and CK56. So P63, apart from being the myoepithelial marker and the basal cell marker, is also used over in diagnosis of the metaplastic carcinomas. We should keep it in mind. So use it as per what you think you are going to interpret it for. So the 10th pattern, benign looking spindle cell stroma only. Maybe it is only the interlobular fibrosis, comforting one, and there is nothing else. or you are looking at vascular channels which are being formed in these fibrous areas, a pseudoangiomatous stromal hyperplasia, but the endothelial markers would be negative, CD34 and 34 would be negative, only vimentin would be positive. So still okay, you are making it benign, no harm done. Central fibroelastosis of radial scar, difficult because it could be a preneoplastic. Stromal overgrowth of benign phylloids, you have not got any other thing except spindle cell stroma. So a repeat true cuts in these cases would be required, and the most dangerous to miss is the central acellular carcinomas which would be there. Because rest all are still okay, and if it is a repeat biopsy in a tumor bed in a post-chemotherapy patients, it would indicate, give you the response to chemotherapy and whether further cycles of chemotherapy is to be given or not. This is what the central acellular carcinomas look like. Central area of fibrosis, and remember getting the true cut only from the central core and malignant cells only at the periphery. This occurs because the tumor has overgrown its blood supply, central area has gone necrosis, and that necrosis has healed by fibrosis. So these are called as the fibrous scars which are present in the tumor, and there could be central large scars which could be there, and more than 1 millimeter of these fibrous scars do have a prognostic implication. Here we are seeing elastosis, over here the dense pink fibrillary material and intratumoral fibrosis which is present. Cores of malignant spindle cells, we all know how to identify the malignant spindle cells, high nuclear grade, nucleocytoplasmic ratio, easy to say, malignancy hai, spindle cell malignancy hai, but is it a deep seated lesion in the mammary parenchyma? Yes. Metaplastic carcinoma, cystosarcoma phylloids, and soft tissue sarcoma of chest wall which have come, which are the benign spindle cell, whether it is a fibrosarcoma or a leiomyosarcoma or a new peripheral malignant nerve sheath tumors, which would all come like malignant spindle cells which would be there, and you are only getting the spindle cells. While P63 would be positive in the metaplastic carcinomas, you may need to repeat biopsy for looking at the benign epithelial component in cystosarcoma phylloides, but ultimately it's benign, so go ahead and report it that it may be possibly a spindle cell component of a malignant sarcoma phylloides, because the treatment would be similar. It would be a mastectomy, simple mastectomy which would be done. If it is a superficial lesion, adherent to the skin, ulcerating through the skin, rule out whether you are looking at the spindle cell squamous cell carcinoma or a spindle cell melanoma. So these are the ones which would require your immunohistochemical markers and looking for keratinization or looking for pigment, and the melanoma markers, the melan A and the HMB45. Stroma with matrix, as I have told you, chondrosarcomatous stroma easy to find, and the osteosarcomatous stroma. Again, heterologous differentiation in cystosarcoma phylloides can occur both chondrosarcomatous and osteosarcomatous areas. So first differential comes as heterologous sarcomatous areas of cystosarcoma phylloides, even if you are not seeing the benign epithelial component. The other next is the matrix producing metaplastic carcinomas. Next is look out for your x-rays, look out for the clinical appearance, whether it is a chest wall chondrosarcoma or osteosarcoma arising from the ribs, or rarely we may have an extraskeletal chondro or osteosarcomas which can occur in any other soft tissues, and so they can occur in the breast. Very uncommonly there are chest wall hamartomas which can show chondroid areas as well as aneurysmal bone cyst like areas, but they are extremely uncommon and one is not expected to make those diagnoses on true cut biopsies. So one uske liye maafi manzoor hai. So 13th pattern, only mucin and mucin predominant cores with few cells scattered around, looking very benign, low monomorphic, hardly any nuclear atypia or mitosis. Because we know colloid carcinomas don't show much of atypia and mitosis, so do not consider them as benign ones. Though they look benign, they will lack the myoepithelial cells, so it would be a colloid carcinomas and invasive colloid carcinomas. But look out for these micropapillary areas. If there are these micropapillary areas or atypia despite being in the colloid background, the colloid carcinoma does not have as good a prognosis as it is known to have if these micropapillary pattern or in anaplasia is available. So look for IDC component, it may be part of the no specific type infiltrating duct carcinoma. Pure mucinous carcinoma has a round circumscribed mass on imaging, so be confident in asking for that and look out for those features. Mucocele may have ruptured, so keep an eye on that, whether it is only a ruptured mucocele that I am seeing and there is an irregular mass because of fibrosis and inflammation, which would be reported as Birad's 4 on mammography. and on ultrasound it will be an irregular mass. So mucinous carcinomas generally lack atypia, but they are strongly ER and PR positive. If they are not ER and PR positive, go ahead and repeat. Maybe your stain is not standardized or it is not a mucinous carcinoma. So this is a slide from the mucocele of the breast which had ruptured, and there is inflammation in the surrounding areas and in the surrounding lobules. So which could be there. Sometimes you can have a granulomatous inflammation. Of course, tuberculosis is not unknown in India. We can have tubercular mastitis also, apart from the breast abscesses and all which can occur. Only necrotic tissue, no opinion possible. This is what we sign it out majority of the times. Kindly repeat. But let's go back to the basics and think of what we teach our undergraduate students in the 3rd semester in our 1st and 2nd class. What is the type of necrosis? Is it a liquefactive necrosis mixed with neutrophils? Am I looking at only at the breast abscess? Is it a coagulative tumor necrosis? Say it is highly suspicious of malignancy, though no viable tumor cells are seen. Please repeat biopsy so that the patient does not go unescorted for. Or it is a caseous tuberculosis, caseous necrosis, looking like tubercular, go ahead and do an AFB stain. You may get AFB positivity and the patient may not require any other treatment apart from the ATT. So, or it is a fat necrosis which we all know can clinically, radiologically mimic a malignancy, and microscopically you are the one to make a diagnosis for this. So try to type the necrosis. To preach is fine, to make a diagnosis on these necrotic cores is really difficult. Trust me, it is very difficult. Most of the times we sign out necrotic material, no malignancy seen, and the patient goes scot-free and comes back later on with metastasis. As in cytology, all papillary lesions need to be excised because the spectrum is huge, from intraductal papillomas to encapsulated papillary carcinomas, solid papillary carcinomas and invasive papillary carcinomas. Even if you are 100% sure that it is an intraductal papilloma on true cut core or on FNA, still excision is to be done because we know DCIS and ADH can occur within intraductal papilloma, and the criteria of DCIS in cases of intraductal papilloma is 3 mm and not 2 mm, which is there for the infiltrating carcinomas otherwise. So within the intraductal papilloma, it should be at least one focus of more than 3 mm. If there are multiple small foci less than 3 mm in size, so go ahead and report as multiple foci of atypical ductal hyperplasia arising within intraductal papilloma. So core biopsy may miss such a serious lesion which may be focal. So one has to go ahead and apply it. Classical intraductal papilloma, we are seeing the papillary cores, and we know that myoepithelial cells will be present throughout the course. So here the myoepithelial marker helps, because when you are looking at the myoepithelial marker, the focus where the myoepithelial marker is lost is the area of ADH and DCIS. Like in this area, we had the loss of ductal myoepithelial markers, where in all these ducts we are getting the myoepithelial marker positivity, nuclear positivity with P63 in all these areas, less than 3 mm, so areas of atypical ductal hyperplasia arising in a intraductal papilloma. Of course, this is on the excision specimen and not on the true cut biopsy. So our cytologist only privileged to give the reports as pathology category. No, histopathologists are becoming smarter and trying to make this into pathology category, which is pseudo smartness, because we are missing out on descriptions. So I would not like the pathology category to be entirely replacing the pathology descriptions, an old timer, but these are the pathology categories which have been the guidelines which are there for non-operative diagnostic procedures and reporting in breast cancer screening. The B1 from normal tissue and B5 for malignant, like in all cytology reporting, we are all very well aware of. Use the pathology category to assist management decision. Use it to supplement pathology report after you have given the descriptive report. Please do not replace pathology descriptions, because once we replace, we stop looking at the slides. So that is where we will start putting them into positive for malignancy, negative for malignancy, suspicious for malignancy, without categorizing those ductal, without categorizing those lesions, and that is where we lose. But that's my personal opinion. Of course, you can go ahead with what you feel like. Each case will require its system approach. What pattern you are seeing, whether it's completely necrotic, benign ducts, benign stroma, malignant ducts, benign stroma, malignant epithelial cells, and malignant stroma. So each case will require its own systems approach. Keep clearing your roadblocks by using whatever aids are available to you, if morphology, and yes, and second opinion from other person who has been doing those cases is always a welcome thing. So this is the place where I grew up, as a pathologist. My mentors are over here in the audience. It is my privilege to stand over here and say that Mamsi has grown me and has given me this opportunity to stand in front of you and to confidently speak. So this is Maulana Azad Medical College for me, where I have spent 34 years. So, and a big thank you to all my staff, faculty and residents of the pathology department and all the patients and the clinical colleagues who have been sharing their clinical material and diligently giving it to us and putting their trust into us for giving them the reports. I'm open to taking any questions.
Thank
Yes,
you.
sir.
Over to the chairpersons for their comments, please. Yeah, okay, yes, sir. Sir, please.
It was an excellent presentation, fantastic talk, and it was just hypnotizing. I would like to know one thing.
Yes.
Would you like to give all true biopsies to that artificial intelligence machine to report?
So artificial intelligence is ultimately going to be there. So yes, I would like to train the artificial intelligence by good pathologists so that it picks up majority of the lesions. In case those lesions are missed by a younger pathologist who has not seen them, they will come back for a second opinion to us. So we can't run away from technology. We have to train the technology to use it, make it best for us so that any false positives or false negatives which are going up, so those would come back to us. Yes, artificial intelligence reporting on its own has not been successful even in the PAPnet for LVC. काफी सालों से है PAPnet for pap smears, but it has not yet come. But definitely I'm not averse to artificial intelligence.
No, it is not a question of averse. See the nitty-gritty, the small alterations in the cells, small alterations in the stroma, which are making these various groups of lesions. Do you feel that those can be picked up by artificial intelligence intelligently?
So I think it is how intelligently we teach that intelligence. So we have to be intelligent enough to teach that it will grow up to become that. Ultimately it will have to be required. But yes, the way the number of pathology seats are increasing, yes, we are all scared of it. Radiologists are already on to getting artificial intelligence reports from for the X-ray chest and even the CT scans which is there. And I think it may not be even a few years when it would be there rampantly being reported by artificial intelligence. So we should take the mantle on training them, training the intelligence. That's it.
Thank you, sir, for making it more interesting and interactive. Thank you so much,
Thank
sir
you, sir.
and ma'am. And over to the chairpersons for the comments, please.
Thank you, ma'am. It is very informative and excellent presentation. You explained everything in such a short, limited period, and it is very useful to all of us. Thank you, ma'am, for
Thank
sharing
you so
your
much.
knowledge.
I think we all have to develop our own systems of reporting, so hopefully we'll all.
Thank you so much, ma'am, for this profound session. Now I would like to request our respected chairperson to present a memento to our respected speaker, Dr. Neeta Khurana, ma'am. And now, I would like to invite Dr. Vinod Kumar Bharadwaj, Professor and Head of Pharmacology, to please come on stage and present a memento to our respected chairpersons. Sir. Dr. Meenu Gill, ma'am. And Dr. Sumiti Gupta. Thank you so much, ma'am. Thank you so much, sir. Thank you so much, sir. And now, to lead this session forward, I am delighted to invite our respected chairpersons, Dr. Sangeeta Singh, Professor and Head Department Biochemistry, SHKM NU, Dr. B.C. Gupta, Consultant Pathologist, Faridabad Diagnostic Center, Private Limited, Faridabad, and Dr. Manish Wadhwa, Consultant Pathologist, Param Imaging and Diagnostic Center, Faridabad, to please come on stage. Blood is life sap, but it's just not sufficient to transfer blood to save a life. It's even more important to deliver safe blood so to avoid any associated morbidity or mortality. So now I would like to invite our next speaker, Dr. G.P. Saluja, sir, to give us his insights on topic of intricacies of blood banking.
माइक नहीं है दूसरा, इस पे शायद नहीं आएगा पूरा। और पॉइंटर ये है, ये वाला बोलो।
Sir, could you just please introduce, sir?
Give me some writing. I invite Dr. G.P. Saluja, our esteemed consultant, Blood Center, Alchemist Hospital Limited, Panchkula. He is the ISHBT Life Member and Chairman of ISHBT State Chapter, Haryana. He is a very senior person of and regarding this blood bank business, and let us, ask him to share his, experiences regarding some common problems regarding the blood banking, which we face in day-to-day practice, the intricacies of blood banking in day-to-day life. Please, Dr. Saluja, take over.
First of all, I am thankful to the HAPPCON organizers 2024 for giving me this chance to present my topic on intricacies in blood banking. And I think the budding pathologists, those who are most of them are out, and they should have been present, and even the MD students should have been present. And because this talk is going to be more useful, and nowadays, as per the licensing guidelines, even MD pathology without 3 months exposure in the blood banking is not allowed to run the blood bank. Okay. That is a change which has been brought by the Cosmetic Act in the amendments in 2020, March 2020. So it becomes more important, and the days are gone when we started the transfusion, animal transfusion to the human beings, 50% of them were saved, and then human to human without any grouping, and then the Landsteiner who invented the blood groups. From there on, the history starts. And now even I must say that A group cannot be transfused to an A group, or O group cannot be transfused to an A group until and unless all these budding pathologists or those who are in the blood banking, because I am saying this because today even most of the blood banks and most alone blood banks, just stand-alone blood banks, they are doing grouping even by slide method, which is not, and even cross-match by slide method, which is not an accurate method, because slide method determines only ABO incompatibilities, and the blood banking is beyond those ABO incompatibilities. So this becomes very relevant, and in between I'll also be telling you the latest changes which have been brought about in the Drug Act, in the amendment March 2020. Now, role of blood center in treatment of the patients cannot be undermined, and this is very important healthcare system part. And while it can be life-saving, there are several intricacies also which are involved in this blood banking. And several incidents, they have been demonstrated worldwide during collection, transport, storage, and transfusion of the blood. Human errors, most of them, they contribute about 40% of the errors during the transfusion. The intricacies in the blood bank lie in the complex interplay, because so many people are involved. Clinician is involved, staff nurse is involved, LTs are involved, doctor is involved, and when the patients are involved in that. And because of those interplay, there are a lot of intricacies, and sometimes even the attendant of the persons I have seen, that they point you that, well, this here is the wrong which is going on to the blood bank. You are transfusing a wrong blood bank, or you are transfusing an expired blood bank to my patient. And sometimes those are overlooked by the staff. And blood banks, they play a critical role in ensuring life-saving blood products which are available whenever needed. And today's presentation, we will delve into these intricacies of the blood bank, blood groups, cross-matching, transfer, and critical safety protocols associated with these. And besides that, some view about the court cases, so that to highlight the intricacies of these blood banking which are involved. And by understanding these intricacies, we can definitely save many lives in day to day in treating of the patients. Now, these are the different components, intricacies which are involved with blood types and incompatibility, donor recruitment, screening, blood collection and processing, storage and shelf life, blood transfusion, emergency preparedness, disaster, and regulatory compliances. All these are associated with, and it's not a one size fit, you can give O group to anybody. That is not the case. That's right. Had it would have been there would have been there was no need of having any more types of blood groupings. And today, if we say that there are 47 recognized blood groups with 366 red cell antigens, it is up to October 2024, and every year new groups are being added. And there are certain groups which are still on the registry, but those have not been classified into particular group. And there are 47 systems genetically determined by 52 genes. Now, blood group antigen molecules, as we know, being pathologists, those that is being taught, those are the glycoproteins, glycolipids, or polypeptides on the surface of the red cells. And ISBTI, that means 3 categories I have already specified. And then ABO is the only system which is, and apart from RH, ABO is the system which is being day-to-day routine. We do cross-matching and we give the patient to the blood A group, B group, or O group. But the beauty is that the antibodies which are present in ABO group, those are naturally occurring antibodies. And as per the Landsteiner law, if an antigen is present on the surface of the red cell, opposite antibody is present in the serum or in the plasma. So if the person is carrying an A antigen, anti-B is present in the plasma. If B, anti-A is present, AB nil, and O group both antigens, and no antigen and both antibodies. But here also the concept is wrong. O group actually carries the H antigen.
Yes.
And as per law, if an antigen is absent on the surface of the red cell, opposite antibody is present. So if H antigen is absent, anti-H will be present. So can you give an O group to an O group?
No.
Not the least. And that is what the Bombay group is. When antigen H is absent, anti-H is present, and usually I came across a case, kidney transplant case, who was O group, and he needed, kidney was being rejected, transfusion was needed, that hospital could not give the blood, and the sample was sent to me, and I found that the blood group of the person is Bombay blood group. So in day-to-day activities, you have to be very, very careful in knowing the blood group of the person. If the blood group is not known, then O group is given. Provided, I will come to the other conditions which are also required. And these antibodies then ABO group. So that is very important. And secondly, in slide method or tube method, you cannot categorize exactly what the reaction is, agglutination is, whether it is 1 degree or 2 degree, 1 plus, 2 plus, 4 and 3 plus are easy to recognize. But difference lies where you detect 1 plus or 2 plus agglutination. Whereas nowadays the gel cards, I am not advertising any particular company, but the method which is column agglutination method may be gel, may be beads, may be any. Here in that, this pellet of red cells at the top of the microtube gives you the 4 plus reaction. And the pellet which is down at the bottom, that gives you a negative reaction. And if it is throughout the column, it is 2 plus. If it is in the upper third, upper half, it is 3 plus, and if it is in the lower half, it is 2 plus. Very simple. Why I am telling you this is because this has a relevance in correctly knowing the blood group of the patient. These IgM antibodies, ABO group specific antibodies or antigens, they give normally 3 plus or 4 plus reaction. That is a 2 reaction. And if it is less than that, then you have to think of what is the group of a patient. And similarly, the antibodies, they give up to 2 plus agglutination is acceptable. If it is less than that, then you have again to think of whether this grouping is wrong or right.
Yes, not issue.
And I will explain this by certain examples because it will be, you only then the things will be clear. And all ABOH antigens, they develop as early as 37 days of life, fetal life, but do not increase very much in strength during the gestational period. Red cells of the newborn carry 25 to 50% of the number of antigenic sites. A or B antigen expression is fully developed by the 2 to 4 years of age. We normally, the hospitals, they get blood group of the neonate. That may change, and you have to advise in your report that you please get it done after some time, after 1 year or 2 years. and the presence or absence of ABOH antigen, that is controlled by the genes, and A and B gene, they code for the enzymes that add an immunodominant sugar to the H antigen, and if what the genes do, this is the precursor of the dead cell antigen, A group antigen, A or B group antigen, which and if the fucose is attached to this H antigen, this is a precursor, and if fucose is attached, this becomes your H antigen. That is what the genes do. Now, if to the H antigen N-acetyl galactosamine is attached to the terminal sugar, this becomes your A antigen. And if fucose is attached, this becomes a B antigen. So that is the difference between this, and that is why the scientists, the research labs are doing that. If we can remove these sugars and we can have an inert blood substitute, so that it can be given to any patient. And for ABO group antigen, you have to put up forward grouping as well as the reverse grouping. If in the forward grouping for ABO antigens you get 3 or 4 plus reaction, that is a true reaction, and on the reverse grouping if it is up to 2 plus, then it is a true reaction. If it is less than that, if those results they do not collaborate with each other, then there is some discrepancy in the blood grouping system. So say for this example, this is the negative reaction, this is negative, so this becomes O. And then this is the RH group, this is the control, and these are all 4 plus reactions. RH ka, and then this is the anti-A and anti-B. So this shows that our O group is all right. If you do only this, sometimes what happens is so H is present initially. This H is present, greatest amount is present in the O group, and it becomes lesser and lesser, and it becomes A1B is the least amount of H which is present. If you do the H, basis of depending upon this, in my blood bank, what I do is my technicians they put up in every O group the anti-H also.
Okay, that's right.
So that Bombay group is not missed. And individuals then there are subgroups also, and particularly A is notorious for the subgroups, and these subgroups are present depending upon the number of antigens on the surface of the red cell. Why these are important? Because these subgroups may carry, because the principle is antigen which is absent, antibody is present. If a person is having A2 group, he may be having A1 antibody. And this is true of AX group. And if you give A group, which is not going to be detected unless and until you do a forward and reverse grouping and tally the forward and reverse grouping results. So this becomes very important, and until and unless grouping is important, this is a intricacy which can be solved in day-to-day practice, provided we know it and we are aware of it. And if we leave the blood bank to the technicians, whatever they do, they are right. So you are going to have problems. And say for example, now A1 group A simple anti-A1 lectin is always available, and if you do it, if there is a discrepancy between forward and reverse grouping, you put up A1 anti-lectin, and you come to know whether reaction is 4+ or 2 or it is nil. And the number of red cell side antigens, those are 1/3 of the A1. So that is the difference. And no, these are the different A groups: A1, A2, A3, AX, AM, AMY, and AX is almost invariably accompanied by antibody, A1 antibody. So giving A1, giving A group blood to an A2 or subgroup of the A group, it can be fatal.
Yes.
And you can have then the repercussions, of course, the court case and all those things. Now the advantage of gel card is, or the column agglutination technique is, that technician is bound to put up forward reverse grouping both. I have been practicing in this blood bank which I have set up in Alchemist Hospital since 2007 after my retirement, because I had been to Belfast and other countries for WHO fellowship, TCTP Colombo plan, where they were already doing. In 90s I had gone, and यहाँ तो अभी वो हम ग्लास बॉटल्स पे कर रहे थे, स्टरलाइज भी खुद कर रहे थे, तो those things वहां जाके पता लगा कि ब्लड बैंकिंग है क्या. एंड नाउ दिस इज, अगर हम टेक्नीशियन अभी भी मेरा जो है, आज भी अगर कोई उसको डिस्क्रिपेंसी मिलेगी, he will immediately WhatsApp me that this is the finding which I have found. He is not supposed to give the reporting.
Yeah, definitely.
All reporting, in spite of we are having HIS, and that report is not, blood group report is not being made online visible to the ward or to the patient. Those are individually seen by me, and gel card, if we are routinely doing gel card grouping on all, for all the patients, for all the donors, and even the cross match is being put up on these column agglutination technique. Because reading of the grouping, reading of the system is very easy, and technician is not left with no other choice. If he is seeing this, that there is some discrepancy in the blood grouping, he will immediately come to me, or if I am not available, he will WhatsApp me up. So that way, this group is very important. And for this cross match, indirect Coombs test is, firstly, all the blood donors are screened by single cell panel, and all the patients are being screened by 3-cell panel, and cross matching is done by IAT.
Yes.
Because of the fact that there are still other groups or other antigens. Why every year the antigen groups are being, one or two groups are being added? It's all because those antigens, antibodies might be present, and the cross match, in spite of doing 3-cell panel or 1-cell panel for the donor and 3-cell panel for the patient, you may have some incompatibility. The other day there was a case with me, kidney transplant case. Surgeon has booked a case in the morning. He said that I have booked a case and I am going to start the operation at 9 for the kidney transplant. What should I do if you are not giving the blood? I cannot give you the blood. It is for you to do the kidney transplant operation without blood or not, but you will not get the blood. That every unit we found that is being incompatible. B group था, and every unit was, जितने हमारे पास unit थे वो सारे हमने compatibility लगा के देख लिए, हमें unit नहीं मिला. 3-cell panel was positive for that. Single cell panel was negative for the donor, all the donors. Ultimately, because in a private hospital we are with the reagents and all those, sometimes those are rare reagents because of expiry and all that we don't keep, and PGI being nearby, we send the case, such case with full investigation detail what we have done, and ultimately to cut short that case was found to be having anti-E antibody, small e, and that is only in 1 or 2% cases those who are antigen negative, anti-small e negative. We tried to test their brothers or sisters whether they are also negative or not, but they were also positive for E antigen. And the case was to be operated after giving his own blood. We took it and autologous transfusion के साथ उस केस को करवाया. So that becomes an importance, and if you are doing blood group correctly, it is very important. Then you can save so many lives. And incompatible blood, you know that is a potential activation of immune system. Clotting system can cause shock, kidney failure, circulatory collapse, and even death. And you might even land in court cases also. Now this is an example of a case. Yes. Purposely I have missed the reverse grouping for this card. This case was a regular donor. Everywhere he was being given, and he brought a card even that he is blood group ORH positive. And in the forward grouping, both being at the bottom cell palette, this is a O group, and this is RH positive, this is control. But if you go to the reverse side, the other half of this slide, anti-B is showing 4+ reaction. So this means this is a true reaction, and anti-A antigen must be present. Anti-B is present only if A is present.
Correct. A to B over.
And ultimately, there are simple methods of doing resolution, elution, and absorption technique. And if you are aware of that, then you can definitely diagnose this case to be a subgroup of A. This was a case of subgroup of A antigen, A group. So how can you give this A1, right, even if it is A? And all throughout he was being told that you are having a O group.
O group.
Then these are typical cases which I have from my own blood bank. And now this, you see, this is a 2+ reaction. A में, B is 4+, RH is negative, control is negative. Now this, if it would have been 4+ or 3+, I would have labeled this blood group as AB RH positive, RH negative. And this was a case in the morning nursing home had fixed up a cesarean section. That she told me that your blood bank is not issuing, although she is having AB negative RH, and we were having AB RH negative group. At that time I was doing only the whole blood, components were there, but till your blood group is decided, you cannot give anything. So if we go to the other side of the case, now A1 reverse grouping में is 2+, and B is negative. Either it should have been negative at all, if it would have been AB. So this shows that there is an antibody which is present. 3-cell panel of this case was negative. 3-cell panel will detect atypical antibodies. And I took the plasma of this case and got it reacted with the A1. So this was giving a 4+ reaction. So this is a A1 antibody. Ultimately this case, after all adoption and technique, we proved that this is a group. And anti-lectin A1, that was negative in this case. So this group comes out to be A2B negative with A1 antibody. You cannot give A group, you cannot give AB group.
Correct.
So here comes the importance of the components.
Yes.
You can give only B group component, red cells, to this patient, and plasma of AB group.
AB.
Because that will contain no antibodies.
No antibody.
And throughout life, उसको मैंने लिख करके दिया कि आपको कभी भी होल ब्लड नहीं लगवाना और आपको बी सेल ही लगवाने हैं और प्लाज्मा लगना है तो ए बी ग्रुप का लगना है.
That's right.
So these are the certain, these are the few examples. I have so many cases about this, but it's not the time, it will take long time resolving discrepancy kaise kiya. Now, then we come to the discrepancies in the donor grouping, donors. You know that it's a kind act, allotrism is important, donors voluntary, we are after that, being ISBTI president in the state chapter, that there should be 100% voluntary donation. And all the blood banks in the private hospitals, they depend upon the replacement. Now, the amendments which have been done in 2020, very stipulated, hard, strict guidance have been issued, guidelines for the donor recruitment as well. Like first time donors, donors who have not slept, anxious donors, donors with previous history of reaction, and multiparous women. Now, are not accepted because anti-HLA or anti-HNA antibodies are frequently seen, and this is a trolley risk reduction strategy. Because it has been seen that if you transfuse the blood of a multiparous woman, the patient lands into trolley, transfusion related lung injury.
That was previously also there.
And case is almost dies. And then each donor is also screened, and every system wise, which was not present in that in the earlier drug act, but in the amendment it is system wise diseases are there which are not for which the donors are not to be accepted. So one has to go through all those things, and rather it is a guideline that you have to make a poster and reflect it and paste it on the wall on the blood center also, so that everybody knows it. There are so many, and even the stringent guidelines are more stringent for the platelet apheresis. We do not, and first related blood donors, relation blood donors are not given the blood, because whatever the minor differences are there in the genes or the HLA antigens, those are not detected, and patient may land into graft versus host disease.
Oh.
This is a cell transplant. It's not a solid organ transplant. This is a cell transplant actually. Correct. This is not like a glucose or normal saline transfusion that you are doing it. And then NAT, which adds also another layer of safety and added safety for the window period, and some cases are detected in the window period. When the donor is selected, then we assign a particular number, and that number, that ID should be present on all the bags. If you are using multiple bags system and in the smaller aliquot also, all those they should carry the same number.
UID.
Date of then the blood bag has a diversion pouch. Nowadays there are blood bag system which have diversion pouch, and initial 5 to 10 ml of the blood is withdrawn into that, and that blood sample is used for testing, maybe viral, maybe blood grouping. Idea is that even if how so cleanly you may clean the skin surface, there may be some infection, और कई बार क्या होता है कि normally जो हमारे आदत है फूंक मार देते हैं जी dry कर दो उसको करने के बाद.
सही बात.
So some bacteria or a tag of skin may be carried away along with the blood, which may produce later on septicemia. So few 5 to 10 ml of blood is withdrawn in that, and after that the bag is filled up. And there and then the collecting staff writes the date of collection and date of expiry. Now date of expiry, एक बार क्या हुआ अभी I think last month की बात है most probably, कि 9/10/24 को ब्लड लिया, and instead of writing 9/10 उसने लिख दिया 24.
Oh.
Expiry date. And that expiry date, mind you, that was carried forward on all the components.
Naturally.
Goes unnoticed by the staff also, and it was a relative of the patient that you are transfusing my patient with expiry date blood. So nowadays everybody is very careful, And that patient, that relative was taken to the blood bank by the, it was a night time, by the technician. He was shown all the record that this is a typographical error, and even if you want, I can issue an error unit.
Yeah, definitely.
But he was satisfied, and that unit was transfused because this was a typographical error. So you have to be very, very careful in these such instances. And then the bags also come with a filter.
Liquid reduction.
Normally, previously we used to do filtration along the bedside of the patient, but now there are systems which are available with the liquid reduction filters are available, and we do pre-storage liquid reduction. And this pre-storage liquid reduction is up to the, for prevention of fever, not hemolytic transfusion reaction, febrile non-fever, non-hemolytic transfusion reaction, log 1 reduction, that is critical antigenic leukocytic load 0.5 into 10 raised to power 8, and for this prevention of alloimmunization, it should be less than 5 into 10 raised to power 6. Buffy coat derived platelets, such products which are leukoreduced, they can be labeled as leukoreduced, only these components. And this is labeled as leukodepleted because it is not a log, this is a log 4 reduction. And Buffy coat derived platelets suspended in platelet additive solution. Now those solutions are also available, which also help to reduce the trolley reaction. And blood components can also be irradiated whenever there is a need, for example, to prevent the graft versus host disease. And then the shelf life for these is only 28 days from the date of irradiation or the original date of expiry of the unit, whichever comes first. Now then comes the storage. Of course, this is mandatory to have a proper temperature, proper time of storage also, and whole blood or RBCs are stored up to 4 plus minus 2 degree. FFP is stored in minus 40 or minus 80, and platelet on 22 plus minus 2 degrees Celsius. And from, of course, from the, now these are the different periods of storage for this, for all the components, which, now what are the storage liens? We are going to store the blood. There are physical changes, there are biochemical changes. Physical changes are the shape of the RBC changes, loss of lipid from the red cell membrane, as a result there is decreased deformability capacity of the red cells, decrease in critical hemolytic volume, increase in osmotic fragility, blood stored in for more than 24 hours, 2 to 6 degree, have few viable platelets, heat label factors are also decreased, and viable lymphocytes persist throughout the storage period. So if we do not do this leukoreduction, you may have those reactions. And as a result, now because of these red cell changes, that leads to changes in the rheological properties of the red cells, and loss of cell integrity results in hemolysis or even microparticles formation in during the storage. And because of these microparticles, we use filters for transfusion of the blood. So that whatsoever microparticles are there, those are trapped in that, and it does not lead to any complication. And biochemical changes, of course, decrease in glucose and pH level. Decrease in pH leads to this decrease in 2,3-DPG. Now this has a property that if this is decreased, red cell property to transfer the oxygen to the peripheral tissues is also decreased. So here it comes that if a case is critical, those who need the oxygenation, or a neonate, you should not give the blood more than 7 days. They require less than 7 days blood, because the oxygen property, releasing property, we are giving the blood to maintain the oxygen level. So that will not be of any beneficial. Of course, I mean, if this is regenerated in 3 to 8 hours of transfusion, but if it is too much less, then it may not be useful. That time may not be there with the patient, and that giving the blood, that may not be of useful also. So therefore, they should be given relatively fresh blood that is less than 7 days old. Now blood transfusion, normally ABO compatible. If you have done donor screening, if you have done and properly cross-matched blood, we give. But before issuing the blood, the staff should have an informed consent for transfusion. Informed consent means that we have to explain to that patient or their relative that we are going to transfuse the blood, these are the advantages, these are the disadvantages, plus there are other substitutes available, why blood is necessary and what are the complications and how those can be saved. वो सारा उनको बताने के बाद ट्रांसफ्यूजन informed consent में होता है. And as per guidelines, the informed consent should be in English as well as in Hindi or the vernacular language, maybe Punjab to Punjabi. Now once that, of course, the laboratory technician issues a blood bank after checking all the formalities, all the data of the patient, all the data of the, in spite of that there can be errors. Once a wrong blood was issued, staff nurse ने लिख के भेज दिया O की बजाय B group. Staff LT ने without seeing वो B group उसको उठा के issue कर दिया. Without seeing.
Without.
Then the information comes from above.
Definitely.
From the staff के ये B group issue हो गया है. So patient were of the same name. And secondly, एक टेक्नीशियन अगर टेस्ट करके गया है, दूसरा इशू करा, he must see. From that day, I ensured that fresh sample is also called for when they get the blood issued, so that they check the group there and then issue the blood. So वो वहाँ पे मेरे को चेक लगाना पड़ा. These things are not written anywhere, but you have to see how your system is working and how you can improve upon the working system. And then when the blood is issued, then 3 pre-administration check of the patient, prescription and pack. These are to be checked. And for this also, I have designed this format. Usually हम कह देते हैं staff nurses को और उनको कह देते हैं कि जी आप चेक कर लो, हाँ जी चेक कर लिया. And it's all factors that patient की age, sex, MR number, group, वो सब ठीक है. But यहाँ पे ये form मैंने बना दिया था. Physician order है या नहीं है, patient first and last name क्या है, patient MR number क्या है, patient ABORH, donor ABORH, expiry date, and ये जो empty spaces है यहाँ पे उनको लिखना है. And 2 persons should sign. These are the WHO guidelines. Just two staff members, maybe 1 staff nurse, maybe 1 doctor or RMO, maybe they should check this format and then transfuse. If this is all right, then they should transfuse the blood. But इसमें भी कई बार क्या होता है कि I have seen RMO साइन करके पहले देके चले जाते हैं स्टाफ नर्स वो RMO उन्हें पिक्चर देखने जाना है या कहीं और जाना है, शाम को उन्हें साइन करके दे देंगे जी लगा देना ब्लड. And there are discrepancies available. Now duration of the blood. I have already told that filter is to be used. Filter is 170 to 200 microfilter and to be changed every 2 to 4 units of the blood. You should not transfuse any platelet after giving the RBCs through that same set. Because RBC they get trapped, filter भी उसके जो holes हैं वो block हो जाएंगे and you will only the plasma will go and no platelet will go through that. So for every platelet transfusion, if you are giving only platelets, so try to use a fresh IV set. And PRBC, within half an hour of the issue time, they have to start the transfusion. If it is more than half an hour, if the temperature of the bag is more than 10 degree, that blood is not to be used. That goes discarded. This is a WHO guideline. And the transfusion is to be completed within 4 hours. And during that period, first 15 minutes blood is given slow, and then every half an hourly the BP and vitals, those are recorded. So that chart is also, format is also designed. And FFP within 30 minutes of removal of storage, platelets immediately,
SDP 300 ml and immediately within 30 to 60 minutes. So these are the timings to be started and for the completion of the different components. मैंने सिंपल क्वेश्चन पूछा है स्टाफ नर्सेस से कि मैं ये कह रहा हूं कि ब्लड 10 डिग्री हो जाएगा जब उसको कैसे आप चेक करोगे, टेम्परेचर कैसे चेक करोगे. एंड माइंड यू, नो RMO, no consultant, no staff nurse could able to answer me this question. मेरा उनको सिंपल यही था कि आप बच्चों का टेम्परेचर कैसे देखते हो, बगल में रखते हो, थर्मामीटर रखो, बैग को बैग फोल्ड कर दो, सिंपल. So that is the and after completion, empty bag plus transfusion record that comes back to the blood center to have a full traceability of the blood. So that from donor to किस पेशेंट को गया, पेशेंट से उसको लगा नहीं लगा, and disposal तक. So this is in short the steps. Before time, this was a poster developed by me. And compatibility, wrist, जहाँ wrist band use करते हैं, ये सारे particulars check करो. Then back to label का check करो. And then back के ऊपर जो है expiry date क्या है, उसका discoloration है या नहीं है. And then tubing का है, segment number क्या है. RBC में जो RBC का बैग होता है, उस tubing के ऊपर थोड़े distance पे segment number लिखे हुए हैं. And what is the importance of that? We don't open the bag. Whenever some cross match comes, we take one segment for cross matching. So bearing that segment number identifies that this unit is cross matched.
Correct.
इसलिए हर बैग का जो RBC का बैग है उसको सेगमेंट नंबर जाएगा, उसका वो सेगमेंट नंबर वहां आइडेंटिफाई भी करेंगे. And then if these steps are okay, or 1, 2, 3, 4, and then we go to the 4th step, start the transfusion, and this label is pasted on the bedside ticket. After completion, along with empty bag, that goes to the disposal biomedical waste. Now reactions, because it will be beyond time if I start enumerating all those reactions. Of course, acute hemolytic reaction, allergic reaction, delayed reaction. Now, allergic reaction with FFP, plasma, they invariably occur. And we will not be able to find the cause of that. If reaction occurs, that FFP is to be discarded, fresh is to be given. I was going through the literature, even if a donor has eaten peanuts and he has donated the blood,
that can cause reaction.
If he is allergic, that he may develop the reaction also. So how far you can go and asking the history from the donor what you have eaten and whether the patient to whom it is going to be transfused, whether he is allergic to that or not. So allergic reactions, they cannot be, to FFP they cannot be avoided, those will be there because of plasma proteins. And 40%, as I have already told, are due to errors in post-analytic phase, checking labels, frequency, all those things. These 40% errors we can definitely avoid if we are careful. And the last phase of the transfusion, careful monitoring, is also in that during the transfusion we have to vitals record karne hain. If there is an reaction, we have to be careful and we have to start immediately. The first thing to be done is stop the transfusion, inform the consultant and monitor the vitals.
Right.
That my staff can definitely do it. Now then comes the emergency preparedness. Of course, the blood banks must maintain a reserve for emergencies, disaster and mass casualties. And during emergency or disaster, there can be shortages leading to difficult decisions about prioritizing who receives the transfusion. And disaster response plan includes mobilizing additional units by collaborating with other facilities or institutions or school educations, or usually there is a shortage during the summer time. So we have to go to the different organizations or the industries so that we can find a focused group to be addressed to and we can take the blood.
Thank you.
Now challenges, blood shortages remain a challenge. Encouraging regular donor and raising awareness are ongoing efforts. Advances in blood banking include pathogen reduction technique, extending shelf life, and developing universal blood group, blood products, as I have already told. Examples, artificial blood, main purpose of RBC is to transport the oxygen. If anything we can develop, and that transports of course this is not a substitute for the blood, but that will serve the purpose for emergency purposes. High turnover of the staff, this is another, technicians, आपके बहुत turnover होता है. Secondly, because of capping in the processing fee, even private hospitals or corporate hospitals are not paying that much as they are paying to other specialties. They are dependent on the revenue because blood bank is not giving any revenue. So so that is the least which is not a good for the and blood transfusion therapy. They don't understand that if they are having blood center in their hospital, so many facilities are there, so many surgeries and all those will be referred. Casualties, how can they are going to treat the casualties or the emergencies? So that is not a concern. They are concerned only with the revenue. This is not revenue generating and we should give the minimum to the doctor and the staff. Frequent changes or the senior staff has to take a mentor, has to become a mentor. जो नया technician आया, उनको train properly करने, what are the processes which are being followed in the blood bank. So those are to be taught. And then another is bloodless surgery and technology, advances in surgical technique and equipment such as blood salvage and are also reducing need for transfusion, and resource constraint, limited budget and time constraints, they hinder the extensive training also.
Thank you.
Now regulations, I have already told, the blood banks are regulated by the Drug Act. अब इंस्पेक्टर्स हैं हमारे, अगर कोई हैं तो आई एम सॉरी, उनको कोई ज़्यादा पता नहीं होता. एक्सपर्ट जाता है उनके साथ तो एक्सपर्ट वो भी कभी ले जाते हैं नहीं ले जाते, तो ऑल दोस थिंग्स दोज आर द फॉल्ट्स विद द सिस्टम, बट दे शुड ऑल्सो बी ट्रेन्ड, व्हाट आई मीन टू से, सो दैट दे नो. इनिशियली टू बी वेरी फ्रैंक, बीइंग पैथोलॉजिस्ट, मैंने भी कभी ये पता नहीं था ये टिपिकल एंटीबॉडीज क्या हैं, ये है वो तो एक्सपोजर में हुए थे, वो हमें कुछ हो गया. So otherwise, then good manufacturing press, all blood banks should adhere to national and international guidelines, whether it may be FDA or WHO. Good manufacturing practices, that is a part of the act, described in the act. All processes which we are carrying, we have to have an SOP for each. If we are taking blood, drawing the blood, if we are doing grouping, for any procedure, SOP has to be maintained. And those SOPs not just book. Those are to be SOPs, methods should be, SOPs should be dependent on the method, reagents which are being used, what equipment is being used. Being part of the joint inspection team, I have seen blood centers में कि equipment Trans Asia का है और SOP बना हुआ है Johnson and Johnson के equipment का, so those things should be avoided. And then accreditation and certification of the blood banks and transfusion services and traceability, I have already told. Each donation has to be tracked to the disposal level, starting from this.
Thank you.
Now, to cite certain cases, I'll briefly go. This was a case in PGI. Wrong blood transfusion was given. Case was of burn injury. जल्दी खत्म करो.
With all, अच्छा ठीक है. With all your excuse, I need just 2 minutes.
Yes.
अभी आप.
Should I carry on?
Yeah.
So this was a case of burn referred from Ludhiana. Initially her blood group was A positive, given B group 2 times. Rather, this was one group was given on 20th May, another on then on the night also 20th, reddish like substance. In spite of seeing that plasma is not clear, again the B group was given on 21st. And on complaint, inquiry was conducted. Departmental inquiry confirmed that wrong blood transfusion has occurred for this patient. And State Commission observed that there has been serious deficiency and negligence on the part of the PGI and its attending doctor or staff for transfusing wrong blood to the patient, which caused death of the wife of the appellant number 1. And mismatching of the blood has been confirmed by the senior resident in the death summary also, and once the patient is brought to the PGI or any other institute, the background oblique history, if any, for example, that patient was maltreated by the husband, because that is irrelevant, but the death has occurred because of this, your negligence cannot be ignored. That is what the state has observed, and that findings were confirmed by the state commission also. And damage control treatment was started, and kidney failure and all those things are there, and Supreme Court upheld the view of National Commission with the remark that it does not suffer from any error of law. In the result, the appeal was dismissed, worth cost 20,000 rupees. That of course the this compensation was given to this case. Now this is another case which without blood grouping, blood दे दिया गया था, केस की डेथ हो गई. This was a case in district Kanpur, and Dr. Verma and others. इनको कमीशन ने केस रजिस्टर करने के लिए कहा, लेकिन they went for the court. वो कहते हैं ये group हम this without testing the blood has been given, and suddenly instead it was found that the B group instead of O group was given, and due to administration of wrong group, blood, kidney and organs of the body of Yasin Begum were damaged and died on this in the evening. And for the death, the Dr. Rajan Luthra and those doctors were found responsible, and because their negligent administration of wrong blood without testing resulted in death of the Yasin Begum. After hearing, his request discharge was rejected, and case the court ordered the registration of the case for this. So court is not going to make it free that there has not been a negligence. Negligence, they take it very seriously. Then Bathinda, this was a news about 2 years back, I suppose, and the patients were knowingly, LT has called the HIV positive cases, and those blood were taken and given to the thalassemia patients. So this was in Tribune 18th 2021. Then mix up of blood, this was recently there, and February 23 2024 2 accident cases came, their blood was sample were changed, and they were giving the interchange blood करके दे दिया था, उनकी भी death. So this was recently in Jaipur. So most of the errors, this was a army officer that directs the army to pay 1.5 crore rupees to the ex-officer who got HIV during blood transfusion. A former Air Force officer contracted HIV/AIDS after a blood transfusion at military hospital during the operation at Parakram in 2002. The Supreme Court has rejected the review petition filed by the Indian Army against its verdict, directing Indian Army to jointly pay 1.5 crore compensation. The appellant is entitled for compensation of itne on account of medical negligence of the respondents. Now, screening of viral markers, here I have forgotten a point, this is also very important. We are not giving any diagnosis for the patient. The blood is just being screened. Even if the level 1 test is positive, that blood better is, it is to discard that blood and not to transfuse, and rather than going into second, and if you suppose that you do some other test, it comes to be positive, negative, are you going to transfuse that blood? No. In case you are doing the diagnosis of a patient, you may do one test or second test or confirmation. For blood transfusion centers, only screening is being done. That thing must be made clear to the patient, to the donors. Counseling should be done, pre-counseling and post-counseling, and they should be made that this is not the diagnosis, this is not the final diagnosis, only the screening, and discard that blood if you want to save yourself. So understanding these intricacies, health professionals can ensure safe and effective blood transfusion, minimizing the risk and maximizing the benefits for the patient. Thank you very much.
Thank you, Dr. Saloja. It was very informative talk, in fact. Sorry for being absent in the last for 2-3 minutes. And whatever you have said in this lecture really very, very important in our day-to-day practice as well. Not only for the knowledge sake, but every word which you have spoken is really true. We have, myself and Dr. Manish Vadva, we have maintained a blood bank for 6 years in a private hospital in Faridabad. And we have come through almost all the things which you have said. It was because of sometimes typographical mistakes, sometimes because of the staff, because of some negligence in just writing the signing and sending the things like that. And really each and every step in blood banking is so important nowadays, especially that Bombay group type.
Yeah.
That is very, very important, that we should be very careful about it.
Even A group, subgrouping, it's very important.
Yeah.
And
So-
I tell you, one thing I may tell you, that another factor which was brought by the state drug controller in our meeting with the private blood bank associations held on 17th at Karnal was that technicians क्या करते हैं वायरल मार्कर के लिए रैपिड कार्ड लिया जब तक कि वो पॉजिटिव नहीं आता वो सैंपल उसी में डालते जाते हैं ऑल आर नेगेटिव.
And that is very wrong. It cannot
This is
be
also a practice.
accepted at all. So
if we are careful.
Yes, yes. So it is quite late, and though I am relieved, but others are waiting for. It is very late for the lunch as well.
Yeah.
So I'll say, wonderful talk, very informative. Thank you very much. Thank you very much.
ये मेरे तो सारे इसमें एसओपी की एक किताब भी है. स्टैंडर्ड ऑपरेटिंग प्रोसीजर एंड रेगुलेटरी गाइडलाइंस ब्लड बैंकिंग. सेकंड एडिशन मेरा लास्ट ईयर आउट हुआ है. डॉक्टर शांत जानते हैं. And so many blood bankers know, and it's available on JP and even on Amazon also.
Okay, doctor. We'll.
So it's all SOPs, updated act. All information is there. And all those whatever I have told you, it is there in those.
And recent thing which you have said that 3 months. Experience for a MD pathology is still required.
Now it is on.
It is, yes.
Previously, MD pathology was authorized to run the blood bank.
Yes.
Now even pathology MD cannot run the blood bank without experience in blood banking for 3 months.
This is something which is
And
very
only without experience is blood transfusion medicine person.
Right.
So that change is also there in the act.
Right. Thank you, doctor. Thank you very much.
Thank you so much, sir, for this profound session. Now I would like to request our respected chairpersons to present this token of appreciation to Dr. G.P. Saluja, sir. And now, I would like to invite Dr. Prashant sir to please come on stage and present a memento to our respected chairpersons. Dr. Sangeeta Singh, ma'am. Dr. B.C. Gupta, sir. And Dr. Manish Vadva, sir. Dr. Sangeeta Singh, ma'am.
I request you all to please visit the stalls while enjoying the lunch, and I request the members of IAPM Haryana chapter to please stay back for the GBM.
Just बोलो डॉक्टर भरत. हाँ, just introduction about Dr. Bharat.
Dr. Bharat Reiki, Professor Pathology, MD DNB, MIAC, FICP, FRC Path, Department of Pathology, Tata Memorial Center. Post MD is 23 years. Areas of interest: soft tissue and bone tumors, adult and pediatrics, gynec pathology, related cytopathology and molecular pathology. Major achievement: grand prize. Conducted and participated in the National CME, Editor-in-Chief, Indian Journal of Pathology and Microbiology.
And that's the feeling I've had. So very, very grateful to you for having me here for talking. And it's been a blessing to have met my teachers who've always immensely influenced me. And there's not a single day, when I was just telling my colleague Dr. Minu that, I tell my residents how proud I have been to be, have worked and done my post-graduation from such a beautiful department at Rohtak. So thank you so much, ma'am, for having me, and thank you, everyone. So I'll be speaking on the role of immunohistochemistry in gynec-oncopathology, focusing on certain specific scenarios with diagnostic implications. And when I say gynec, I've realized over the period of time that I do bone and soft tissues in gynec, it's no more one system, it's like 4 systems. The way it has evolved in terms of ovarian tumors, endometrial carcinomas, cervical carcinomas, mesenchymal tumors, and vulvovaginal tumors. So I'm here to cover this talk, which supposedly could be a CME, into 45 minutes, and I have some basic points to focus, but before that I would just like to reinforce the point that we can make diagnosis of a lot of tumors, including the prognostic types, on the simple H&E stain, which is, there is no substitute to that. But yes, over the years our good friend immunohistochemistry has helped us in uncovering very uncommon clinical scenarios, which have treatment implications, and it is from the diagnostic and prognostic point of view, and also certain theranostic aspects. So I have certain plan in my as a part of my talk. We'll see ovarian tumors, a whodunit situation of primary versus metastatic tumors. We'll see how IHC helps us in uncovering unusual tumors. In uterine tumors, the Cinderella of the tumors is endometrial carcinomas, because it's been with the magic wand that this tumor from molecular has gone to the other level, and that's the focus of all the oncology talks these days, including the FIGO staging that is now molecular for the low stage endometrial carcinomas. The mesenchymal tumors have an expanded spectrum, which is so evolving with the immunohistochemical stains and also the molecular. And again, the next aspect that I'm taking here is a cervical tumors, including the value of the HPV surrogate P16 in trying to differentiate HPV positive versus or the HPV associated versus the HPV independent tumors that we are trying to classify cervical tumors as squamous or adenos. I'm not taking GTDs because that's another part of the talk that you can have a CME in the gestational trophoblastic tumors, and so I'm just kind of keeping it not as a part of my talk today. And then my approach is going to be case-based, which are experience at TMH that I work here. So looking at the scenario in the ovarian tumors is the whodunit situation, and we see cases, with advanced stage tumors. So where is the tumor coming from? It's very important because, the tumors primarily of the ovarian, the vast majority of the serous carcinomas, they present with advanced stage, so they are dealt with a very specific chemotherapy in contrast to the other chemotherapeutic agents for tumors coming from the other sites. So when I was not doing GYN as a specialty and as like a usual sign out, I got this rectal biopsy, and it's a no-brainer that this is an adenocarcinoma. Now the issue here is that you have a normal mucosa and you have a tumor, so where is it coming from? What helps us here is immunohistochemical stains, because you can see this tumor is CK7 positive and negative for CK20, which is actually highlighting the rectal mucosa, you can see. And then you have the other stains, WT1 and CA125, as we used to do. Now we've moved from 125 to Paxate, which is a better Mullerian marker, to reinforce that this is a metastatic high-grade serous carcinoma coming to the rectum from the ovary, in fact. And that just stems towards, our initial publication in 2008 when I joined TMH in 2006. I was very excited to see how CK720, now I think a lot of us know how we can use these markers, the play of this 7 and 20 combination, because if you have a 20 positive and a 7 negative, you have very high chances that the tumor is coming from the lower, the lower GI tract. You can see 7 and 20 positivity also in primarily ovarian mucinous tumors, but the 20 positive and 7 negative is quite towards a lower gastrointestinal tract. That's another example that we had as part of this publication, that we were seeing that 7 positivity is seen mostly in tumors like endometrioid or serous in primarily ovarian tumors, and you don't see 20 positivity. In contrast, you see 20 as GI, what I mentioned. But one thing again very important we learned was that you have always a morphological motive towards what you're seeing immunohistochemical. So you see a very typical garland-like necrosis as a part of the tumor pattern when you see a metastatic tumor in the ovary from the GI tract, in contrast to the primary ovarian, which might not show you that very peculiar garland-like necrosis. So again, looking at the scenario what I mentioned, that you have the advanced stage tumors, primary ovarian versus the metastatic, the choice of chemotherapy is completely different. You will have a platinum-based chemotherapy for a patient with advanced ovarian carcinomas, in contrast to a fluorouracil-based chemotherapy which is offered to the patients with colorectal carcinomas. It's very important that we differentiate this scenario when a patient has advanced metastatic tumor. And the IC profile, like I mentioned, we've been graduating from 7 and 20 combination towards WT1, which comes positive in serous, and now we have Paxate as a good Mullerian marker. In contrast, in colorectal, we have 20 positivity, but then you have something more specific in terms of, you can have a choice of CDX2, which again is not perfectly specific, and then you can go for SATB2 that we use off late to reinforce again. I always say we're reinforcing a diagnosis than rather making on immunohistochemical stains. That's a scenario of an adnexal mass, which is again a no-brainer. This is an adenocarcinoma. What you see here is a 7 and 20 combination positivity. It's not very typical for a serous carcinoma. And in addition, you see CDX2 in 19.9. So this was a metastatic high-grade carcinoma, and the scenario was pancreatic biliary tract. So you have ovary primarily as, a site for carcinomas, primarily ovarian, but you can have this also a seat for tumors which are metastatic, and I think we know that. When we look at the IC profile of ovarian tumors overall, in epithelial tumors, WT1 is good to reinforce serous. P53 abnormal diffuse staining is what we call as mutation type or completely absent. If you see focal, we call it wild type staining. When you're dealing with a clear cell carcinoma, napsin A is a good stain to reinforce that diagnosis. If you have hepatocyte growth factor, that's another good stain. Endometrioid carcinomas, vast majority are ERPR positive. You can have beta-catenin nuclei, but that's a bit tricky situation, but you can also utilize P10 loss or the added 1A loss in endometrioid carcinomas. In mucinous carcinomas, you will have a variation of the CK7 and 20 combination with variable positivity for CDX2 and CEA. Coming towards germ cell tumors, you have a layer of markers that you can go from your basic panel towards indiscerminomas. We use c-KIT, and OCT34 is overall a good marker for germ cell tumors. For yolk sac tumor, glypican-3 is good, and Salfor again a good combination for, you know, when you're putting a panel for your IHCs in the germ cell category. Sex cord tumors again have evolved from our basic spectrum towards calretinin and inhibin that we used to do. CD99 or MIC2 is not very specific. They can also show you A1, A3 and WT1, but now you have SF1 and FOXL2 as two markers that are useful to reinforce a sex cord differentiation. Like I said, why do we want to do these immunochemical stains? Because again, when we look at the epithelial types of ovarian carcinomas, clear cell carcinoma is clearly a chemorefractory tumor, in contrast to serous carcinoma, which is a chemosensitive tumor. Of course, it recurs, but it is chemosensitive. Clear cells are not. Germ cell tumors melt like butter on the chemotherapy or the radiation, so it's very important we differentiate this, especially in younger patients when these can be overdiagnosed as carcinomas. Sex cord tumors, again, chemotherapy is for high-grade, high-stage tumors, and of course, poorly differentiated ones don't respond to chemotherapy, so they are bad actors. So we need to sort of differentiate these tumors, which are the good ones in terms of their response to chemo, or we want them to be excised, versus the poorly differentiated that won't respond to any chemotherapy. That's an example of a clear cell carcinoma with its very peculiar hobnail-like pattern, clear cells, and you're reinforcing this diagnosis with napsin A positivity, which is very granular sort of staining pattern because it's an enzyme. You have WT1 for a high-grade serous carcinoma, mostly it's a diffuse nuclear. That's again, you can see a spectrum of clear cell carcinomas when you can see no clear cells actually, and you can see clear cells in a serous carcinoma which is post-treated. So clear cells is a bit of a misnomer when we say something is clear cell carcinoma, because you can see these tumors without clear cells, and paradoxically you can see post-treated serous carcinomas showing clear cells. So napsin A is a good marker to reinforce your diagnosis of clear cell carcinoma. And that's what we published in terms of two markers, napsin A and WT1, that are mutually exclusive, because you have WT1 positivity in serous carcinomas, which doesn't happen in clear cell carcinomas, and napsin A comes positive in clear cell carcinomas. It doesn't come in serous carcinomas, and that's the evidence you can see as part of this publication that we did. Now, not only the pattern of the tumor and its expression, but it also reflects an underlying genetics. So I would like to quote, and I very much fondly associate, as Dr. Joan Rosa has said, every genetic event underlying shows itself phenotypically. So it's like, you know, it's a good synergy or jugalbandi between the genotype and the phenotype. And I like that. I see slides in their dynamic, and I see Dr. Sen here. I remember when he used to report, he used to show us cases in a very dynamic mode, then a very static way in which we see it's a bit mundane, but he used to make us feel that yes, something is happening here and we need to know that. And you can see in this case of high-grade serous carcinoma is what we call as a set pattern. It's called the, you have the, earlier these tumors used to be called as transitional carcinomas, like we have done with that pattern, because we've realized these are all serous carcinomas. And this particular pattern with this WT1 positivity and P53 abnormal expression that you can see here is actually kind of a BRCA associated pattern. You call this set pattern with BRCA associated, and these patients can be candidates for olaparib therapy. So just see morphology going with immuno, and in fact reflecting a underlying genetic subtype, which we can see as a part of this tumor example here. Coming towards the whodunit situation, we've learned that ovarian serous carcinomas, a vast majority are coming from ovarian, the fallopian tubes that we used to very casually sample, but over the years with phenomenal works by Christopher Crumb from the from Brigham's and Women, I think Mass General or Harvard, we've realized that actually it's a fallopian tube, and you can see in this particular case in a serous carcinoma ovary, there are some areas of atypia, and you can see P53 in certain areas is kind of focal wild type expression. It's showing this diffuse expression telling this is a stick or the intratubal intraepithelial carcinoma, and that's the origin of the serous carcinoma of the ovary coming from the fallopian tube. Coming towards the spectrum of the sex cord tumors, you can see that they can show you CK positivity. In this particular example, looks very epithelial, and you have markers like inhibin that we used to utilize for reinforcing diagnosis of steroid cell tumor. In this particular example, morphologically very classic, and then you use inhibin positivity for this sex cord tumor example that I showed here. This was an interesting case I came across in an abdominal tumor in a young girl who had this very spindle cell sarcomatous tumor, and I was wondering that looks like a, because I do bone and soft tissue tumors, and I thought that perhaps looks like a nerve sheath malignant tumor with this rhabdomyoblastic differentiation reinforced by desmin positivity. And it's very important that we make a diagnosis, we don't miss out on something which has happened. And this particular case, there was an earlier report of an ovarian tumor that was in fact a poorly differentiated Sertoli-Leydig cell tumor, which can show you heterologous elements. And those cases with young patients are actually dicer associated. So it's again morphology, immunohistochemistry, and you have a genetic motive as well to this particular tumor example that I shared here. That was a case of a 61 years old lady who had an adnexal cell mass, and it was reported initially as small cell tumor. It's kind of a very nondescript diagnosis, but what you see in lower magnification is variable areas with necrosis, and you can see frankly malignant tumor with epithelial differentiation. And there was some areas of carcinoma with this rhabdoid cells, and wondering perhaps this could be a carcinosarcoma. Of course, A1, A3 or the keratin highlighted the epithelial elements, and the desmin and myochinin or the skeletal muscle specific marker highlighted the rhabdomyoblastic differentiation. And this was a carcinosarcoma of the heterologous elements. Again, these tumors have moved from sarcomas to the carcinomas because they behave like them and they are treated, except that they don't respond as good as the carcinomas. So we don't use the word Mullerian, Mullerian tumors, and we designate these tumors as carcinosarcomas, including in the uterus and also in the ovary. That's a series of 27 cases of mixed Mullerian tumors that we used to call them earlier with my colleague Santosh, and we partnered in this publication, and we realized that certain morphological features again are hinters, that you have these pink globules in these tumors associated, which can hint towards possibility of a carcinosarcoma as we call them here. So taking another case scenario which is very frequent in ovarian carcinomas as it present at locally advanced stage at our center, and that's ascites the patients present with. So we call carcinomas of the ovary like the silent lady killers, because they present late with ascites and the tumor is like all over. The positive report here is going to triage the patient for the platinum based chemotherapy. It's very important that we are specific in that diagnosis. The challenge could be that we have to differentiate reactive mesothelial cells from adenocarcinomas and trying to subtype adenocarcinomas towards are they really ovarian or something else is there. And also when we look at these mesothelial rich effusions, rare examples, that are these reactive or it's a mesothelioma. So that's the panel which can be useful for adenocarcinomas. You have BRIP4, which will be positive, but now you have MOC31 and Claudin4, which is a better choice. Calretinin should be mostly negative, which is positive in mesothelial cells, and I'm very fond of calretinin, apart from CK5-6. So adenocarcinoma of the ovary, which will be positive mostly for PAX8. We're done with CA125, but if EP4 anyways will be positive because it's an adenocarcinoma. Mesothelial cells will be calretinin positive and CK5-6 positive, and we are trying to differentiate mesothelioma from the reactive. The markers that one can utilize is desmin, because desmin is positive in reactive mesothelial cells. It won't show up in the mesotheliomas. And now you have the new age markers like the BAP1 loss and the MTAP that you can utilize to reinforce a diagnosis of mesothelioma. That's again a no-brainer. This is a high-grade serous carcinoma yielding itself in the effusion specimens that we get most frequently, the way carcinomas of the ovary present with, and the patient goes for a high-dose, the platinum-based chemotherapy. So it's a carboplat and a platinum-based chemotherapy. It's very, very, it can be very toxic in terms of the neuropathic effects, and I've seen patients. So it's important that we make a very specific diagnosis and we don't miss out on that. That's a scenario you can come across by atypical cell clusters. You're wondering perhaps this is adenocarcinoma, and I think those were the situations we used to use BRIP4, but now we've moved to PAX8 positivity. This is what is most frequent that we see, high-grade serous carcinoma, and PAX8 is positive, WT1. Of course, WT1 can also be positive in mesothelial cells. So I don't do WT1 in the fluids, but I do in tissues because, in fluids you have a mesothelial cell population also, so it's difficult to differentiate. So PAX8 is a better choice. And if I don't do P53, my smart oncologist will ask me that, can you demonstrate it's a mutation type? When I say P53 positive staining, we actually don't call it positive. We call it abnormal or mutation type because either it's diffusely positive or completely absent. So focal expression is what we call as wild type, and most serous carcinomas show you abnormal or the mutation type of P53 expression. That's another example of an elder lady who had this, I won't say elder, 55 years old lady who had this widespread disease and very overwhelming cell block, just like a microbiopsy. And you feel perhaps this is a high-grade serous carcinoma, and you have your favorite Samoma bodies also. So looking at the IHC profile, you can see actually calretitin is focally positive as expected. It's all BURI-P4 positive, Paxate is diffusely positive, and P53, as you might expect it to be abnormal or mutations, actually focal staining. So this was a low-grade serous carcinoma which can present with high-stage disease, and these patients are triaged with debulking surgery primarily, with maybe options of platinum-based on adjuvant settings, in contrast to the high-grade serous carcinomas where patients gets the platinum-based chemotherapy at the upfront at our center. So that's important that we are able to differentiate the uncommon low-grade serous from the high-grade serous, which is frequent. That was an unusual experience of seeing a squamous carcinoma yielding in the fusion specimens, and we reinforced this diagnosis with P53, P63 and P40, which is a better choice for reinforcing squamous differentiation. That was a very mesothelin-rich effusion, and it was initially diagnosed as adenocarcinoma based on some signet ring cells, until we found that these are all diffusely calretitin positive. So you know, generally if you see mesotheliomas, you wonder that they are mostly coming in clusters like mulberry clusters, which is our usual thought process, but you can see a scatter of monomorphic atypical cells in mesothelial rich effusions, which actually could be mesothelioma. But again, it's very important that we don't make a diagnosis based on only morphology and immuno, but also on the clinico-radiological context, because this can have actually, you know, the certain medico-legal implications also for patients, you know, who might be exposed to asbestos, especially in the Western population. So this was a mesothelioma. Now that was an interesting example I came across when the resident brought to me that this is negative, and I was just wondering some morphological clue, which is mucin coming in the you know, the smears or the cell block preparation, and that's kind of worrying me towards what it could actually have. And when you see closely, you see these atypical cells with some you know, signet ring cell forms and some clusters. So this was a presentation, perhaps, you know, this is ovarian because they are bilateral masses, they can't see ovaries separately, and that's the time when we employ certain stains with the thought process, perhaps this might not be ovarian, something else. And we played with 7 and 20. You can see 7 is completely almost negative except highlighting rare mesothelial cells, and 20 is nicely positive in those atypical cells in CDX2. So this was actually a context of unknown primary where the metastasis was from the colorectal carcinoma, and the patient went for a fluorouracil based chemotherapy in contrast to platinum based chemotherapy. And that's been a bit of a paradigm shift towards when we started cell blocks routinely. Now we do in all serous you know, the fusion specimens at our center. Initially this particular example, you know, you can see was misdiagnosed as adenocarcinoma, until on cell block we found that this was P63 diffusely positive, and of course you have a morphological pattern of squamous carcinoma on the cell block. This was a case in which the patient in 2013 with effusions was called as adenocarcinoma, and that they induced the patient on pemetrexate, which is treatment for the lung carcinomas, because you have the pleural effusion, and you know, the patient is presenting with the effusions and perhaps it could be a lung mass, so they instituted or the induced the patient on the pemetrexate based chemotherapy. And then I saw this case coming to me on my table in 2000 you know, years later as ascites, because I do gynec. So I was wondering, is it same disease or there are two diseases? And when I looked back, you can see your favorite Samoma body lying in this cell block preparation. Unfortunately, the immunostains were not done because we are associating very casually that it's adenocarcinoma, it's coming from the lung, which actually was the serous carcinoma presenting with pleural effusion to begin with stage 4 disease, until we diagnosed this serous carcinoma in the ascites 3 years later, and the chemotherapy was changed from pemetrexate to the you know, the platinum-based chemotherapy that I just mentioned. We've uncovered very uncommon scenarios of clear cell carcinoma, and this kind of a predictor. I just presented our data of 13 cases as an award presentation at recent cytology conference in Jodhpur. So this is very interesting to know that, you know, you can see some morphological features that you can predict, and we've seen 100% prediction of identifying these hyaline globules and raspberry bodies, what I call as flower cells, which you see these pink bodies on GIMSA preparation, the cells surrounding these globules, which are seen in clear cell carcinoma of the ovary, and you can see napsin A nicely reinforcing this hobnail pattern of clear cell carcinoma cells on the cell block. It was very heartening to see that this publication featured on the cover page of Cytopathology Journal and propelled us to, you know, analyze 13 more cases that I just presented. Now coming towards second part of my talk is uterine tumors, and that's kind of been a endometrial carcinoma as a Cinderella of the tumors, because there's so much molecular that has come up, and we've been associated with these radiation colleagues with the PORTEC trials. So the basic thing that we have challenged is to try to differentiate this atypical endometrial hyperplasia or the EIN from the carcinoma grade 1. It's not that much of a challenge as we used to feel, because they are similarly dealt with high dose progesterone therapy, except if you have these foamy cells back to back arrangement. Again, basic morphology. I word out my report with these, the collection of neutrophils as grade 1, especially in the elder patient. If you have a younger patient, my report could go as bordering on or cannot rule out, and I think everybody is right in the way they want to word out their reports, because we want to be a bit conservative. But it's not too much of a challenge now, because the patients are dealt with high dose progesterone therapy, be it grade 1 or EIN or AH, as you would like to word it, or complex atypical hyperplasia, which we used to call. So endometrial carcinomas classically are diffusely ER/PR positive, and that's been seen that trying to differentiate who done it again, endometrioid versus endocervical, it's been realized now again that's not a challenge, because endometrioid carcinomas occur essentially or vast majority in the endometrium only. If you have that tumor coming in the cervix and your oncology surgeon is asking you, oh, and we used to do these 4 markers, which we still do. ER/PR and Vimentin positivity comes in the endometrioid, and endocervical will show you diffusely P16 block-like with CEA. So that's a good combination that we used to do. We still do that. But it's been realized that endometrioid carcinomas coming in cervix actually are also part of the uterus, lower uterine segment. So if you see the latest classification in cervical tumors, endometrioid carcinoma has gone almost out, as much as serous carcinoma also. So they don't exist in cervix, because serous carcinomas are metastatic, and the endometrioid carcinoma in the cervix are actually coming from the lower uterine segment. But we use this 4 marker panel that you can utilize, and again you can play with if you have P10 loss or the arid one to say something as endometrioid. So for serous carcinomas, we have this P53 abnormal expression like in ovary, also in the endometrium, and we add on WT1 to say something as serous carcinoma of the ovary, because endometrium serous carcinomas generally are WT1 negative, but they can be positive as well. So it's keeping your options and eyes and open with a broader mind to see things not in a marker but in a context. So again, a scenario which I think we don't have that, but I think at community hospitals one can go have that difficulty of differentiating Ares stellar reaction from clear cell carcinoma, and those will be less on MIB1, and they won't show P53 abnormal as the serous carcinomas would be. So coming towards this possibility of endometrioid versus an endocervical, and you can have a very overlapping morphology. You see this particular example as ER negative, and it's P16 diffuse block-like, and that's what I call block-like. Every cell, nuclear to cytoplasmic, it won't be perfectly nuclear, but it just covers the entire tumor, what we call as block-like staining with CEA, and of course you will see Vimentin mostly negative, but there can be focal expression of Vimentin is not a no for endocervical. So this is what is an morphological or immunohistochemical profile of an endocervical carcinoma in this example. That's another example you can see here. You see this ER positivity with this nicely Vimentin staining, more than maybe 50% or 70% cells, and then you don't see that P16 block-like, but you see patchy staining and CA negative, so it's an overlap, but this one is endometrioid carcinoma. This case came to me as, in a 63 years old lady as a atypical hyperplasia. Looks very superficial, but I always say whenever you see this endometrial biopsies with this complex pattern, devil is in the details. You go further and you see marked anaplasia, even though you don't see this invasion, but there's necrosis and marked anaplasia. And even if I'm not seeing frank invasion, I'm suspecting something high grade in this patient, particularly in 63 years old lady. So I thought that this is at least a high-grade adenocarcinoma, even though it was called as atypical endometrial hyperplasia, and it was ER negative. So it again put me towards, are we dealing with something serous? And this was P53 abnormal. You can see this diffuse staining pattern and P16 block-like. So it kind of reinforces towards serous carcinomas of the endometrium when you see P53 abnormal with this block-like staining pattern. Few examples will show you WT1 positivity, which is seen mostly in the serous carcinomas of the ovary. So these are the copy number high. Now I'm coming towards the morphology immuno to the molecular types as we are seeing in the current scenario. And it's also very important to know that whenever you're sampling polyps in the post-menopausal women, make sure if you see high-grade atypia, throw in a p53 staining, because you might be surprised that there's a serous intraepithelial carcinoma, and those are very aggressive tumors, and they have been missed very easily as benign or just as endometrial polyps. And that's one publication from our hospital we had. Without invasion, we had 40% and 52% association of the serous carcinomas is with polyps. So all polyps in elder patients, if you see atypia, make sure you're not missing out on doing a p53 staining. So that's another example, classic, that these tumors are not very proliferative, but they are like more infiltrative, high-grade atypia, very permeating, and you see this abnormal p53 expression and also WT1 positivity, which generally is seen in serous carcinomas of the ovary. If you see this in endometrium, make sure you're ruling out an ovary before considering endometrium, which is very rare but can happen. So again, like I shared with you the scenario of the carcinosarcomas, we don't use the word MMTs with rhabdomyoblastic differentiation reinforced with this desmin and myogen and myod1 positivity. So there have been certain limitations in the morphology with the IHCs, which was realized is trying to differentiate complex atypical hyperplasia from well-differentiated endometrial carcinomas. Grade 2 to grade 3 had poor inter-observer variabilities. They had high inter-observer variabilities, including trying to see tumors with mixed patterns, and I see now endometrial carcinoma is a heterogeneous disease because you can see in a same tumor endometrioid, serous, and clear cell pattern also. It's important that we identify at least serous pattern or the high grade patterns. We don't miss out on those. So it's been seen that these classifications were not very reproducible, they were inter-observer variability, and it was imperfect reflection of the tumor biology. That was realized, and in 2013 came the TCGA, or the Integrated Genomic Categorization of Endometrial Carcinomas, and you have now the 4 genetic types or the flavors of the endometrial carcinomas. You have the poly ultramutated, which are 7%, and these are the good tumors. You have the microsatellite instability hypermutated, 28%, or the MMR deficient tumors, wherein you test all endometrial carcinomas now at our center for the 4 MMR proteins, MLH1, PMS2, MSH2, and MSH6. Copy number low, which is the most frequent, or the grade 1 to 2 endometrial carcinomas, about 40%, and copy number high, which are the serous or the p53 abnormal, which form again the next, the third most common type, which are the most aggressive types. So even you have these 4 types, you can have this combination of more than one, which are called as multiple classifiers, and any combination of the 4 can happen. So this made a lot of sense because you had the POTEC trial, which was the radiation people, and they found that clearly chemotherapy adjuvant CTRT works better for serous carcinomas or the the p53 abnormal copy number high, and the poly can happen across all grades of the tumor. So even if you have a high grade carcinoma which is poly ultramutated, it will do better. You had about 12% of the polymutant cases in this trial which are high grade. Actually, these are all high risk patients, and that is what came out, that serous carcinomas benefit from the adjuvant chemoradiation. In contrast, the poly, which are irrespective of any grade, those patients do well. So it's important that we don't miss out. And what was the challenge was to do polymutation across. So it came out that, do you need to do molecular testing for all cases? But this was a good study that was a bit of a bridge between, what you have and what is there. So this PROMISE classification tells just poly 1 mutation is important, and rest of the 4 types you can use immunohistochemical stains. So a copy number high can be dealt with this p53 abnormal staining pattern. MSI is just equational to MMR proteins, and the most common not specific type is the endometrial carcinomas grade 1, which are ERPR positive. So you just need poly mutation as 1, and the other 3 types can be dealt with immunohistochemical staining. That's the power of these surrogate stains. And that's what I realized with this example in this young patient who came with this endometrial carcinoma with very lymphoepithelioma-like pattern. It's one of the patterns that you can suspect for an MMR deficient tumor. And this tumor was high stage. We lost this patient because she didn't respond to chemotherapy. She had adrenal metastasis, and now we have a hope of immunotherapy for these patients. So it's important that we not only identify the Lynch syndrome based on the MMR, the MSI testing, but also there is a treatment associated implication with these tumors. Now coming again back towards our basics of grossing, and I again remember our grossing days in, at PGIMR Rohtak, when we used to really carefully sample the tissues. And you can see endometrioid carcinomas, when you look at grossing, becomes very important, especially the lower uterine segment, because MMR deficient tumors have a propensity towards lower uterine segment in younger patients. This patient was a 36 years old lady, simultaneously an ovarian tumor, and you can see this tumor is involving the lower uterine segment. So this was an endometrioid carcinoma. It's again a no-brainer, very classic, grade 1 to 2 you would consider. Additionally, there was a clear cell pattern reinforced by napsin A positivity. And that's the time, if you see this ambiguous patterns, lower uterine segment in young patients, you think about MMR deficient tumors. These are mostly ER positive. They can be, even though they are high grade, they could be high grade, they're mostly P53 wild type. And this particular example is showing loss of MLH1 and PMS2 in contrast to MSH2 and MSH6, completely diffused positive staining pattern. So any one of the four loss is called as a deficient, and that just mirrored towards the MSI, which is microsatellite instability. So that's another example of a dedifferentiated pattern you can see with this, and that's the time you can suspect again a MMR deficient tumor. In this particular example, you see this again high grade, but it's ER/PR positive. Generally, high grade serous will show you variable or low ER positivity, but these tumors, even if they are high grade, dedifferentiated mixed patterns, they do show you ER/PR positivity. They can also show you a focal neuroendocrine differentiation, which you can suspect morphologically, but we don't call these as neuroendocrine carcinomas. It's just focal neuroendocrine differentiation, which is dedifferentiated pattern as a spectrum of these endometrioid carcinomas, which are MMR deficient. This example again is MLH1 and PMS2 loss with this MSH2 and MSH6 staining pattern retained. That's again our experience of 50 MMR deficient tumors, and what we learned from this publication was that you see these tumors in young patients, lower uterine segment, lymphoepithelioma-like patterns, the redifferentiated patterns. So those are the times that you can suspect if you don't go all out to test all endometrial carcinomas, which is ideal for the 4 MMR proteins, which is a mirror towards the MSI testing. So what are the uses of MMR protein testing or MSI? Diagnosis of endometrioid carcinoma in certain situations when you can have difficulty with serous versus the endocervical, so this can help. Triaging patients for promoter hypomethylation, which is mostly in MLH1 and PMS2. Then you identify patients with Lynch syndrome, particularly if you see the MSH2 and MSH6 or either of the two losses or complete losses, those have more chances, and we've seen that those patients have multiple cancers. Lynch syndrome, that is one of the reasons why we do MMR protein or the MSI testing. And of course, these patients with high stage disease can be candidates for immunotherapy because you have this lymphoepithelioma-like microenvironment for this immune cells. So they might not respond to chemo, but there is a hope for the immunotherapy because they have a high tumor mutation burden. That's one of the features for triaging tumors for the immunotherapy. So that's another example of a high-grade endometrial carcinoma. You can see a lot of lymphocytes, and you suspect that this could perhaps be a the MMR deficient tumor, as what I did. And this was actually P53 wild type, in contrast towards what I thought that it could be mutation because it's high grade. It was MMR proficient, and ER is diffusely positive. So this was a candidate towards, when you ruled out an MMR, we triaged this for poly mutation, showed this 286 specific mutation, point mutation, single point mutation in the poly, and that's what it is. So these tumors again have, they can have lymphocytes with this high grade morphology, but the important thing why we want to identify these tumors are that they are better tumors. They don't respond, they don't behave, or prognostically they are not bad tumors. That's why we want to identify these 7 to 8% tumors. Even in this high grade, they can have a very high grade morphology, but if it's poly mutation, that patient is not going to have a very aggressive clinical course. So that's our experience at TMH, and we've done now more than 200 patients with poly mutation testing. That's a very high molecular work that I do routinely, and we had this cherry picked cases, 3 out of 30 as a part of our validation, and these are the 3 hotspot mutations at exon 9, 13 and 14 that we do, with this most common 286 point mutation for exon 9, which is most common for poly mutation. So another low hanging fruit towards choices of serous carcinomas which are high grade, which might not respond to chemotherapy, and patients, what is the second line therapy that they can go for is HER2. And we've seen now serous carcinomas or high grade carcinomas again need to be tested for HER2. And you can see this very beautiful example of this diffuse HER2 staining, which is seen in serous carcinomas. And this was just one presentation my student Dr. Parul presented at Florence meeting in ECP this time. And we've identified 19% cases of high grade serous carcinomas showing HER2 positive expression, be it on immunohistochemistry or on FISH, which we triage 2+ cases. So HER2 staining gives a choice towards, trastuzumab, just like in breast, in certain serous carcinomas of the endometrium. So moving towards mesenchymal tumors of the uterus, how I'm doing with time? I have 8 minutes, so I have to quickly go towards the types that we have in mesenchymal tumors are mostly stromal tumors or the smooth muscle tumors. Again, I'm not going too much into the leiomyomatous tumors. It's again very important aspect to cover, because you have the FH deficient smooth muscle tumors that we've uncovered of late, but I'm focusing more on the stromal tumors. And when you have the stromal tumors, we've always felt, the low grade and high grade are based on mitosis. You've seen over the period of time now differentiation in well, moderate, poor. Mitosis is all waned out. It's more like IHC and molecular that is taking up precedence towards prognostic types, and that's another example. Low-grade endometrial stromal sarcomas, very classic morphology, just like a stroma, but they have this tongue-like penetrations all over the uterus, the uterine corpus, and they're mostly positive for CD10. Now, CD10 is not a very perfect stain. It's just to reinforce a low-grade endometrial stromal sarcoma, and most of these tumors are ER/PR positive. That was an example on a 30-year-old lady who had this uterine tumor, which was submitted to me for a review, and it shows a very epithelial differentiation apart from this very stromal type of proliferation. And you wonder perhaps this epithelial differentiation is a part of a carcinosarcoma, but the epithelial or the epithelial-like areas are actually not very bad looking if you see carefully. And these were actually sex cord elements apart from this stromal component that you can see with this CD10, maybe variable desmin and SMA positivity, that this was calrotine and inhibin positive. So this was an endometrial stromal sarcoma with these sex cord-like elements, and of course this was diffusely positive for progesterone receptor. So this patient just goes for a resection of this polypoid tumor rather than a chemotherapy for a carcinosarcoma, which one would offer. So it's another thing to know the spectrum of these tumors, from the just stromal sarcoma towards the sex cord-like elements that you can see. That's an example, another example of a stromal tumor that you see very bland looking, very fibrous looking, wiry like collagen, and then you do CD10, which is very focally positive, desmin is negative, SMA is again negative, ER is variably positive, so PR is focally positive, and you still think that this is in the endometrial stoma, it's in the spectrum of stromal tumors, low grade perhaps. This tumor was diffusely cyclin D1 positive. So this is towards a high grade. So you have now cyclin D1 positivity in the stromal sarcomas diffusely is towards the high grade. And we are not using mitosis anymore as a criteria to say something is low or high grade. So you can see a face of a high grade sarcoma which looks morphologically low grade, but immunohistochemically it's cyclin D1 positive. That's another example of a stromal tumor. Again, it looks here morphologically not low grade, very cellular necrosis, mitosis are there. And these were the differentials, the usual suspects like synovial sarcoma, lyo, if this tumor is occurring in the abdominopelvic location of this particular 43-year-old lady. It was negative for CD10 and all the other usual suspects were ruled out until we thought that this perhaps could be a stromal sarcoma. Cyclin D1 is very focally, it's not very diffusely positive. So in this situation I would go, even if I'm thinking stromal sarcoma, I go to the next choice of markers called BCOR, and that's C10 clone, the diffuse chaining pattern for BCOR again, and we go for FISH because again it's a bit of a complex thing to understand, but I can just try to simplify that when you have a high-grade stromal sarcoma, you think of two choices, the YWHA or the BCOR rearranged tumors. And it's important, we don't have to differentiate these two, but you can use these two stains to say that this is high-grade stromal sarcoma and it's not low-grade stromal sarcoma. We do molecular testing to identify that YWHA gene rearrangement in these high-grade stromal sarcomas, and this was negative. It was also negative for the SS18, ruling out a synovial sarcoma, which is a differential diagnosis in this particular example. So this was a BCOR positive high-grade stromal sarcoma. Patient goes for a chemotherapy just like a high-grade sarcoma. adenosarcoma. Adenosarcomas, you have the atypical or the benign epithelial component, the malignant stromal component. Just like phylloides, a beautiful presentation by Dr. Neeta in the, the phylloids-like appearance that you can see. And it's important that we make sure that we're not missing out on the stromal in terms of this higher grade or the stromal overgrowth or any rhabdomyoblastic differentiation. Periglandular condensation as a part of the spectrum of adenosarcomas, you can see heterologous elements, be it rhabdomyoblastic or cartilaginous, and that's another example of our publication of 19 cases of adenosarcomas dealing with this spectrum of the varied morphologies. Very interesting case of a 45 years old lady with this abdominal mass, and you see very epithelioid tumor, nesting pattern, looks a bit rhabdoid, epithelioid, it's Desmin positive and also positive for HMB45. So any guesses what this stain could be? It's a TFE3 positive malignant pecoma. So that's another interesting example of mesenchymal tumors, the way they have evolved in the uterus, and we thought perhaps these are just smooth muscle differentiation or leiomyomatous tumors, until we realized that they also show melanocytic differentiation. These are myomelanocytic tumors called pecomas, and again there are criteria to say something is benign and malignant pecomas depending upon cellularity, mitosis, necrosis. So why you're trying to identify these tumors? Because again, if it's high stage disease, there is sirolimus or the mTOR inhibitors which are offered to these cases. Coming towards the scenario of cervical lesions, it's all about HPV, and P16 is a good surrogate. That's an example of a SIN3 which you see morphologically, and you reinforce P16 block-like staining pattern to say something is CIN3, which we do, or high-grade SIN. And that's another example. You see this coilocytic atypia beautifully seen in this vaginal biopsy post-treated case of cervical carcinoma, again block-like staining pattern with this high MIB1, and that's what I do. In vulvar tumors or the early lesions, I do P53, P16 and Ki67. It's a good combination of 3 markers to reinforce a morphological pattern, at least of significant SIN, which is 2 and above. So SIN 2 and above is significant SIN. SIN 1 goes for just rescreening, and maybe they might not do something aggressive. Coming towards carcinomas, squamous carcinomas again have been differentiated. Now we don't use well, moderate or poor. Again for adenos also we're not using this. It's all about HPV. So P16 is taken the forefront, and we are trying to differentiate whether tumors are HPV positive or negative. That's an early lesion of an adenocarcinoma in situ seen with this P16 diffuse staining pattern borrowed from an IARC website. That's a case of a cervical growth that I came across, and you can see certain morphological features that I'll point here, which is called apical mitosis and apoptosis, and these are the parameters towards saying something is endocervical carcinoma, which is perhaps likely HPV associated. So it's morphology which is telling actually the underlying genetic or the underlying the viral associated subtype of a tumor. Apical mitosis and apoptosis, these are 2 features in adenocarcinomas of cervix which are pointers towards an HPV associated, and these are the desirable criteria that we have in the WHO fascicle 5th edition, and that's what you see with your morphology reinforced with diffuse block-like staining pattern of P16 as a part of this endocervical carcinoma, which is most frequent HPV associated P16 block-like staining. These are Vimentin negative, like I mentioned. CEA will be variably positive, ER is mostly negative, and P53 is mostly wild type. Again, sharing examples of endometrioid versus endocervical, you can see overlap morphologies, but you see block-like staining pattern with P16, negative staining for the endometrioid. You can see patterns of endocervical carcinoma that we never thought. Clear cells, signet ring cells. We thought these are mostly metastatic, but you see all these patterns reinforced with beautifully block-like staining pattern. These are all mucinous carcinomas of endocervix, HPV associated, likely HPV associated with this P16 abnormal staining pattern. Something that can be missed, which is aggressive, is a HPV independent gastric type. These are the adenoma malignum. I think I'm time's up here, so I think I'll just quickly go towards mentioning that gastric type adenocarcinomas can be missed, but it's important that we recognize these tumors. And that's all about the gastric adenocarcinomas. I'm not going to details towards the data TMH. So that's a rare example of gastric carcinomas, which surprisingly can also be P16 positive. And that's the time one goes from morphology, immuno to molecular. And we don't have the RNA scope at this point in time, but you can see rare examples of this gastric type also can be HPV positive. So I'm just finishing my talk with some neuroendocrine tumors, which I think a lot of us know and realize it's just that certain morphological patterns which can be missed apart from the usual small cell carcinoma is a large cell carcinoma. And this particular example was called actually as adenocarcinoma with this musicarmine diffusely positive. So if you see the morphology of this salt and pepper chromatin with this any variable pattern, and make sure 2 stains like synaptophysin, chromogranin, INSM1 and CD56. So I do 4 stains, 2 out of these positive, it's good to say something is neuroendocrine carcinoma, and these can be P16 block like staining pattern. One of the mimics in this particular example is a melanoma with a sudden nuclear pleomorphism, especially in cervicovaginal sites. We don't miss out on this tumor, as we don't miss out on Burkitt's or the high-grade non-Hodgkin's lymphoma. So this was a recent example. I'm just finishing my talk with this example of a 28 years old lady with abdominal mass, and she was referred with a diagnosis of rhabdomyosarcoma. Any thoughts for the postgraduates, what you see here? So it's an abdominal mass referred with the diagnosis of rhabdomyosarcoma, because I do soft tissue tumor, so it was, it's frankly a malignant tumor. But what do you think? And you have the panel of markers here, which I did. Any thoughts from the postgraduates? It's a final example that I'm sharing here. I'm just circling back to my talk from who done it here. So my question here was, what about the ovaries? Because I'm seeing something very morphologically typical. Again, thanks to my morphology foundation at my from where I did my PG, I said this is a classic dysgerminoma. I see you have high-grade malignant cells, lot of lymphocytes trafficking through. So my question was, what about the ovary? And they said that the radiologist says, the report says ovaries are normal. I still didn't. I pursued that with the, now that's how, if you have a morphological, thought in your mind, you pursue with your choice of markers. I did c-KIT and sulfur, and it was diffusely positive. And then I said they had a review, and it was actually an ovarian mass. There was a printout about, of another patient whose radiology report got stuck to the that case, and they said that it was normal. Actually, she had an ovarian mass. So rhabdomyosarcoma abdominal, the worst tumor, and you have a germ cell tumor which will melt to radiation or chemo. So that's what the point here is I'm trying to make is morphology with your choice of immunostains. And I think we can say that it has definitely a role. Ovarian tumors, like I mentioned, primary versus metastatic, colorectal, certain types in terms of the uncommon scenarios that you can uncover, again based on your morphology, clinical settings, uterine tumors, endometrial, we have the 4 subtypes molecular where IHC can help us with our morphology. It can be complex because I see more than one pattern, but again you see a clear cell pattern, you do an absent, you see a serous pattern, you do a P53 and P16. That's how you can uncover all these aggressive types which have their treatment implications. Mesenchymal tumors and evolving spectrum. I couldn't cover, there's so much that you can talk about mesenchymal tumors. In cervical tumors, it's all about HPV with P16 Roche clone. I mean, I don't have any commercial interest, but that is the best thing that you can work with. So you try to separate the HPV associated which you can do in morphological features for the adenocarcinomas versus HPV independent. At all times, I always say, morphology, it's all about morphology, that you integrate IHCs or molecular in a context, and it's important that we make our choices appropriate based on morphology. So thank you very much. Again, I'm very much honored to be here, and I'll be happy to take questions. And thanks for the extra time, and apologize for that.
Thank you, Dr. Bharat, for such an extensive, lucid talk about IHC in gynecological malignancies. Thank you so much. And it's not only you are proud of PGIMS, PGIMS is proud of its student, Dr. Bharat. We are proud of you, Dr. Bharat.
Thank you so much, ma'am. It's an honor for me. Thank you. Any questions, I'll be happy to answer. I'm sure there must be, because gynec is so vast these days. So I'd be happy to take questions if anybody has. I think probably it was an overdose. Yes. Yes, sir. Yeah. So, sir, that's a great question, and there's been, a shift towards what markers have been, and what are the best ones. So, if you ask me, my choice for epithelial markers will be Claudin-4, which we don't have, which is on my wish list. BARIP4 that we have. So, Claudin-4 is good for epithelial differentiation, and BARIP4 and MOC31 if you have whatever. For mesothelial, I go for calretinin and CK5/6. Now, if a scenario for mesothelial reactive versus malignant is, best is BAP1, MTAP. BAP1 we have, MTAP we don't have. But if none is there, I still use conventionally Desmin. So these are the choices. And then trying to subtype adenocarcinomas in terms of ovarian or the Mullerian, Taxate is the best marker. And we play with CK720 for the GI possibility. And then again, the scenarios that we have, if it's a lung, then TTF1 and Napsin again. So these are the markers. I don't use HBME anymore. I don't use WT1.
Nineteen point nine. 19.9?
Again, it's not a very perfect because you can see it in mass.
Okay.
CA, I would value the serums are CA level. The serums are not IHC that much. Unless it's endocervix.
Hello, sir. I have one question. Yes. The pole mutation you are, for finding the pole mutation, which technique you are using? Is it NGS or Sanger sequencing? PCR, we get satisfactory results.
Yes, so that's a great question. So, because every time you might not have your all exons working. So it's about forward and backward that you have to do for all exons, like 286, your 2 of exon 9, 3 of 13 and 4 of 14. So it might not be coming for all, so we do repeat. So because we do forward and backward for all. So if, forward for 13 is not coming, so I'll do a backward. But if I'm not seeing all coming, even with the repeat, so we have a we have a format in which we say polymutation positive or wild type. If even one of these has not worked, even with repeat, so we put it in others. So can be a challenge because we repeat, and tissue is an issue. So that's the limitation that you have, So variable fixation can be an issue. And it's very important, again, a nice point, because endometrium is a very fragile tissue. So fixation is so paramount importance. Do you do IHCs or molecular? It should be very, adequately, appropriately, in time fixed. That's very important for endometrium because it's such a fragile tissue, and it influences your IHCs and particularly polymutation tests that we do. Yeah.
What is the prevalence in your setup? Pole mutation. What is the prevalence of pole mutation in endometrial cancer?
Okay. Yeah, so it goes, like I mentioned, we've seen in 30 cases that we did, 3 were positive. So we are just very much in the range of about 7 to 8% that, is seen. In the PORTEC trial, for the high risk, it went towards 12%, which you can see and expect. But I think it's more towards 7%, 7 to 8 is what we are seeing, just pretty much with the Western population. Yeah.
Thank you.
Yeah.
So a huge round of applause for Dr. Bharat Peki, sir, and heartfelt gratitude for this amazing session and Q&A, sir. Now I would request our respected chairpersons to please present a memento to sir. Thank you so much, sir. I would like to invite Dr. Pooja ma'am, Dean Academics, Professor and Head, SHKM NU, to please come on stage and present a memento to our esteemed chairpersons.
प्ले कर देना.
Now to move forward to the next session, it is my pleasure to introduce and invite our respected chairperson, Dr. B.M. Bhatnagar, consultant pathologist, Bhatnagar Path Lab and Maternity Hospital, Gurugram, Dr. Anurag Ambrose Singh, Professor and Head Medicine, SHKM NU, and Dr. Rajiv Kumar, Professor and Head Forensic Medicine, SHKM NU, to please come on stage. The understanding of patterns and terminologies forms the basis for routine microscopic diagnosis. Many lesions are recognized by characteristic pattern in which the cells are arranged. To detail further, let me take privilege to invite our next speaker, Dr. Rajiv Sen sir, to give his insights on terminologies and patterns in histopathology.
वो कॉलर माइक है क्या भाई? I like that all the postgraduates should come up in front because this talk is basically oriented for them. This is the last talk and this is just ABC of pathology. So after these sessions with high scientific value, I am just teaching like ABC. So this is basically oriented for postgraduates. So, terminologies have overlapping features and they refer to mimicry to some normal structures, patterns. Pathologists used to be fond of eatables, so sometimes shapes of eatables or their appearances. So we'll do some nuclear features, some cytoplasmic details, types and patterns of necrosis, types of stroma, pattern cell arrangement, and so this talk is basically oriented in relation to hematoxin and eosin appearance of tissue sections, and that is from where we should have been starting for postgraduates. Nuclear shapes, so round, they can be round, oval, flat. Flat, anybody can cite an example of flat nuclei? Like endothelial cells in venules, flat nuclei like hair. And they can be horseshoe or kidney, this is kidney shaped rather, and then segmented or lobulated. What is lobulated? When they are folded. Coffee bean like hair, a cleaved appearance. So probably many of us would not have seen what are coffee bean, but remember this feature. Now when you are seeing under microscope, give this thing, focus on nuclear membrane. Like in thickened nuclear membrane, as in plasma cells, nuclear membrane is quite distinct. Then dents and grooves, you refer to dents and grooves in papillary carcinoma like here. What are grooves? It appears that nuclear membrane is dipping inside. So these are nuclear grooves. So they are particularly relevant in relation to papillary carcinoma and in relation to follicular type of lymphomas. Folds, and then molding. What is molding? What do you understand by molding? The cytoplasm has disappeared between two nuclear membranes. So two nuclear membranes have come in a position to each other, that is molding. That can be seen in herpetic infection, small cell carcinoma. Overlapping in contrast to nuclear molding, where cytoplasm between two nuclear membranes have disappeared. In overlapping, there is overlapping, I mean overriding of nucleus over each other, like here and here. And what is crowding? Crowding refers to increased density of nuclei in a given area. So that is crowding. So all these three things, crowding, and overlapping and molding that we use in relation to papillary carcinoma, sometimes in small cell carcinomas. And concentrate on chromatin, condensed and hyperchromatic when it is ink dot like appearance. Small lymphocyte are one example. Vesicular, what do we mean by vesicular? Nucleus appears as if it has been filled up with water. So chromatin is very, very dispersed, almost indistinct. That is like hair. That is vesicular, as in adenocarcinoma of cervix. Salt and pepper, this is a very commonly used word, salt and pepper or stippled chromatin. तो जैसे सफ़ेद नमक एक उस पर प्लेट में रखिए, ऊपर से थोड़ी काली मिर्च के दाने डाल दीजिए. That is the stippled or salt and pepper appearance. Like in, and this is considered quite suggestive of neuroendocrine differentiation. Reticulogranular and some fibers and some dots. So I think this I have covered already. Coarse chromatin, clump chromatin and smudge chromatin. When there is loss of distinction of chromatin pattern, that is smudge chromatin. Then you look for nucleoli which could be of different colors, eosinophilic, basophilic, amphophilic, which could be indistinct, which could be prominent, inconspicuous as in lymphoblast, and conspicuous eosinophilic nuclei in embryoid shape in monocytoid blast, which could be very prominent, macronucleoli as in hepatocellular carcinoma. Classically in Reed-Sternberg cell, as per your undergraduate teaching, these are eosinophilic nucleoli with owl-eye appearance, meaning there is clearing of chromatin around these nucleoli. So that is owl-eye appearance, and they could be sky blue, as Dr. T. Singh was saying in promonoblast or promonocyte. When nuclei are lobulated, and they could be basophilic nucleoli here, as in Richter syndrome. Nucleoli could be centrally located, as in RS cells. They could be eccentric near nuclear membrane, and they could be membrane bound. Now this is terminology, membrane bound, that we generally use in relation to showing differentiation, lymphoid neoplasm showing differentiation towards centrocytic, centroblastic or follicular center cell. So what is happening is that nucleoli appear to be connected either to the nuclear membrane or to a dent which is coming from the nuclear membrane to connect with the nucleoli. That is membrane bound nucleolus. Inclusions. So you know about CMV inclusion, and there could be viral inclusions, acidophilic inclusions in herpes simplex. Pseudo inclusion. What do we mean by pseudo inclusion? Cytoplasmic invagination into the nucleus, that is pseudo inclusion. And then pseudo inclusion. What is pseudo inclusion? When chromatin is not properly fixed, so during the staining process some portion of nuclear chromatin is washed off, leaving a vacuole, that is pseudo inclusion. So viral inclusion, Negri bodies, and CMV inclusion, intranuclear inclusions, large eosinophilic inclusion in the nuclei, HSV inclusions, coelocytic atypia. So these are all viral inclusions. Then you look for cytoplasmic details, which could be basophilic, which could be eosinophilic, which could be clear or chromophobic. Cytoplasm is almost clear here, it is not reflecting, or amphophilic, meaning it is staining in between basophilic and eosinophilic. spatial appearances of cytoplasm, and this this is basic introduction to morphology. This is by no way is a very comprehensive this thing on this, just introductory. Plus I am trying to be short because we are already running quite late. So glassy cytoplasm. Now glassy cytoplasm, you would have seen frosted glass generally used in either in toilets or sometimes in kitchen, where a frosted glass is put on through which you cannot see outside. So that appearance of cytoplasm, like here, this is eosinophilic cytoplasm and this is glassy cytoplasm. Or cigarette ring, all of you know that, or soap bubble or chordoid appearance. So that is seen in chondrosarcoma or in chordomas, also referred to as physalis, where there is where numerous vacuoles in the cytoplasm as in plant-like cells, and ballooning degeneration, when there is lot of water accumulated in the hepatocytes giving small and large vacuole resulting in swollen up hepatocytes, and when there is presence of pigment in those hepatocytes, it is referred to as feathery degeneration. Oncocytic, so you have large eosinophilic, prominent eosinophilic granule in large cells, and this is eosinophilic cytoplasm, but you have perinuclear clearing. Cytoplasmic vacuolization could be because of presence of edema, intracytoplasmic inclusion of water, which is cleared off during processing, or glycogen or fat during processing. So edema, as in proximal convoluted tubule of kidney, very commonly seen, very early reaction pattern in kidney. And in glycogen storage disease, you can see this type of clearing in the cytoplasm in muscles and liver, kidney and elsewhere, and fatty liver. So glycogen can be demonstrated with best carmine or periodic acid chip, which is glycogen diastase sensitive. For demonstrating fat, you have to do frozen section and use fat soluble dye like Sudan or oil red O. Mucin can also be looking like vacuolated. So mucicarbon periodic acid chip for Alcian blue. Brown pigment, which can be melanin, and you know how to stain for melanin, silver stains, Mason Fontana, or bleaching with potassium permanganate. And for melanocytic cells, HMB45 melan immunohistochemical stain, and lipofuscin. Anybody who can tell me what is lipofuscin? These are lipid derived from disintegration of membranes, subcellular membranes. So autophagic vacuole and indigestible lipid in them. So that is, I am not yet very comfortable using these gadgets. So this is the yellow brown pigment which is deposited at the poles of the nuclei, and generally it is associated with cachexia or advanced aging, where there is lot of subcellular autophagic reaction and lot of deposition of these. So sometimes cachectic diseases, a small heart recovered from in autopsy from a cachectic patient would look pale brown in appearance and will be atrophic. So it used to be referred to as brown atrophy of heart, brown because of deposition of this lipofuscin pigment. And formalin, if your fixative is acidic, If it is not neutral buffered formal saline, then sometimes you find this acid hematine deposition in the section. And hemocydin is also brown in color, which stains with Prussian blue, deposited in macrophages and sometimes in parenchymal cells, and bile pigment which can be seen in liver. And then asteroid bodies which can be seen in some sarcoid granulomas, and concentric calcificated structures which are referred to as Michaelis-Guttman bodies seen in some xanthogranulomatous inflammation, which are known as क्या बोलते हैं Melacoplakias, generally seen in genitourinary tract. Then you look for mitosis, serrated borders and a vacuole surrounding it, and this could be bipolar normal and this could be abnormal mitotic activity. It is to be differentiated from karyoraxis, where you find multiple nucleus fragmenting into multiple fragments. Squamous differentiation, either you should find individual cell keratinization or you should find intercellular bridges morphologically, or as earlier speaker Bharat and Neeta said, P40 and P63. So intercellular bridges are being seen here much better. Giant cells. So giant cells, most of you know what is a Langerhans giant cell, where you find peripheral arrangement of identical looking nuclei in the periphery in a semicircle, which is referred to as horseshoe arrangement. So this is a type of foreign body giant cell with a typical arrangement of nuclei here. Now in xanthomas or fat necrosis, you find two-tone giant cells where nuclei are condensed around a central eosinophilic structure and connected to cell membrane with some vacuolated cytoplasm or through cytoplasmic threads. Now what are osteoclast like giant cells? When you have identical round nuclei condensed in the center, these are osteoclast like giant cells. Foreign body giant cells, when there is a irregular collection of nuclei, these are types of histiocytes with either vacuole or some foreign bodies within them, and if you have anaplastic nuclei, they could be tumor giant cells. So granulomas, they could be foreign body granulomas when you have collection of foreign body giant cells, and they could be sarcoid. What is sarcoid like granuloma? Anybody? Sarcoid like or tuberculoid granulomas? What are these? When you have collection of epithelioid cells without necrosis, these are sarcoid like granulomas. They may have a collection of or rim of lymphocytes around them, with or without Langerhans type of giant cells. Xanthogranulomatous, I told you about macrophages or histiocytes with lot of vacuolated cytoplasm as here. So these are macrophages, histiocytes, and these are two-tone giant cells in between. So this is a xanthogranulomatous structure. They can be seen in inflammatory conditions, they can be seen in some storage disorders. Tuberculoid versus tubercular, if you have caseation, it is tubercular. If caseation is absence, this is tuberculoid, as in tuberculoid leprosy. So only difference is absence of caseation. You may still have a rim of lymphocyte. I mean, morphological features may be overlapping, except caseation necrosis, which we still consider to be of absolute value in differentiating tuberculoid from tuberculous inflammation. Osteoid and bone, what is the difference in osteoid and bone? In osteoid there is absence of calcification. So, there is only matrix with hydroxyapatite crystals, and they can be woven bone, which is immature bone due to haphazard arrangement of collagen fiber. They can be lamellar layered structures, trabecular and compact and cancellous bones. And sometimes it is said that osteonic sarcoma shows malignant bone. So, bone actually it is a malignant tumor which shows a pattern of bone where these malignant cells are producing osteoid around themselves. Generally in reactive bone you have bony lamellae lined by osteoblast, but in at least some well differentiated osteogenic sarcomas may show that type of pattern also, but these frankly anaplastic osteogenic sarcoma may show production of matrix around anaplastic malignant cells. Chondroitin and myxoid, when you have these cartilaginous cells, this is known as chondroid. Myxoid, when you have stellate cells with matrix bluish, light bluish vacuolated matrix around, this is myxoid matrix, and this is 5. So, basically we start our section viewing with H&E stain, and these are the terminologies from which we start writing our, with which we start writing our description of a section. So, all of these terminologies and pictures are pertaining to hematoxin and eosin. So, this is a collagen, you recognize this collagenous appearance, you have seen it, and this is chondromyxoid, where you have some vacuolated cells enclosing chondrocyte like cells and some cells, some stellate like cells. I think it is not working on this. So, stellate cells is myxoid, and if you have some collagen, some myxoid, it is fibromyxoid. So, combination thereof. Hyalinization is dense collagenous appearance with reduced hypocellularity and dense eosinophilic collagenous eosinophilic hyalinized material. If it is getting calcified also, it may be referred to as sclerosed. Amyloid, you know amyloid, you have been having a frequent this thing in undergraduate teaching, an extracellular deposit of fibrillary protein. So, you have to differentiate between hyaline and amyloid. In situ, when abnormal cells are found within a limited anatomical space, invasion, Neeta showed a beautiful picture when it is getting into outside that anatomical space and eliciting a reaction. It is not a sectioning artifact, then it will be evoking a response from stroma in the form of either fibrosis or inflammation or necrosis. And this invasion could be infiltrating or pushing. When it is broad based, then it is broad front invasion, it is pushing invasion, infiltration. Then you have to, whenever you are seeing a tumor, you must start with whether there is a capsule, true, or it is only a rim of fibrous tissue around it. So, fibroadventitious capsule, that is a true capsule. Generally you see it at a lower magnification, and you do not have a layer here, here only some compressed, there is a fibrous reaction the adjoining host tissue. So, that is a pseudo capsule. Pattern of necrosis, I think I can omit that, this you read and teach in to undergraduates, all the postgraduates treat them, except fibrinoid necrosis probably, which is supposed to be, which is not actually a necrosis pattern. Fibrinoid necrosis, because by definition necrosis refers to cell death, morphological appearance of cell death in a living tissue, that is necrosis by definition. In fibrinoid necrosis it is not cell death, it is deposit of a material on HND, looks like on HND stain, this looks like fibrin and platelet thrombus. Therefore, it is referred to as fibrinoid. What I recollect in my undergraduate days, it used to be considered pathognomonic of malignant hypertension, one of the differences between benign and malignant hypertension. Now, in tissue sections, if we are seeing it in skin biopsy, we think of autoimmune disorders, SLE and polyarthritis nodosa and other things. These are punctate necrosis, when there is a 2 or 3 cells, necrosis of 2 or 3 cells, it is punctate. Comedonecrosis, when central portion of a tumor shows necrosis. Geographic necrosis, abrupt necrosis. So, this type of necrosis to be differentiated from infarction, because this type of necrosis in a tumor is indicative of higher grade as compared to infarction necrosis or ischemic necrosis. So, I think this has been. Now, patterns of histological patterns of cell arrangement. So, this is derived from your recollection of your microanatomy or histological section of normal tissues. Most of the terminology that we use here are derived from mimicry or appearance to normal histological structures or pattern of differentiation. कुछ सेल्स हैं एम्ब्रियोनल स्ट्रक्चर्स हैं उनकी, फिर उनके फीटल डेवलपमेंटल स्ट्रक्चर्स हैं, उसके बाद फिर चाइल्डहुड पैटर्न्स हैं, फिर एडल्ट पैटर्न्स हैं. तो पैटर्न्स ऑफ डिफरेंशिएशन लाइक न्यूरोब्लास्ट इज अ स्मॉल प्रिमिटिव सेल, फिर वो रोजेट, व्हाट आर रोजेट्स? रोजेट्स इंडिकेट न्यूरल डिफरेंशिएशन. इन न्यूरोब्लास्टोमा रोजेट डिफरेंशिएट. कौन से न्यूरोब्लास्टोमा में कौन से रोजेट्स? थर्ड ईयर वाले कोई नहीं है भाई? होमर राइट. और आंख में जो है रेटिनोब्लास्टोमा में. सो आइडिया इज दैट when we are using these terminologies, we are trying to say that this is showing differentiation towards that type of structure. So, this is mass forming lesions. Now, neoplasia, new growth or discoordinated, uncoordinated with the normal surrounding. What are hematomas? They may also be mass forming lesions. So, hematomas are masses formed, tumor like masses composed of mature normal cells in usual location. Say for example, you have a very disfiguring type of lesion in face, बहुत ग्रोथ भी हो जाती है एबनॉर्मल, पर वो न्यूरोप्लेजिया नहीं होता है, न्यूरोफाइब्रोमास होते हैं फेस पे, और लिम्फेंजियोमास होते हैं, बहुत बड़े बड़े सिस्टिक डायलिटेशन ऑफ स्पेसेस ऑफ लिम्फेटिक स्पेसेस, मोर डिसफिगरिंग देन अ ट्यूमर वुड बी, और एक्सटेंट भी उनकी बहुत मैसिव हो सकती है. कोरिस्टोमास, tumor like masses consisting of normal cells in abnormal location, and heterotopias, presence of particular tissue type at non-physiological site. So, for considering glandular differentiation, as in case of salivary gland, you have a duct here. ये lobule, और इसमें लोब्यूल में आपको म्यूकस सिक्रीटिंग सेल्स हैं और दूसरे एसिनिक सेल्स हैं, और सिक्रीशन कैरिंग करने वाली जो स्ट्रक्चर्स हैं वो डक्ट है. तो जो एसिनाई होते हैं they have abundant cytoplasm compared to ducts which have scanty cytoplasm. So glandular pattern, when you have cells radiating around the lumen with nuclei pointed towards the center of the lumen. Ductal patterns, less abundant cytoplasm and smaller lumina, crowded nuclei. Alveolar, which mimics alveoli of lung, central empty space, peripheral arrangement of nuclei of the cells hanging from a septa, vascular, fibrovascular septa. Hobnail, apical nuclei hanging into the lumen, as Bharat was showing clear cell carcinomas of ovary, probably a misnomer. Follicular pattern mimicking to follicles of thyroid gland, endocrine pattern. Epithelioid looking, cells which are looking like epithelial cells but are not epithelial. So generally we are using either it in relation to some histiocytes which have transformed their morphology, or sometimes some tumors, epithelioid, particularly some connective tissue tumors, because epithelial tumors are epithelial, they are not epithelioid. So connective tissue tumors which are assuming epithelial looking morphology. So in relation to epithelioid cells, indistinct cell borders, abundant eosinophilic cytoplasm and vesicular nuclei. Lipidic pattern, a pattern of cell proliferation along the lining of the alveolar structure. So it used to be a difficult thing to document infiltration invasion in these tumors, because these cells will seldom be seen invaginating into the stroma. Lobular pattern, Neeta showed that. So this is in situ type thing. When there is infiltration, you find India file pattern and you find disc cohesive cells, and these are beta catenin positive. Insular pattern, growth pattern comprising of tightly packed islands or nests. Papillary versus micropapillary, most of you know that. Papillary structure show a vascular structure in the core, micropapillary. Its shape is papillary like, but there is absence of vascular core in the center. Cribiform, बड़ा अच्छा सा एग्जाम्पल दिया था डॉक्टर नीता ने, कुकी कटर अपीयरेंस. Adenoid cystic, nuclei are pointing towards. So we are using these terminologies in relation to certain tumors. Like adenoid cystic, generally we use in relation to salivary gland tumors, and cribiform in relation to carcinoma of breast. But if you find similar appearance, I mean adenoid cystic appearance in breast, that is an unusual pattern, but you still call it adenoid cystic pattern. Organoid meshwork of thin fibrovascular septa surrounding individual small nests of tumor cells, like here. As in paraganglioma or some other neuroendocrine tumors. Nesting pattern, a small focus accumulation of one type of cell different from the other cells, as in pancreas, islets of Langerhans. Solid pattern, sheets of cells, no glandular lumina. Symplasmic, when cytoplasmic membrane of different cells are not distinct. So it appears, are you dealing with a single cell or multiple cells fusing together? That is symplasmic appearance. Palisation, as the arrangement of basal cells in skin. Trabeculae as the arrangement of hepatocytes in a lobule of liver. So, rosette, flower-like halo or spoke wheel arrangement of cells around a central structure, especially neoplasm of neuroblastic or neuroectodermal origin. So, as I said, in neuroblastoma you have smaller compact structures with a central small lumen containing neuropil. And true rosettes are to be differentiated from pseudo rosettes. In pseudo rosettes you have a vascular structure around which you find some tumor cells surviving. These are pseudo rosettes. True rosettes indicate that type of differentiation. So, pseudo rosettes generally show a growth pattern, type of vascular growth pattern. So, in ependymoma you have both true and pseudo rosettes. You have these types of ciliated structures in the lumen in ependymoma. In perivascular rosettes, pseudo rosette, you have a vascular structure on which you find cell processes arranged. Flexner Wintersteiner rosette, you have in कहाँ पर होते हैं Flexner Winter retinoblastoma. So they are photoreceptor differentiation, and Homer right I told you earlier. So this is a fish herringbone, this type of arrangement of cells, that is called as herringbone pattern, generally considered suggestive of fibrosarcoma type of differentiation. Story form, there was a time science, the science that we are dealing with is a ever evolving concept, and what is truth today may not be the absolute fact maybe 5 or 7 years later. There was a time when I was doing my post graduation, most of the soft tissue tumors used to be classified as malignant fibrous histiocytoma. No more, after invent of immunohistochemistry and molecular diagnosis, this term is now discarded, not considered worth retaining in histopathology, and this used to be the characteristic pattern, story-form pattern. Dr. Bhatnagar might remember those days when when there will be spokes from a central structure radiating, and sweeping bundles, we refer to this type of pattern, or we use this terminology generally to describe fibromatosis. Sweeping, अगर कहीं dusty space में झाड़ू के तिनके वाली झाड़ू से झाड़ू लगाई जाए, so you have some arrangement of nuclei but in between some dots like structures, low grade nuclei, low cellularity. Fascicular pattern, parallel arrangement of multiple rows of nuclei or cells, that is fascicular pattern. Then perivascular, India file, this single cell arrangement pattern, India file pattern. Vascular arrangement, plexiform, chicken wire. These terminologies are self-explanatory. I have also put in some examples. Stag horn, so, and mosaic pattern. I think we are pretty late. Even I am not understanding what I am speaking. So, what will be happening to the listeners? Rhabdoid, when you have deep eosinophilic inclusion like cytoplasm and this is generally considered suggestive of differentiation of a tumor showing skeletal muscle differentiation or rhabdomyosarcoma. Cellular blue, when you have scanty cytoplasm, cellular blue tumor, very scanty, hypercellular, dark blue appearance at lower magnification without any pink in between. So, a small spindle cell tumor, a very short of immunohistochemistry and other things, and patternless arrangement. P-comas already covered. Now, how do you conclude your reporting? Now, this is something which may have sometimes medical legal connotation. Compared to other branches of medicine, where things are very dynamic, one may or may not be keeping the records of whatever all is happening, but your reporting is a documented thing. आपने जो अपनी रिपोर्ट में लिखा उसकी हिमेटॉक्सिन ईओसिन सेक्शन और स्पेशल स्ट्रेन और जो भी आपने किया है वो आपके पास, you are keeping it as a record, and if anybody wants, you are giving it out. So sometimes we are giving it suggestive of and we think we have not said this is that, but this is our perspective. Is this perspective shared by those who are on the other side? Supposedly I have said this is suspicious of malignancy, clinicians excise that specimen or this portion and it doesn't finally turns out to be malignant, as in needle biopsy of breast, and patient goes in court. So what I am thinking is I haven't said malignancy, but is judge agreeing with you, is police agreeing with you, is the opposition's lawyer agreeing with you, and what is the perspective of consumer redressal forum, or what is the redressal of your council? Is it comprising of only pathologists or there are other clinicians? Because the surgeon who would have removed that breast would be saying that you have said malignancy, you have used the word, and therefore to overcome this there have been so much of change in terminology and so many patterns, and in cytology particularly where we are using it as a screening thing, we have forgotten to report as there is only one thing, benign or malignant. There is nothing else in between. Like in lymph node you say it is positive or negative for malignancy, but what is tuberculosis? In FNAC you can still diagnose tuberculosis if you are finding caseation and AFB. So whatever Milan system and so many other systems which are talking of, either you are saying malignancy or you are saying this is benign or you are saying something in between. So you have to be sure of your terminologies as per changing requirements and needs and patterns. So with that I think I will be concluding. Still 8 minutes 20 seconds left. Thank you very much for all of your patience, for bearing with me in these late hours when ordinarily you would have finished your day if it has not been a conference, and probably you would not have been captive audience. Thank you.
A round of applause for Dr. Rajiv Sen, sir. Thank you so much, sir, for this enlightening session.
And don't ask for them to ask questions on this.
Yes.
Anybody who wants to ask a question, you can always come to me or you can ask me on WhatsApp or telephonically, or most welcome.
Thank you, Dr. Rajiv Sen, for a very clear description of the terminologies and patterns in pathology. I think very useful presentation for all, especially the PGs of pathology.
I was requesting the organizers, since I had actually cut it short, that if they can make a link of all the talks, then it might be useful. Like I was feeling, Bharat is also, even I was finding it for myself difficult to follow whatever all he was trying to say. and if I read it sometimes later at leisure, I might be able to comprehend it better. So if it can be converted into a link and all the talks, so that will be useful.
Now I would like to request our respected chairperson to present a memento to our respected speaker, Dr. Rajiv Sen.
थैंक यू सर, थैंक यू, थैंक यू. आप नींद से लड़ रहे थे. मुझे भी आ रही है नींद, तो इस समय मैं गाड़ी में बैठ के सो रहा होता हूँ. ड्राइवर गाड़ी चला रहा होता.
Now I would like to request Dr. Sheetal Gole ma'am to come on stage and hand over the memento to our respected chairpersons.
क्या हुआ?
Yes, ma'am. Yes, sir. Dr. B.M. Bhatnagar, Dr. Anurag Amrose Singh,
पता नहीं.
Now I would like to invite
चलो हो गया, कोई बात नहीं. फट है. नहीं मैम, हो गया बस.
चला दो.
Thank you so much, sir. With this amazing session, we come to the end of an academic fiesta. And I would like to thank all the distinguished guests, speakers, and the delegates for their contribution. With this, I would like to call Dr. Sonia to please commence the valedictory function.
So teamwork makes the dream work. Good evening, distinguished guests and dear participants. With immense pleasure, I, Dr. Sonia, delighted to commence the valedictory function of 2nd Annual Conference of IAPM Haryana Chapter and 14th Annual Conference of APP Haryana. Organizers of HAPPCON and APP team have burned the candle at both the ends and brought this fabulous event together for all of us. And it's time to celebrate the efforts, contributions, and achievement of everyone involved. So to begin with the ceremony, I would like to invite respected Dr. Pooja ma'am, organizing chairperson SHKM, to please come on the stage and present awards to the winners of oral paper and poster presentation. Dr. Pooja ma'am, please.
सर ओटर पेपर का तो मैम से दिलाते पोस्टर. हाँ ओके.
इफ यू डोंट माइंड ना, सारी चीज़ें आप ही 2-3 बंदे प्रेजेंट कर रहे हो, तो मैं चाह रहा था कि जैसे डॉक्टर संदीप कालरा से 2-3 दिलवा दो.
अच्छा.
वो अच्छा लगेगा.
ठीक. डॉक्टर सुनीता सिंह है. हाँ डॉक्टर. ठीक है. कौन बैठ. हाँ वो कर दिया. पोस्टर की है ना. नहीं ये तो.
The oral presentation, third prize goes to Dr. Nivedita Devi, SGT Gurugram. Topic is study of reticulocyte parameters in iron deficiency anemia and other microcytic hypochromic anemia in pediatric age group. Dr. Pawan will take the award in behalf of Dr. Nivedita. I would like also invite Dr. Rajiv Sen. Rajiv Sen sir, to give the second award to Dr. Anku Alisha of PGIMS Rohtak. The topic is assessment of immunohistochemical expression of HER2 new in gastric adenocarcinomas. बोल देती हूँ ना सेकंड पे होल्ड करते हैं पीजीएमएस रोहतक का सेकंड वाली में तो कोई है ही नहीं फर्स्ट वाला बोल दिया ये तो अंकुलिशा सुनो ये तो बोल दिया Here, Dr. Anku Alisha from PGIMS Rohtak. Next invite करने से पहले पूछ लो थर्ड बंदा जो है फर्स्ट है Now first prize goes to Dr. Shagud Pragya from ESI Basai Darapur, New Delhi. It is role of proliferation marker cyclin D1 and Ki67 to solve the diagnostic dilemma between psoriasis and other psoriasiform dermatitis, a clinico-pathological study.
Is there?
Now, from the poster presentation, I would like to invite Dr. Sanjeev Kalra, sir, to please come on stage. So, third prize goes to Aprajita Garg, non-Hodgkin lymphoma of the nasal cavity and paranasal sinuses, a short case series of 6 cases. I think she has left. Second is Meghna Yadav, papillary cystadenoma of the BPS of the epididymis, Meghna Yadav from BPS Kanpur. Anyone from Kanpur? And first prize goes to Hemant and from PGIMS Rohtak. And the topic is glioblastoma presenting as cervical lymph node metastasis, a rare case report, diagnosis by fine needle aspiration cytology. I would like to acknowledge the immense support and assistance we have received from APP Haryana. So commemorate this, would I like to request Dr. Pooja ma'am to appreciate the organizing team of APP Haryana. Ma'am, please welcome on stage. Person who has just left, I think, Dr. Santosh, organizing chairperson. Sir, please come on the stage. Dr. Prashant Gupta, Organizing Secretary and Treasurer, APP Haryana.
Sir, please stay back for the last group photograph. Yeah, please, sir. And we are really grateful for your support for the whole team. Thank you so
A
much, sir.
backbone of APP Haryana.
Yeah.
Dr. Yudhveer, Organizing Secretary, APP Haryana.
I hope the youngest member and the most enthusiastic one.
Dr. Saurabh, Joint Organizing Secretary, and Dr. Sonam Sharma, Joint Organizing Secretary, APP Haryana.
Just stay here for a last photograph together. Yeah.
Now the dedicated organizing team of SHKM has left no stone unturned in making this conference a huge success. Now I welcome Dr. Sunita Singh ma'am on stage to appreciate the effort of organizing SHKM team. Ma'am, please welcome. Ma'am will present a token of appreciation to Dr. Pooja ma'am, organizing chairperson, SHKM. Dr. Sheetal Gole ma'am, organizing secretary, SHKM. Dr. Bhavna ma'am, joint organizing secretary, SHKM. Dr. Shilpa Garg ma'am, joint organizing secretary, SHKM. डॉक्टर सेन पूजा मैम अपने पीजीज को दे देंगी. ये बोल देते. Now I welcome Dr. Rajiv Sen sir, Treasurer APP, to come on the stage and appreciates the effort of organizing team of SHKM.
Thank you very much. I want to thank APP Haryana and also the Department of Pathology, SHKM, to carry the baton forward. Thank you so much.
Thank you. Please call on stage Dr. Sonia Hasija ma'am, Organizing Committee Member, SHKM. Dr. Ashok Sangria sir, Treasurer, SHKM. Dr. Shilpa Bairwa ma'am, Organizing Committee Member, SHKM. Dr. Sapna Singla ma'am, Organizing Committee Member, SHKM. Dr. Shilpa. Now invite Dr. Prashant. Please come on the stage. Dr. Prashant to come on the stage and have a
photograph कराएंगे सबके साथ एक बारी last में. So stay back.
Dr. Monica Surohi, Organizing Committee Member, SHKM. Dr. Rachit Batra. Dr. Rachit Batra.
हॉल में कोई है? हॉल में कोई है? Yes, thank you so much. We also need appreciation sometime. Please, thank you.
I would like to take privilege to appreciate the efforts made by our main strength and supporting pillars of the department who have been running day and then to make this conference a grand success. Our postgraduate students. I invite respected Dr. Pooja ma'am to appreciate our PG students. Dr. Vara Lakshmi, Dr. Vaibhav, Dr. Kiran, Dr. Tanya, Dr. Reshmita and Dr. Vijay. Without their hard work, it won't be possible to make this conference a big success.
इनकी फोटोग्राफ होने दी फिर स्टूडेंट्स को बोल देना. Okay.
Let's have a group photograph of all the organizing members of IAPM Haryana and APP Haryana. SHKM Haryana. वो बाद में उनके लिए देंगे. See.
Meanwhile, we are having a photograph. We request all the volunteers to please come backstage because we are going to felicitate you in the last. Please come forward. Gather.